Ama முடிஞ்சுதா அம்மா?
Hello, 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 hello. Hello, hello, hello. Good morning, everyone. Morning, Ramesh. Morning, Ramesh.
Hi,
Morning,
Naren.
morning, Professor Unterberg. Good morning. How are you, sir? Very well, thank you.
Since I will be lecturing later,
Yes.
I think I'll put off my video and the audio and come back at 1:30 German time, which
Sure.
is 12:30 London time.
Brilliant. That's
That's
brilliant.
okay?
Thank you very much, sir. Thank you. Look
Okay.
forward to it.
See you later.
Cheers. See you later. Bye for now. Choose. Good morning, Ramesh.
Good morning. Good morning.
How are you?
I'm fine. I'm fine. I was worried to get the time wrong.
Same here. Same here. Morning, Miguel. Good. I'll just go and send an email announcement so everyone gets the start. Thank you.
Okay. Maybe you can hear me now.
Oh, very well. Thanks, Miguel. Good morning. Morning, Miguel.
Good morning.
Ramesh is there with you? Excellent. Thank you very much. Morning, everyone.
Light.
I'll quickly go and I'm just going to go and send an announcement. So
Naren,
yeah.
the order I gathered, you will make the welcome and introduction, right?
Yeah.
And then just let me know you want to. I can be with you, and you can do everything. Just let me know the way I can help.
Okay. Thank you very much, Miguel. If it is okay, if you can pretty much run the session, I will just be on the side, and I might just pull people to give comments if I can see what people. I'll introduce Ramesh. I know him very well, and he's a pivotal figure in Britain who has abandoned Britain before Brexit, and then. But if you can run the session, that will be fantastic. Is that okay, Miguel?
Great.
Thanks.
Excellent. I'm really willing to do whatever You think it's okay? And you want the discussion at the end or after every topic?
At the end, please. I've given quite a good time for 10 minutes of presentation and 5 minutes of discussion. So we can
At the end.
at the end of each talk. So people have
Okay.
for Professor Kyrillos, it's 45 minutes, including questions, and so there's plenty of time for each
Right.
person.
Right. Right. Okay.
Is that okay?
So I will make the introduction for every talk, and after that we open discussion for about 5 minutes.
Yeah.
And topic by topic. Okay. And at the end, if you want, you can close the session if you agree.
Yes. Yes, please.
Okay.
Thanks. Sorry,
Excellent.
something went wrong.
I have another webinar at the same time, but I didn't have any active participation. It was on laser ablation. I'm very much interested on that.
Sure.
But insofar as you call me, I will make the decision of being with you.
Thank you very much. Thank you very much.
By the way, Naren,
Yeah.
I didn't manage. I couldn't manage to see the program of Sunday. Excuse me, I have some urgent call.
Okay, no problem.
Dígame. Vale. Vale, bueno. Vale, perfecto. Fantástico, muchísimas gracias. Gracias. Hasta ahora. Excuse me, because I'm preparing some material for some pituitary operation on Monday at the pediatric facility.
Oh, nice.
So, sorry, I was saying that I couldn't manage to see the program for Sunday.
Okay, I'll email to you. It's now on the line, but I'll just send this email and then.
Well, because I see the program on Friday for today, but I couldn't see the program for
Saturday and Sunday.
Maybe some other people had the same problem.
Okay, I'll get that one. No problem.
Yo ahora en webinar en informática, punto. ¿Dónde está Miguel Domínguez? Signo de interrogación. Le he enviado WhatsApp y no me contesta. Lupe está con la histeria tradicional. ¿Cuánto dura la intervención? ¿Toma, Miguel? Signo de interrogación. Guadalupe, me dice Miguel que el martes le resulta imposible. Punto. La cirugía es de 1 hora. Punto. No se puede hacer en uno de los quirófanos de abajo, de forma excepcional, pidiéndole el favor al equipo de guardia, etcétera, sin una interrogación. Esto se resuelve así en el 99% de los hospitales.
Good. Ramesh, do you want to check the sharing, and then we can take it out for a second? But
Okay.
I'll just make you.
Shall I press? Or?
Yeah, so you can now try to share. Thanks. Oh, that's brilliant. That's excellent. So, excellent. That's brilliant. Excellent. Thank you very much, Ramesh. The Zoom has this new feature now that what you call you have to admit everyone into the room rather than them automatically coming. So that's Professor Goel, I see you, sir. Good morning. Morning, Lay.
Naren, you can hear me?
Yes, I can hear you, sir. How are you?
Very well, very well. I'm going to join very soon. Just give me a
Excellent.
few minutes.
Thank you,
I want
sir.
to enjoy your program.
Thank you
And I
very much.
wish you all the best. I know you have worked very hard. And you
Thanks.
have, this is a very important show for every one of us.
Yes.
More particularly for you and for your team. And my best wishes. Naren.
Thank you, sir. Thank you very much. Most grateful. Good morning, everyone. It's now 8:30. Welcome to the first World Neurosurgery Webinar Conference. This is a exciting moment, and we are going to have a fantastic series of lectures and presentations. This is also a brave new world. We are going into the world of internet to run a whole conference. As with anything, what you call as neurosurgeons, we have to be brave and take with cautious steps, but still be brave and go and make the most of the technology that it has to offer, as we are now living in 2020 and going to 2021 soon. So in 15 minutes, I'll introduce Professor Ramesh Kirilos, and the session will be chaired by Professor Miguel Arath. It's an honor to have him here to take the proceedings through. So please feel free to chat among the chat on the chat box while we start in 15 minutes with the proceedings. And it's really great to have everyone from all parts of the world. And I think this is the future. Look forward to it. Morning, Noor. You okay?
Hi, sir. Good morning. I'm doing great. Thank you so much. It's a huge honor to be here.
Pleasure. You're very welcome. You're very welcome.
Thanks a lot, sir.
Ramesh, how is the weather in Singapore? Hot and sunny?
It's the same temperature the whole year. In the morning, 28 at night. Never think.
I take it the weatherman doesn't have a job, isn't
You have to come to Malaga.
Oh,
We have
yes.
a beautiful weather here.
Yeah, I remember.
So, Rames, is raining there?
No, not really. It rains every now and then, heavily, and then it will stop. But today it's okay. I didn't see any rain. I was in the hospital most of the time. But now it's 4:30.
Just be
p.m.
back in a second.
¿Qué te he hecho? Tú sabrás. Dímelo. Pues no. ¿Qué te he hecho? Tú sabrás. Dímelo. Pues no. ¿Qué te he hecho? Tú sabrás. Dímelo. Pues no. ¿Qué te he hecho? Tú sabrás. Dímelo. Pues no.
So, Miguel, after Professor Kyrillos, we have got Professor Nimrod Muangombi from Kenya on epidemiology of spinal bifida in Kenya. Then Professor Dubaknath Srinivas from NIMHAS Bangalore on lesioning for tremor. Then Dr. Noor Ul Huda Maria from Pakistan on robotics and spine. And then we have endoscopic surgery for craniosynostosis, again from Dr. Noor Ul Huda Maria. So Dr. Noor Ul Huda Maria is here. And let's see. Professor Duara Kanath is here as well. Great. I'm sure Prof. Nimrod will join soon. Great. Excellent. So we have got 5 minutes. So I have transmitted the meeting on the YouTube live and told the Facebook about it. So it should be there. Great. Let me just check. Good. We are live. Good. Morning, Dr. Larionov. It's coming from the Russian Federation. Good. Professor Nimrod is here. Good. I suppose, Miguel, you being in Malaga, you are the only one who doesn't need to go on holidays. Is that right? You don't need to, you don't miss holidays, whereas we guys are all missing holidays.
This is true. We feel truly fortunate because we are living where many people is much, willing to come to spend some period for holidays. And this is actually, you know that because you came several times and you have to come back. And you know that this something like a paradise. The weather is very nice. We are very well connected with the airport, international airport. And at the hospital, we have a big catchment area, busy practice.
Yes, Professor.
So we are
next time we go together to Malaga.
Yes, we have to. We have to.
I've already, Miguel has already promised to invite us.
Oh, it's
well. Be sure that you will come as visiting professor. Insofar, and this is true. This is my commitment. Insofar as the pandemic is over, you are going to come.
Yeah.
Naren came.
Yeah, I have went several times. It's gorgeous. Absolutely gorgeous. Even the air is absolutely beautiful.
And Atul, I went many times to Mumbai. I know very well the way, so it's very easy to come. You have thousands of flights every day to come.
So I am waiting for pandemic to go, and then I come. And we will invite Naren also.
Yes.
It's Ramesh, you remember the days in Malaga we spent?
Never forget.
We had that coffee with three of us, didn't we? After that first day.
Yes.
Great one. Great one.
Yes.
Excellent.
I'm looking for the picture. I think I have the picture here. Let me see.
Morning, Tatiana. You are in the bus or something like that? Good. So we have got 2 minutes. What we will do is once the meeting starts, if you only keep the video for the speaker, moderator, and I will come in and out so that the bandwidth is not high. So that way people from countries which might not have a very strong internet, they still don't have interruptions in their connection. So that's my only small request. And then when we come to questions, we can put it back on again. And for each talks, we have given good time for questions. So please have a handbook by your side and write any questions. And you can put the questions on the chat box. And time permitting, if I can pick you out, then I'll also put you on the microphone as well. So you feel that you are part of it. Good. So good morning again. So we are now 8:45, time to start the proceedings. Welcome to everyone. This is a absolutely exciting time, and to be able to communicate with so many around the world through the webinar, and to have such eminent figures giving us talk and such excellent talks to come. So without further ado, I want to introduce Professor Ramesh Kyrillos. Professor Ramesh Kyrillos is now in Singapore, but I had the privilege and pleasure knowing him when he was in the UK. He had trained in many highly regarded departments in Atkinson Mole, in Liverpool, Leeds, but he was in Cambridge, where he made a pivotal role, not in vascular neurosurgery for Britain, but also in terms of neurosurgery trainee, neurosurgery resident training. He's transformed the whole the landscape of British neurosurgery training. Pretty much any courses that came up was inspired by him. He was very good at bringing his residents into doing courses, and he helped with the neurosurgery research listservs, international neurosurgery course. But he was amazing. I mean, I was in Cambridge just before him, and I went after he came, and the atmosphere in Cambridge when he was there with the residents was fabulous. And I'm sure he's doing great things for not only clinical neurosurgery, but education in South Asia, as well as continuing to do it in the world. So welcome, Professor Kyrillos. I shall, if you would please share your screen. Thank you, sir.
Thank you very much, Naren. I have to say, friendship is priceless. This is all I can say for what we had together over the years. I tried to cover as much as possible in this period of time about AVM surgery. First, I will thank, of course, the late Professor Roten. I'm using some of his anatomical slides. I will just give a short introduction for selection of surgery. Most of it you can read in books, but I will just put like a summary for it. And then we will go and cover surgery, mainly for anatomical planning. And then at the end, the short time for what interests a lot of trainees, what to do with timing of intervention when you are faced with an AVM with an acute intracerebral hematoma. So first, how we select surgery, you can find it in books, and we all know that the main reason and the indications will be to eliminate the risk of hemorrhage. You can add control of epilepsy, but really it is the elimination of the risk of hemorrhage. And there are steps in any management. First, you have to decide whether to treat them or not at all, and then to choose the treatment. Because it's all or none, except for few cases of the rare steel, you either remove the AVM completely or not treat it at all. So the decision making depends on, you have to estimate the risk of hemorrhage, morbidity of each, but also to have the ability to predict whether your treatment be successful before you started, and don't underestimate the morbidity of your surgery. You all know that, and not only that the risk of annual risk of hemorrhage is between 2 to 4%, it rises to 6% in the first year or two after presenting with hemorrhage. But you have to know that each hemorrhage is not like aneurysmal hemorrhage. The mortality is lower 10%, and the morbidity depends on the location. So you have to beat this natural history. So your mortality and morbidity of surgery has to be less than your natural history. And these are the factors that we know clinically increases the risk of hemorrhage. Of course, if you have a previous hemorrhage, then especially in the first 2 years, it is quite high, a cerebellar location, and increased venous pressure. I put pregnancy in between brackets because most of the studies showed that it is similar to any other interval and not really particularly related to the stages of labor or the second trimester was the flow was high. This was all studies. But for anatomy, these are the architecture reasons for hemorrhage. And in fact, they are interrelated, and contrary to what you think, the arterial pressure may not be high in the feeders because it's a dilated system. And Professor Michael Morgan have shown elegant studies that the pressure may not be high, but it will be high in the venous side. And it was said that small AVMs have a high risk of hemorrhage, but this is not because of the size per se, because you will have less number of venous drainage and the venous pressure will be high. Of course, intranidal and related aneurysm increases, and the reason why deep location have a higher risk probably because the number of draining vein for deep system is less than superficial. Associated aneurysms are important, and you have to know their classifications. They are mostly flow related, and they can be very rarely incidental, unrelated, but the flow related ones are in the proximal feeders or intranidal. And it's important to know when you have a hemorrhage, whether which is the source. If it is, of course, both near each other, you can treat them together, but if it is far away, you can target the treatment to the symptomatic one first. So how we select patients, this is you will find in any textbook. I don't have to read them one by one, but as a neurosurgeon, you have to look at certain factors that predict your success of treatment. And one of the most important is how diffuse or compact the nidus is. When we sit together to decide which modality, each is the complementary, and you can see the limiting factors are different in each. For microsurgery, it's really, again, diffuse nidus come, but also the eloquency and how to access it. Now, for example, the embolization, they only need to how to access the feeders, not the nidus at all. It doesn't matter where the nidus is. And for radiosurgery, we all know this limitations, and it is said that shunts within the fistula can perhaps are more radio-resistant. So for surgery, the only adjuvant modality is embolization, and it is widely used, but really we have to know, of course, there is perfect endovascular surgeons that can do miracles, but really it is used as embolization. But you have to look into that. Of course, the clever endovascular practitioner will not have this high morbidity, but it still have a high complication rate. Every time you use it, because you need multiple treatment, you're adding complication. So try not to use it unless needed, and I will discuss that later. So how is it useful for adjuvant surgery? Now, this is an example where, okay, it has embolized a lot of the nidus, may decrease a little bit of the hemorrhage, but what it has done, it is in the middle of the nidus. It is left here. Now, the onyx you use is quite rigid, and to reach the apex of the AVM, it's not compressible. In fact, this type of embolization makes it more difficult to operate on it. Now we use it greatly for associated aneurysms. So the perfect embolization, if you have two compartments, you know, if you take the deep compartments completely and embolize it and then deal with the superficial ones, then this is perfect embolization, which is rarely achieved unless in very expert hands. So now if we go to surgery itself and how we select them as a summary, so you have the Spetzler-Martin classification, and this is the most that we operate on. But we have other modalities. So the problem is they are perfect for surgery, but if they are deep, then you have a problem with the access, and you may try stereotactic radiosurgery. And when I say true eloquence is the primary motor cortex of the hand, the language white matter tracts, and the primary visual cortex. But peri-eloquent location, you can still do surgery if you keep perinidal. So if you have a hemorrhage, then you want to protect early, and there is a delay in stereotactic radiosurgery, so you will go more for surgery. Now I put here embolization because I said don't add it to Spetzler grade 1. You only use one modality if you are using, unless you are using as a curative method. But in some aspects, for example, if you really have a deep AVM that you don't want to wait for gamma knife and you have a clever endovascular surgeon, go for it. Now, grade 3 is difficult because it has subcomponents regarding the size, eloquence, and venous drainage. And most of them are not treated at all. But if you really are pushed to treat it and the size is not large, they are just grade 3 because of eloquence or deep venous drainage, then you can use stereotactic radiosurgery. And here you can use combined treatments. So there will be a role for adjuvant embolization for surgery, as I told you before, for grade 3. Now for grade 4 or 5, or this is the C is the Spetzler-Pons classification, of course, don't do anything. If you are really, really pushed for it, then you can use combined treatment. And don't forget, this is the best philosophical term: from the air hits your brain. If something is bad, you can make it much worse if you try hard enough. So don't be inclined to treat unless you are really up to it. So when we decide for surgery, we have to know what is the big task we are facing, because the goal, you have to resect the whole nidus, I said all or none, and to minimize the morbidity. And you have to know that before you start, because once you start in an AVM, there is no plan B. Really, there is no plan B. You either finish it or you are stuck. So your key here is the selection and prediction. What are you going to do? And this is a whole skill. It is not technical skill. So you have to estimate the difficulty and morbidity before you start. You know, this is really, the planning is to avoid disasters. So the magnitude, we know, we can use all these classifications. They are all excellent. Lawton adds the age and the compact degree of the nidus and so on. But again, on top of it, you have to know whether you can access or not. Some of them are in the hypothalamus or whatever. And this is what Dr. Spetzler used to say, grade 6, you know. And one of the most difficult, how to define the edges of the nidus. So never underestimate a task before you go for it. And again, what is morbidity? Morbidity is really now, the Spetzler eloquence were mainly for cortex. You have plasticity and recovery, but if you damage the white matter tract, they are permanent. And morbidity is different to different patients. You can have a completely grade 0 power in your ankle, and if you are not a footballer, you can walk. You can have grade 5 power in your hand, but it's very clumsy. You can use it for eating and all daily activities. So it's not just the degree, it's what it makes to the patients. Similarly, a lot of the deficits are visual field defects. You can go and have superior condentinopia does not affect you, a small scotoma in your lower field, and you will hit all the objects while walking. So be aware what is morbidity is. And this is the main part of the talk. What is the value of anatomical understanding? Because you need to understand the anatomy before you plan it. And the more you know is not to make your surgery incredible. In fact, the more you know, you have to make your technical surgery easy. So you're more knowledgeable, you're easy, you don't require very skillful surgeons, so that you help the whole global neurosurgeons to apply surgery when it's really indicated. And the surgery begins, you should not go and start an AVM without the day before that you know what you are going to see. There is no laparotomy and just finding what you are going to find. So these are the steps that we all know when we do surgery. So you have to predict them before you start. You know what you are going to see because you are opening a mass like that. You have to know where are the feeders are. You have to know the most difficult part is to define the nidus in complex AVMs. And don't underestimate the deep part of the dissection where you get the white matter tract. But again, don't make drama from a simple AVM. It is worse to underestimate as to overestimate a simple AVM. For this one, you just go around it and remove it. And this must be the vast majority of the AVMs you do. So how do we decipher what looks like a very chaotic and complex lesion? You have to understand what is an AVM. An AVM is a malformation of the capillary bed. That means every artery, every vein is anatomically correct. Maybe morphologically they are dilated, bizarre, but that means they are this normal arteries and veins supply the AVMs. So if you know the normal vascular anatomy, you can deal with a lot of AVMs. We know how the arteries are. They go into the cisterns, you know, the PCOMs, the MCAs, and so on, and then they enter the sulci, and then become cortical branches. And here, where most of you loses the anatomical knowledge. You don't know the cortical branches, which are very important for AVMs. They perforate the cortex to go to the subcortical matters. But what we call true so everything perforates the cortex, but and they become dilated in AVMs. But the true perforators, we mean the perforators that goes without giving a cortical branch before going to the deep structures. And of course, they extend to the ependyma. So you have to know the anatomy on the surface of the brain. The other thing that is unique to the brain is that the arteries do not have always the same vein with it. You know, like in the body, you have a femoral artery, femoral vein, axillary artery, axillary vein. Not always, but sometimes they do. And again, the venous anatomy has anatomical variation, but again, more or less, they have a sulcal. But what you don't know, that there is a lot of transcerebral veins in the cortex. You don't see them normally, but they are there. They are anatomically present. So how do you, what is the importance to know where the arteries is to locate the edges of the nidus? So when you look at the MRI scan, this is the MRI scan are very good for that and make an estimation of the white matter tracts. Naren, this is from Aberdeen. This is the first MRI used in humans ever. I took the photo myself from Aberdeen Royal Infirmary. And but the AVMs does not, the MRI does not predict everything. You see some flow voids, but you don't know the exact anatomy, and you don't know a lot of the dynamics. So you rely on an angiograms. And if you read here, this is what the radiologist will report to you. Very good to see all this stuff here that you can read it. But as a surgeon, you read the angiograms in a way that plan your surgery. You have to know where is the feeders, which sulcus you will find each arterial feeder. There are compartments. So you look at the angiogram in a way that you are planning your surgery. And what you do with it, you form in your mind a sphere, which is AVMs, with the different poles, and knowing where the artery vein is not just to have proximal control. It is to tell you where is the edge of the nidus. It's never clean like that. And the other thing that a pitfall, this is not a hemangioblastoma or a vascular tumor. There is no blind ends. In fact, every part of the AVM has tiny feeders here. Controlling this feeder is easy, but here is very tricky and important. So don't treat an AVM even if it was embolized as a tumor. So when you look at the MRI scan, if you know the anatomy, you know that this area is fed by the prefrontal branches or the pre-prolandic branch of the MCA, and it's draining to the sagittal sinus because you know the normal anatomy. And in fact, if you look at the angiogram, you can predict where the nidus is without even an MRI scan. And this is the anatomical skills that you require. But this is what is very important, is once you go deep in the sulci below the U fibers, you encounter all this that the glioma surgeons know. And the deficits from white matter tract affections is permanent. So this is, you can read it. This is the angiographic anatomy that you ignore. So the MCA branch, which is, you all know them, the M1, M2, I'm not going through them. Then M3 when it comes from the Sylvian fissure, the opercular branches. So this is the operculum of the Sylvian fissure. And then it gives the cortical branches. You have one here, the lateral orbiter, and then if you have an AVM, we'll have all these prefrontal branches, but then there will be three vessels. One goes into the precentral sulcus, the prerolandics, the central sulcus, and the postcentral sulcus, which will be the anterior parietal, and they all come from the superior part of the M2. The lower trunk will supply the rest of the parietal lobe, so you'll have posterior parietal, you know, the opercular branch is here, so it will give to the superior parietal lobule and also to the angular gyrus, whose angular gyrus, as you know, is around the end of the superior temporal sulcus here. And then the temporal lobe lateral surface will have a posterior and anterior temporal and a polar one. So you have to know where they are so that you can follow them to the nidus. On the medial part of the frontal lobe, as you can see, you have the fronto-orbital, fronto-polar, and then you have the after the A2, the A3s, A4, and A5, and it ends in the callosomarginal will end in the cingulate sulcus. The posterior cerebral is more important to know, because if you look at an angiogram, you have to know what is what. This is an AP. So the P1 is in the interpeduncular systems, is here. The P2 around here is in the cisterna ambiens, so you know where it is. Then if you look here, you have a wasting. This wasting corresponds when the posterior cerebral goes on the tentorial notch, supratentorially, and ends into two branches. One in the calcarine fissure and the other one in the parieto-occipital sulcus. So this is the branches, and you can tell where they are. But what is important, you don't see them from the M2, that it feeds the temporal, the tentorial part of the temporal lobe, and this is a very common location for AVMs. So if you have the frontal lobe, we can divide it into lateral, medial, and orbital surface. And I'm not going to read it for you, but you can imagine if you have a location of a nidus, you can predict which branch will take you to it. And what you know, you can get the branch from its origin and follow it until it takes you to the edge of the nidus. It is not to find it just for control, but to find the nidus. So these are some examples. This AVM here is fed by a prefrontal branch. When you do an angiogram, because of the shunting, the other branches do not fill, which is a difficulty in interpretation. But you know that this is a prefrontal AVM. You know, and then look here. These are the curved part of the middle cerebral. This is the opercular branches because they are coming over the Sylvian fissure. So you know, you estimate the distance between them. If the AVM is here, then it's in the inferior frontal gyrus. This is in the middle, and here it is in the middle. But if it goes deep beyond the U fibers, what you can encounter here is the superior longitudinal fasciculus, and you can have deficit from it. And then the venous arrangement will go to the superior sagittal sinus. Again, this is a similar one, but it's more posterior. So this is the rolandic part. This is the opercular part. So you know this is in the motor area, but it's in the face motor area, which is bilaterally represented. So the patient may not have a deficit if you have a cortical injury, but of course you have to be careful for the en passant vessels supplying the rest of the tracts. And if you go deep, not only you will damage the motor cortex, you will damage the corona radiata and the white matter tract, which will not have plasticity and will be permanent hemiplegia. This one is an opercular one, and the reason is on the left side. So this is what used to know as Broca's area for speech, but we know from our glioma surgeon it does not exist as such. And the problem with this AVM is not damaging the original Broca's area, but its deep extension can go and damage the arcuate fasciculus. This is how you get a speech problem from such an AVM. I know it is opercular because, again, these are the M3 branches. It is very typical appearance on the angiogram. So looking at that without an MRI at all, I know where is it. On the medial surface, similarly, there is no time to go in details, but you know that this one will be related to the supplementary motor area. And if it's on the left, the patient may have a transient mutism and hemiparesis. The temporal lobe, again, I won't read the whole table. I'll just leave it for a while that you can look at it and know where the location is for each AVM. And this is the example. This one will be just the lower trunk of the M2. The vein is going to the transverse sinus. So you know this AVM is that's why they are C-shaped, because they are opercular. They are coming over the temporal operculum. And then the branch, posterior temporal branch, will be this one, cortical branch. And this is the vein. So you know, but if you go deep, you may hit the optic radiation. This is to show you again, this is an AVM that is really fed by on the tentorial surface of the temporal lobe, because this is, I told you this is the P2, and this is the temporal branch is very dilated. Normally you don't see it. So this will be, in fact, coming the P2 in the system ambient, and this is really the branch, and this is the location of the AVM. This is a similar one. And again, this is a more tricky one. It's in the parahippocampal gyrus, which is lying here, again from the P2, and it's adjacent to the hippocampus. And I know it is draining to the vein of Rosenthal because from the cortical choroidal fissure, it goes back to the vein of Rosenthal. Of course, I'm rushing it a bit because of the time. Again, similarly here, the parietal lobe. And if you look at this one, this is really in the inferior parietal lobule, angular gyrus. And the difficulty of this one on the left, that you can take the deep part of the arcuate fasciculus and have language problems. On the medial hemisphere, in the paracentral lobule, you have blood supply coming from the distal part of the pericallosal and anterior cerebral, and also from the parieto-occipital branch of the basilar, and this supplies the leg area in the paracentral lobule, while this one is supplying the distal part of the posterior cerebral, which goes into the calcarine fissure. So this is the AVM of the primary visual cortex. Now, cerebellar AVMs are important because almost 23% of my first AVMs were all cerebellar. It's a common part we treat, and these are the cerebellar surfaces. And this is the arrangement, the arterial arrangement. You have a suboccipital surface, which we all expose. And contrary to what you're saying, the pica does not supply the major blood supply. It does supply the tonsils and a lot of the vermis up to the top. But most of the supply comes from the superior cerebellar artery, which supplies the whole tentorial surface and part of the suboccipital. Now, the petrosal area is very small. It's related to the CP angle, and it's mainly coming from the ICA. The lower part of the tonsil comes from the pica. Now, this is an example that the veins do not follow the arteries. All the veins more or less goes on the top. So you have a median group. They go towards the straight sinus, not really directly, but through the tentorium and then the straight sinus, and more deeply anteriorly to the galenic system. While the paramedian ones, they go towards the transverse sinus and some to the sigmoid, while the lateral surface goes to the petrosal vein, which is the petrosal vein of Dundee. But beware that the petrosal vein may be draining pontine vein. So when you obliterate it, if you can obliterate it near to the AVM rather than the whole petrosal vein, even if it looks arterialized. So this is an example of a petrosal AVM, and you can see the ICA branches near the 7 and 8 nerves. And this is the surgery. So this is a suboccipital craniotomy. The head is here, the feet is down, this is lateral. This is the tentorium surface, petrous bone, this is the tentorial vein, and this is the cerebellum. And if we dissect the nidus from the superior and petrosal surface, you start to find the 7 and 8 in the IM. Here is your jugular nerves. This is hypoglossal, and you can see the feeding artery coming deep from the ICA. So once you dissect it and find it from its origin, then you can isolate it and try to put a temporary clip on it to see whether it's en passant or not. And then go on the top. This is the top of the nidus, and identify this is the fourth nerve, superior cerebellar. So this AVM is adjacent to the middle cerebellar peduncle. And here dissecting the nidus from the superior middle cerebellar peduncle. Dissecting it, it is stuck to the origin of the 7 and 8. Dissected more, and then you dissected of the pica origin itself. So it's all about anatomy. Now deep, you will find the fifth nerve. So we have now dissected most of the nidus circumferentially, but it's still attached here. Then you know that this artery is the end artery, so you cut it. And then you go and find the edge of the nidus from the white matter tract, and be careful not to damage the rest of the pica. This is, of course, it's blood because AVMs bleed. So now we know the anatomy. So this is the pica. This is the pre-meatal part going to the meatus. This is the post-meatal part going down. And this is only one branch that was coming. So the post-meatal was continuing there. This is the nidus being removed at the end. We use the nerve stimulator, and we make sure that the post-meatal part of the ICA is intact. And then we put the Surgicel, and the operation is done. So, how do we avoid morbidity for AVMs? Planning is important. I told you not to under or overestimate it, but make sure you don't cause more morbidity. And the morbidity really comes for finding the parenchyma around it. And the key to find the white matter tract that you have a wide sulcal dissection, arachnoid dissection in the beginning, because once you open the sulci, you know at its depths you have the U fibers, and deeper to the U fibers you find the white matter tract. This is, of course, a preparation anatomy. When you do surgery, you don't find that. You find some white mash there. You cannot know what is what. But to localize it, you know that once you come deep to the sulci, you are near the white matter tract, and you have to be really near the nidus. So when you follow the arteries, you make sure that they will take you to the vessels. You don't damage the nerves, the veins first. Make sure that they are ending in the nidus, because some of them are continuous, and you can be deceived. Like this AVMs, another AVM on the splenium. Some of the compartment is coming from the anterior cerebral, some from the posterior cerebral, so there are compartments. And then you try to find the arteries and takes you to the edge of the nidus, as I told you before, even if the nidus is small. And it will really guide you, because the most difficult part is to define the margin of the nidus. When you have and all the nidus goes subcortical in this shape. So first you go from the cortex and you go tangentially here, not go through the nidus itself. It's like an ice cream. And once you come to the edge here, you need to go to the nose of the cone. Either you go circumferentially or deep, because usually this will be pointing to the ventricle. And these are the most difficult feeders to go. Most people will go around them. Professor Michael Morgan will go in one place, find the difficult ones, and then goes the other way around. But this is the dissection, but it is easy said than done, because you don't know how difficult, because the perinidal zone is. A lot of the AVMs can be compact like that, and they are really beautiful to remove, and we can have beautiful videos for it. But for these ones, you don't know what is perinidal vessels or not. So the perinidal zone is variable. It's an area around the nidus. It contains perinidal vessels. How far you go around the nidus depends. If it is near white matter tracts, you have to be really, really near the nidus. If it is not, take a bigger margin, because even the arteries around the AVM do not remodel for a few days, and they can be a source of hemorrhage. So it may not be elegant to resect more than you need, but it's physiologically better to do that. And we have done this study with Professor Margaret Morgan in Cambridge before. But once the edge comes near and disrupts the white matter tract, and it is really, really near eloquent areas, then your dissection has to be very much near the nidus. So you can use it for your advantage. That's why cases that have a previous hemorrhage, you have a good gliotic plane around it. And in fact, they are easier to resect than elective AVMs that has never hemorrhaged, because they have less of a gliotic plane. So this is an example of an AVM and how we do it. This is again a simple one. So all the steps of surgery is you identify the vessels, the veins, and then the last thing, a resection of the nidus. And you can see here, maybe the initial dissection needs some microsurgical skill, but you are not using your skill anywhere. It is really related to knowledge and patience. So if you have this AVM, this is the terional or frontotemporal craniotomy for the temporal AVM. This is the Sylvian fissure. The head is here, the feet is down. This is the temporal lobe, frontal lobe. We open the Sylvian fissure because we know the vessels are coming from there. This AVM is draining to the transverse sinus, and the Sylvian veins are not involved. They look arterialized, but they are not involved, and you try to preserve them. So we open the Sylvian fissure widely, find all the vessels. I tend not to put videos. It's easy to follow stills like that. Then find the venous drainage at the edges, because we need to find exactly where's the edges of the nidus. They are all bizarre feeders. They are all dilated. They are coming from the M2, proximal M2 branches of the middle cerebral, and some from the M1 because it's going towards the temporal lobe, the temporal pole. And then we go around the nidus. So we have made a corticotomy here in the temporal pole, and we already have the temporary clip on the feeders coming from the Sylvian fissure. And then here you see it is non-eloquent. So you go wide in the white matter tract. I don't need to encounter all these vessels, but you have to be meticulous. Divide them one by one and go around it as here. So you have the nidus being dissected, still arterialized, still not disconnected. Then disconnect the one that has the vein behind the Sylvian vein. Cut it. Again, this is blood because they bleed. And go around the nidus. Again, wide white matter dissection. And then you go down to the tentorial surface in the middle fossa. And again, continue. As you can see, the vein starts to become blue, but so we know that it has been disconnected. And then you have the nidus disconnected like that. And then we pull it out, remove it. And then we preserve the Sylvian veins, and they are all blue again and functional, and put your surgery cell. So again, the whole key is to find the edge of the nidus, use wide dissection of the sulci to find your white matter tract, and know that deep AVMs that have perforators here, that means that the AVM goes through the white matter tract like this one, going through the corona radiata, and really try not to disrupt them. This is an insular one. We don't have time for that. So salamic ones have a distinct appearance. I show that so that you don't operate on them unless you are really like Dr. Spetzler. And finally, in the last 3 or 5 minutes, what to do with surgery and the timing when you have a hematoma. This is what you face on your on-call. You have this hematoma, and you have 2 situations. You have patients who have really, really high ICP, and don't do anything if there is an AVM based on a CTA. If you don't have an angiogram, don't do anything. So you either evacuate the hematoma only, and then do the angiogram and deal with it later. But if you have an angiogram and the AVM is very small, do it at the same time. and you're really concerned and you don't want to touch anything because people tell you once you get the hematoma, they bleed. They only do that if you disrupt the veins. But if you're really scared, just do your decompressive craniectomy. But please put your decompressive craniectomy where you will tackle the AVM later. This is not trauma. You don't just do a trauma decompressive craniectomy while the hematoma is somewhere else. But if they are stable, you can, most people will wait until the hematoma completely go and deal with it electively. This is the classic teaching. Sorry, I cannot go back because people were concerned. Yeah, I don't know the, oh, it jumped on its own, sorry. But anyway, if you have a hematoma and it become liquefied, then make use of it, because in 10 days, 2 weeks, it become liquid. It has already dissected the deep white matter tract, and it will convert an easy and a difficult AVM into easy, and use the hematoma as a cavity to take you to the angiogram, to the AVM. It can even locate to you a cerebellar AVM, just because the slides push what I mean. You have a window of opportunity. You have a hematoma there around some selected AVMs, and it can facilitate your resection, because it's either the cavity takes you to a deep AVM, or it dissected deep to it. I have used that in 89 cases out of 182 with hemorrhage, and you can see some of them were really grade 3 and 4, not because I'm skillful, but the hematoma made it quite easy. But don't do it without an angiogram, because some of them are dural fistula. Dural fistula, you cannot differentiate without an angiogram. If you see some veins and you disrupt them wrongly, then you will have a problem. So in conclusion, I have went very quickly as I can through the selection of surgery and really how to use anatomical planning, and don't underestimate the knowledge of white matter tract. So the takeaway message that you have to have, there is no role for intracranial laparotomy. You have to have it in your head before you do your craniotomy. Knowing the vascular anatomy is very important, even if you're not a vascular surgeon, because all these cortical branches are involved with metastasis, gliomas, and so on. And if you know the normal anatomy, you can recognize the arteries and vein. You dissect them, not just to control them, but the veins will guide you to the AVM, but leave them intact till the end. But the feeders, you use them to track them to outline the margins of the nidus, which is very difficult in difficult AVMs. And knowing the normal anatomy, plus the distinct pathology on the angiogram, some of them are tortuous, will help you in your planning. Again, don't overestimate small ones. Cerebellar ones, I show you, I do easy ones. You just go in the cerebellum and remove it. Don't make a drama out of it. But don't subspecialize your knowledge, because you're a vascular surgeon. You should know all the white matter tracts as well as a low-grade glioma surgeon. So in conclusion, there is no plan B. Avoid a lost battle. Don't take a case beyond your skills. Don't use, for example, embolization. Use it for really for a good reason. And your planning and anatomical 3D vision is the key. And again, you have to make your procedure simple by knowledge. And again, I cannot overemphasize that. And thank you very much. And most importantly, this one. Thank you, Naren. Thank you.
Thank you. Thank you very much, Professor Kyrillos, for that fantastic lecture, making it so clear, a very complex subject. I'm now going to introduce Professor Miguel Ares. He's going to chair this session. It's a real honor to have Professor Ares among us and to chair this session. He's the professor and chairman of the Department of Neurosurgery in Malaga, and he's also the chairman of the WFNS Foundation, past president of the Spanish Neurosurgery Society, eminent surgeon and a great educator and inspirer. I have been to his department. The way his residents are around him is really, really inspiring. Professor Ares, could you please chair this session, and thank you, sir.
Thank you very much, dear Naren. First of all, thank you for giving me the opportunity to take part of this wonderful international symposium. And I've been very happy listening to the talk of Professor Ramesh Kirolos. May I share my screen for a short while, Naren?
Sure.
Just
yes, absolutely.
one second.
I'll just put it, sorry, Miguel. Yep, you should be able to share it now, Miguel.
Thank you. This is just to show this very nice picture taken in Malaga, maybe almost 3 years ago or something like that. That gives me very nice memories. I think this is all I wanted to show regarding Dr. Kirolos and regarding Naren. So thank you for giving me the opportunity to share this session, and I'm very happy and honored to ask the first speaker, that is Dr. Nimron Bangwombe, who is from Kenya and is the president of the Pan-African Neurosurgical Society. We met maybe 2 years ago in Kenya, and it's a great pleasure to ask him to start his presentation. The title is One-Year Prospective Study on the Epidemiology of Spina bifida cystica at the Kenyatta Hospital. Professor Bangwombe, whenever you like.
Thank you very much, Professor Arais. I don't know whether you can I share my screen?
You should be able to. Just let me
just, okay. Okay. Can you see my presentation?
Not yet. Do you have while we take the Professor Mua Gobi's lecture, any questions for Professor Kirolos? Miguel, do you have any questions for Professor Kirolos while we get this?
Yes, I have one question. I have many, but just one. What is your real scenario in your hospital regarding the multidisciplinary approach of the ABM? That is conceptually okay. We all gather that endovascular, radiosurgery, and microsurgery could be combined. But one of the issues that has been losing ground to my mind has been the combination of endovascular procedure and radiosurgery, that I don't think is really useful, and on the contrary, sometimes could be worse for the patient. What is your opinion about that?
Yeah, I can talk about Cambridge, where we used to meet with the radiologists, and really we will try to avoid embolization unless really necessary, because we are adding complication. The problem, we used to send the patient for gamma knife elsewhere, and they don't. It was obvious that the results of gamma knife is inferior on the ones that have been embolized before. First, because the part that is embolized does not get a dose of radiation. They find it more difficult to define it, and they have worse results. But we did not have means every time to do it in the same gathering. So we used to have correspondence with them separately, but towards the end, we will not perform any embolization unless it has a particular goal. Of course, there are some that are totally therapeutic and curative, but we don't use them with surgery unless really needed, and we don't use them before gamma knife, before we consult the gamma knife practitioners themselves.
Professor,
thank you very much.
Professor Kirolos, I've got a question for you. I see many residents here who are keen on vascular neurosurgery. I know them personally, and their question is that in the current climate, how do you go from a resident to a AVM surgeon with the many surgeons not so reluctant to give the cases of complex cases when there are not many cases for themselves. And what do you say to that, and particularly with this coronavirus as well? Thanks.
Okay, so in the beginning, I had some difficult AVMs. Now I don't have difficult AVMs because I learned that I don't know how to do difficult AVMs. The AVMs that we operate on them are really, really the simple ones. And don't overestimate them because you will deny a lot of patient surgery. So if you want the AVM surgery, once you know the anatomy, it will help you. The technical skill should be simple. You don't need so much technical skill unless you are tackling something beyond your control. And then you can go stepwise and do the moderate ones. The people who used to do the special grade 4 and 5, even they were good at it, they have stopped. Unless they are not seeing the patients for follow-up, this is something different. But once you see the patient for follow-up and the morbidity, you will not do a difficult AVM.
Thank you. Just a quick question. I know you used to have an excellent fellowship in Cambridge. Are you having any fellowship in Singapore for the residents who are interested?
In Singapore, the institute has a lot of separate departments and hospitals, so it is not concentrated in one hospital. We do cover as consultants to go from one to the other, but maybe the numbers we will welcome, but I'm here, I can ask my superiors here. I'm a visitor to Singapore, but we will welcome such people, but the volume, again, I'm not sure will support more than our own residents.
Thank you very much. Thank you. Professor Aras, I'm giving back to you, Professor Muagombe. Thank you very much. I think we can see all your presentation.
Okay, thank you very much. I think Professor Rice, thank you very much for the introduction. Now, I want to present the results of work done by my resident, a former resident who is now a neurosurgeon, Dr. Njiru. This was for his master's thesis, and that is on, about almost 8 years ago now, but we haven't published it elsewhere. The other names there are my co-authors who are also co-supervisors. Now, the outline of my presentation will be as shown there, and I'll try my best to keep to the time allocated. Now, spina bifida cystica is usually due to failure of the closure of the neural tube, and it accounts for about 4 to 10,000 live births worldwide, and prevalence is higher in some countries like China, Ireland, and Norway. We had an earlier study at Kenyatta National Hospital almost about 20 years ago, where the median age at surgery was 20 months. And at that time, we thought that the delay was due to the few number of centers which were then available in the country. So we did this study as a follow-up to see whether has the management changed and what are the patterns which we are seeing now. This will be the basis of this presentation. This is a prospective hospital-based cross-sectional observational study. All patients admitted at the Kenyatta National Hospital with spina bifida between September 2011 and August 2012 were reviewed. There was a pre-tested questionnaire which we went through. Participants were interviewed, examined, and the findings entered in the questionnaire. The data was analyzed and statistical analysis was done using the SPSS version 17.0. Results. We had 65 patients over that period, of who 40 were males and 25 were females, a male to female ratio of 1.6 to 1. So this condition in our setup tends to occur more in males than in females. The average age at conception of the mother was 25 years, with a range of between 17 and 45 years. 84% or about 85% of the mothers were married. The mean age at presentation to hospital was 9 days because they were referred cases. And the mean birth weight was 3.1 kilograms, which is in keeping with the data in our environment. The average weight at admission, which was about 2 weeks from the time of birth, had, of course, increased to 3.4 kilograms. What we observed was that almost 50% of the children were firstborns. The head circumference was taken, and 40% of the patients presented with a convex, tense anterior fontanelle, and the average head circumference was 37 centimeters, and which at that time we thought was within the 50th percentile. We looked at the risk factors which may be associated with a spina bifida cystica in our patients, and what we found is that 4.6% of the mothers had a history of alcohol consumption, which is a very low figure, in the prenatal period. 3.1 were confirmed diabetic. One mother had taken anticonvulsants. Only 18% of the mothers expressed awareness of the folic acid supplementation. And out of those 18%, only 12% had actually taken folic acid supplements, which was quite a low figure. 2 of the mothers had had children who had spina bifida cystica. And 8 of the mothers had stillbirths, which again, this can point to a history of having problems in pregnancy. We reviewed the level of education of the mothers, and 63% of the mothers had attained what we call in our country primary level of education. And 19% had reached secondary level of education, which we call high school. Now, primary level of education is free in our country, almost free at the primary level. So that's why that figure is quite high. But some people don't have funds to continue with education after that. And therefore, this tends to fall down. And as you can see, those who are not able to go to secondary education or high school education, the figure is low, about 20%. This observation was reflected in the average monthly income of the mothers, where 77% of the mothers had a monthly income of below $100, and only 5% of the mothers had an average monthly income of $400. And we are presuming that those 5% were the ones who had a higher level of education, and therefore they could get a much better form of employment and therefore supplement their incomes. We look at the cost burden of this illness to the family in terms of transport and care, in terms of transport and care, and the average was about $450 per patient over a 30-day period of follow-up. We need to note that the hospital bills in our patients usually are catered for by what we call the National Hospital Insurance Fund. So these patients are treated in the government hospitals, and the National Hospital Insurance Fund usually takes care of the bills. But there are supplemental costs which they need to, like transport, etc., which can be quite expensive. And that is what we have reflected there. We looked at the site of the lesion and other associated anomalies. 27% were in the lumbar region, 30% were in the lumbar sacral region, 20 thoracolumbar, and 13 sacral region. About 60% of the patients had also clubfoot, and about nearly 31% of the patients had associated hydrocephalus at presentation, of which, and again, another almost 11% of the patients had kyphosis. Surgery, the median age at operation was 15 days. Majority, that's about 60% of the patients, had closure of the spina bifida alone, while about 14% had closure of the spina bifida and placement of a VP shunt at a later date. About 14% had spina bifida closure and placement of the VP shunt at the same sitting. The mean time of duration of surgery was nearly an hour. Post-op complications. The complications which I'll highlight was one, surgical site infection, which was quite high. About 20% of the cases had surgical site infection. The other complication which I would like to highlight was wound dehiscence, which was nearly about 30%. And this sometimes also those skin flap necrosis. Then there were other complications which are usually seen in this surgery, like CSF leak, meningitis, and about 30% nearly of the patients developed hydrocephalus after closure of the myelomeningocele. Discussion. In Africa, spina bifida cystica seems to be more common in males than in females. This observation is also noted in this study. The explanation may be due to the patriarchal nature of the African culture. The male child is probably given priority for access to healthcare, and they're the ones we are seeing. We really don't know the reason about this. Earlier literature reports on the low incidence of spina bifida cystica in Africa. Data published by Henry and Mikkel, they reported 47 cases in 100,000 African children in Durban. That's an incidence of about 0.4 per 1,000 deliveries. And Gupta reported an incidence of 0.9 per 1,000 deliveries in Evening. This was sometimes in the 60s and 70s. And those data, which some of us still quote, were a reflection of data also around the same time in UK, where there were three children with spina bifida cystica per 1,000 live births. While early closure is the most ideal form of treatment, this is difficult in Africa because many children are brought late to hospitals. In this study, majority of the children underwent surgery when they were 2 weeks of age. This may explain the high infection rate that was seen after surgery. Low socioeconomic status is associated with an increased rate of spina bifida, probably attributable to poor diet. In this study, most of the children were firstborn, similar to the study which was published in Nigeria. 30% of the patients had hydrocephalus diagnosed through ultrasound. An earlier study at KNH had shown hydrocephalus rates of about 50%. In contrast, higher rates have been reported in Uganda, about 70%, and elsewhere. According to Asher et al., the most significant factor determining ambulation status in children with MMC is the neurological level of the lesion. In our study, the most common sites for the lesion were lumbar, nearly 30%, lumbosacral, again 30%, thoracolumbar, 20%, sacral and thoracic with 13% and 7% respectively. This was similar to what found in Uganda, where 47% of the lesions were located in lumbosacral vertebrae. Preservation of the L3 function is associated with the ability to stand erect, while L4-5 function is preserved, the ability to walk is maintained. Associated spinal cord anomalies and vertebral anomalies significantly affect the prognosis of children with spina bifida cystica. The problem is that the vertebral anomalies will eventually lead to skeletal deformities that increase the complexity of the clinical picture. Vertebral anomalies also develop in up to about 60% of the children with spina bifida cystica. Clubfoot is the next most common orthopedic problem. Newborns who have had MMC surgery may have nutritional issues such as low body weight, nitrogen balance, serum protein, and total lymphocyte count. This, coupled with excess tension of the suture site, could lead to wound breakdown, as we observed in our cases.
Professor Nimrod, if you can...
Thus, specialist precautions must be adhered to when closing these wounds. And of course, sometimes we advise the mother not to let the child lie on the wound for 7 days after the surgery.
Professor Nimrod.
CSF leak is one of the major complications of myelomeningocele closure. Its incidence is reported to be as high as 70%. It arises from insufficient closure of the dura or through suture holes at closure. It may also arise from inappropriate closure of the anatomical layers or increased CSF pressure. 7% of the patients develop CSF leak and 6% develop meningitis. Since, according to literature, 85% of myelomeningocele are associated with hydrocephalus, the increased CSF pressure poses an additional risk. Recommendations: neonatal assessment of the child should be done early, and the condition should be classified into either flaccid or spastic. And at that time of neonatal assessment, management should be clearly planned so that one can know which patient to operate and which patients not to operate.
Professor, can you hear me? Hello?
Would like to go to the Loba and Selfield had advocated the selective non-treatment policy, which is adhered to in some countries. And I've put there in that slide the factors which usually will determine patients who should be given treatment or patients who should not be given treatment. I mentioned this because many of you are aware of this and as to how it can affect management of our patients. In US, of course, and in other countries, the non-selection principle is not applied, and all children are given surgery. Folic acid supplementation is the major issue which must be encouraged. This is achieved in many of the developed countries. In developing countries, it is not so easy, because even if we do folic acid fortification, most of our mothers usually rely on farm harvests from their own farms, and therefore folic acid supplementation would not be achievable. Therefore, folic acid supplementation cannot be through fortification, but it can only be through, for example, when they attend the clinics. Future recommendations. We are recommending the establishment of multidisciplinary spinal bifida clinic in our unit, where we will have all these specialists looking after these children together and getting good results. We also were trying our best now to see if we can have early closure of these wounds within 48 hours. It's not easy, but we would like to see how we could achieve that. And of course, the other issues which we would like to implement are issues like clean intermittent catheterization, which has been shown to be really important in management of these children. And folic acid fortification, this has been discussed. Already there is folic acid fortification in our country, but as I've said, very few, most of the mothers don't use the cereals which you are buying from the supermarkets, because they are using the cereals which they are harvesting from their own farms. So therefore, we need to do also the folic acid oral supplementation when they attend the clinics. Thank you. Asante sana. That is, I would like to acknowledge Kenyatta National Hospital for allowing me allowing us to do this research and present this data. Thank you.
Thank you very much, Professor Rangombe, for this interesting epidemiologic study. I'm afraid we don't have time for discussion, and we will move to the next presentation to be done by Dr. Srinivas from India about lesioning for tremor in the DBS era.
Can you hear me?
Sure, Professor.
Yes.
You should be able to share it now, sir.
Yeah, no, I think he has to unshare his screen so I can.
Nimrod, could you unshare your screen, please? Thanks.
Yes, let me unshare my screen.
Thank you.
See. Thank you.
Great, thanks. Thank you very much, sir.
Can you see my screen now?
Professor Srinivas, thank you very much. Professor Srinivas is coming from NIMHAS, which is a huge center in neurosurgery in Bangalore. Professor Nimhas, I hope you will give us time to ask you questions. So if you can, I'm sure you will, and because look forward to your talk. Thank you, sir.
Thank you. Thank you. It's been a pleasure interacting with you, and thanks for the invitation, and greetings from all of us at NIMHANS in Bangalore. I selected the topic because this is an neglected modality of treatment, which holds a lot of value in our country nowadays, especially in the smaller countries where the patients cannot afford DBS. So, basic introduction to tremor is that it's an involuntary rhythmic movement, and a very small part seek medical attention. But the important thing to remember is that it's the most common form of movement disorder. And most tremors, the frequency ranges between 4 to 10 hertz. And we have a wonderful classification based on whether they are rest tremors or action tremors. Let me not go to neurological.
Sorry, I'll sort it out.
Yeah, sorry. Or it could be distributed based upon whether they are head tremors, tongue tremors, or extremities, or whether they are low or high frequency tremors. And an important thing of tremors is to differentiate between a psychogenic tremor and a neurogenic tremor versus a drug-induced tremor. Yeah. So there are two modalities which are often used, but most probably when you go to the Western countries, most probably DBS most of the time. So the comparison is that DBS is bilateral, modulation is possible, but cost is a prohibitive factor, especially in our countries. While lesioning is unilateral, it's cost effective, and there are no hardware related or infections. But the one thing you have to remember is that it's irreversible. And we have three methods of lesioning. The one which has been used for more than 50, 60 years has been a thermocoagulation or radiofrequency, but it is minimally invasive and needs a burr hole. but it's a cost-effective setup, and in our country it costs less than 5,000 rupees. So that will be less than $100. Gamma knife is non-invasive, but the disadvantage compared to the ultrasound is that there is no immediate verification of the result. The final lesion is unpredictable, and it's a high dose. It's around 130 to 150 grays, and the cost of equipment is quite prohibitive. But the magnetic resonance ultrasound is even more expensive. But the advantage is it's both non-invasive, and you have a real-time monitoring and immediate readjustment, and the WIM can be visualized on table. When you go back to the history, there are multiple targets for tremor. The first described in 1954, and various targets have been described since then. One is the WIM nucleus of thalamus, which is the most commonly used for multitelogical tremor. The VOA and the VOP, which are used in selected cases of secondary dystonia and tremor. The VOP is particularly useful in rigidity and drug-induced dyskinesias. Subthalamic nucleus has been used in Parkinson's disease, and the PVP of the globus pallidus interna has been used in PD, chorea, primary dystonia, and hemibalismus. So what I'll be describing today is the WIM nucleus. We have done many cases in the other targets, but I'll stick to the WIM nucleus and the tremor today. Yeah. Even though the STN has been used, you have to remember that one thing, it's potentially irreversible, and there's a troubling incidence of hemibalismus which can occur if you use STN for tremor-dominant Parkinson's. Thalamotomy, on the other hand, unilateral procedures are usually safe, but bilateral procedures do have their cons and are not usually recommended. So these includes hypophonia, dysarthria, dysphasia, aphasia, and cognitive deficits. So generally, we prefer unilateral procedures. So when do you select a patient for surgery? The patient should have had an adequate medication trial of at least 2 medications. You should have a frank discussion with the patient and family, and have realistic expectations in that you're treating only the tremor, and the disease progression will continue. For example, in PD, the Parkinson's disease is going to progress. Well, you're going to treat only the tremor. So we use the standard Lexel frame. We use the Medtronic's planning system and the Cosman lesioning system. I'll describe the WIM nucleus of thalamus, which is targeted with us. We initially do the stimulation at low frequency at around 5 Hertz, driving the tremor. I'll just be showing the video now. Then we do a temporary lesion, and then we do a permanent lesion. So what I'll do is I'll describe this on this video over here, and you can see the immediate response which occurs. See, this is the pre-procedural tremor. So what we do is we do a small burr hole just anterior to the coronal suture, standard burr hole. And then we start, then we put the electrode, and we start doing a low frequency stimulation at around 5 Hertz. So when you see the low frequency stimulation, you see the tremor keeps on increasing. And as you increase the voltage, the tremor worsens, right? And then we go on to do the high frequency stimulation. And if you see the high frequency stimulation, when you go on from 0 volts to up to 2.5 volts, the tremor gradually gets suppressed and the patient goes into a dystonic posturing. So this shows that there's a good response. And then we, we make a temporary lesion at this position. Once a temporary lesion is made, we check the power so that there is no, because the target might be close to the internal capsule. What we do is we have to check the power before we make the permanent lesion. Here we are testing the power during high frequency stimulation. And once a temporary lesion is made, you again look for the powers to make sure that the power, there's no deterioration. And once the temporary lesion, once you're satisfied with the power, you make the permanent lesion. So once you do the permanent lesion, you can see an almost immediate response of the tremor. This happens in quite a good number of patients, but it's not unusual for the tremor to respond within the first 48 hours. So we've had done around 57 patients over the last few years with 59 stereotactic lesioning procedures with an average age of 38 years. We have done tremor for multiple etiologies, including essential tremor, PD, Wilson's disease, infective, traumatic, hemorrhagic, etc., with a mean duration of follow-up of around 11 years. So this is the response. The FTM tremor rating scale is what is the important scale for evaluation of tremor response. It's divided into three parts. One is the tremor itself. You can see there's been almost a 95% reduction in the tremor scores. The second part is the handwriting and the drawing, which has reduced by almost 60 to 70%. And the third is the activities of daily living, which has decreased by almost 70%. And the total score has come from an average of 45 to around 9, which almost signifies a 80 to 85% response over these group of cohort of patients. For lack of time, I'll just show you a single video of a patient of a predominantly unilateral tremor secondary to Wilson's disease. If you see this patient untreated or a partially treated Wilson's disease, you can see the significant rubral tremor. It's a violent tremor, and the patient is unable to use the right hand at all. The only way she's able to use her right hand is when she keeps it behind her body or under her legs, and then she uses her left hand. But once the right hand is free, the tremor becomes so significant that she's unable to do any jobs, including walking. So what she used to do was, when she used to walk, she used to keep her hand in the pocket. So this lady, this girl underwent, an engineering student, she underwent left limb thalamotomy. This was on the second post-op day, and you can see that the tremor is almost completely disappeared. So this is what lesioning can do. What it does is it brings an immediate cessation of the tremor and gives a very good response, especially in a predominantly unilateral tremor. See, what happens in many of these cases, the tremor, even if it's bilateral, the unilateral one side can drive the other tremor. And if you cure the tremor on one side, the tremor usually subsides. So we have had no mortality, but we've had 4 patients who had transient deterioration, which included worsening hemiparesis, who improved with steroids. One patient who had intractable hemibalismus. This was a patient who underwent subsequent pallidotomy. This was the patient who underwent STN lesioning for tremor. We had 1 or 2 patients who had unmasking of cerebellar symptoms. We had 3 recurrences, and all of them underwent redo surgery. So this is the chart we follow. All of them undergo medical management of tremor. And if they cannot afford DBS, or it's predominantly unilaterals with significant comorbidities and the patient's choice, we offer lesioning. But if it's bilateral, no contraindications for DBS, and their affordability is good, we go for DBS. So I will conclude here by, I wish I could have shown you more videos, quite a lot, but I think for the interest of time, I'll just keep my talk short. We'd like to say that it can be useful in multi-etiological tremor like PD, essential tremor, PCANS, MS, Wilson's disease. We have done all of them, and the response has been very good. The importance of value of lesioning cannot be underemphasized, especially in countries where both the procedure is quite expensive, the know-how is not available, and the patients cannot afford deep brain stimulation, and where it's not state supported. And especially in the developing the third world, it's very important because you can get excellent results. You should not be thinking that these are DBS is a supplement or lesioning is a tremor, lesioning a supplement for DBS. Both are complementary procedures and both have the indications. They might be an overlap, but more or less you can offer them separately to the patients, and it's an important tool. And even in our institute, we have done more than 250 procedures of deep brain stimulation. The ratio is around 2:1. So for every 2 patients who undergo DBS, 1 undergoes lesioning. We published this, our initial experience in 2014 in CNN. And I'd like to stop here by thanking the organizers and welcoming all you to Bangalore. And this is our institution, the National Institute of Mental Health and Neurosciences in Bangalore. Thank you.
Thank you very much, Dr. Srinivas, for this important presentation, because I think it is something to emphasize the usefulness of this technique in the absence of the possibility of the expensive DBS system nowadays. I remember witnessing hundreds of patients treated in my former department, but with lesioning for Parkinson mainly. But in my former department, the lesion was done by cryogenic system, the Cooper cannula. But I think this is something very important to be keeping in mind, listening even in the time of DBS. I have one question from Dr. Parker. First of all, about how to localize beam. Do you localize beam by means of MRI? And second, in case of bilateral tremor, do you advise bilateral lesions? Thank you very much.
Thanks. That's a very pertinent comment on the importance of lesioning in many situations. And even with the advent of the ultrasound, lesioning is actually caught on in a lot of Western countries. And it's most frequently used. For example, Professor Lozano and Professor Taira use lesioning quite commonly. How do I localize BIM nucleus? We use the MRI for all the sequences. The BIM, unlike the GPI and the STN, is an indirect target. So we have our coordinates, and then we fuse it with the map, the Warren-Scholten-Band atlas, and then come for calculations. Approximately, it comes between 13 to 15 millimeters lateral, around 5 millimeters posterior, and around 1 millimeter inferior to the mid-commissural point. That is the midpoint of the anterior commissure, the posterior commissure. And then we do the intraoperative localization. And sometimes you might have to change the trajectory so that you do not have, you do not get complications of hemiparesis or paresthesias. Do we do bilateral lesions? We have done for one patient, but that was more of a forced indication because after we cured that patient, he developed the tremor on the opposite side worsened, and it was so violent that he developed fracture of the neck of the femur. He had a very good response, but generally, like I mentioned, bilateral tremors are not advised because of the dangers of dysarthria, dysphonia. But we have done, but most of the patients we select for lesioning are predominantly unilateral tremors.
Thank you very much. Thank you. I do insist in the importance of this presentation, and I do insist, I'm not a functional neurosurgeon, but I remember quite well the excellent result in tremor, in Parkinson's disease, and another condition by means of the lesion. Thank you very much. I think we will move to the next presentation. Thank you. Thank you very much, Dr. Srinivas. We will move to the next presentation to be done by Dr. Noor Maria from Pakistan about systematic review of robotic-assisted surgery. I hope to perform safe spinal surgery during COVID and other infective outbreaks. Whenever you like, Dr.
Thank you so much.
Okay. Can you share your screen? Okay.
Can't you see my screen?
Thank you.
Is it visible?
Yes.
Is it visible, sir? Thank you so much, sir. Sir, I'm deeply honored. Thank you so much, sir. Sir, first of all, I'm deeply honored to be speaking and sharing my work on this prestigious platform. I'm going to share our systemic review on robotic-assisted spinal surgery, which is I hope to perform spinal surgery during COVID-19 and any other infective outbreaks in patients with infectious diseases that includes HIV. So this is a very famous verse from our national poet. That means that it is heart-wrenching to see the machines sense wherein these tools crush all sense of human behavior. So I think in one word, it is something that we really want to say being a neurological session. So what is a robotic-assisted spinal surgery basically? And why do we need it, especially in these unprecedented times? Robotic-assisted surgery is a basically domain of spinal surgery that carries a high potential to open new horizons for safe, precise, minimally invasive surgery Basically, it is the extension of the horizons of more advanced spinal surgery, where you can take the precision, you use the precision of a machine and the mind of a doctor or neurosurgeon. So it is basically something like a hybrid. After the approval of robots like Spinal Assist, there is help of robotic assistance providing accurate, precise keyhole surgeries in an environment which provides a low risk of infection transmission and minimize the radiation exposure to the health personnel. This is prudent to evaluate in the wake of this pandemic. Robotics have been considered in spinal surgery because of technical nuances that may allow the utilization of robotic assistance. So why do actually we need it? Right now, I will just evaluate in the part of this lecture. Some spinal surgical robots that I need to mention here: X, Rosa Spine, the initial robot spine robot with Zimmer, and the Biomet ones, and the intuitive surgical and Da Vinci surgical system. I guess the best known to all the doctors is the Da Vinci surgical system, which is also general surgery and urology for the assisted procedures. Basically, they help in fusion and instrumentation. The two spinal surgeons from Virginia Institute successfully performed the world's first combined endoscopy for the modern neurospinal surgery. Once we did, we reviewed 18 articles on robotics in spinal surgery. And relevant data considering the learning curve, the duration of robotic assisted procedures, efficacy in terms of precision and accuracy according to the specified spinal procedures, the caveats and nuances of the procedures, radiation exposure, feasibility of remote supervision, the risk of infection transmission, especially nowadays we have got COVID-19 pandemic, and you can just predict any other infective pandemic someday, who knows, God forbid. And also we have to evaluate, being from the low middle income country, we have to evaluate the cost effectiveness and the reasons for robotic failure, and all of this was collected from PubMed research getting curious. What we found is out of the 18 studies that point relevant. 11 evaluated radiation exposure hazard in teams in terms of usage of fluoroscopy and the overall and the robot will assist you in providing these radiological fluoroscopical procedures. 10 studies examined the learning curve and concluded that it is the same for the minimal invasive surgeries. In fact, everyone who has been well versed and been trained for minimal invasive surgery will be able to learn the robotic assisted surgery in much less duration as compared to all other conventional surgeons, which are not quite well versed with the MIS. So it was quite same for the MIS, and especially with someone who has a background of an MIS, he will be able to learn it in a much shorter duration as compared to the other ones. So I'll study the duration of procedures. And 12 when convinced that it is longer or at the most equal, while two said that there's not much difference, and two said that it shortens the procedure. Again, I want to emphasize here that it depends upon the expertise of the operating surgeon. Of someone who is already well versed with any other open procedure or with the MIS will be able to perform it in a much shorter duration. But again, there's a race between the expertise of the operating surgeon. So it depends upon that basically. Mainly, again, we can have variation in that. 5 evaluated the cost effectiveness and since the equipment is still under developmental phases. So despite our future expectations and goals of having the procedure at a much cost effective when we are by far lacking adequate experience to everyone, because here, especially after the after in the in the aftermath of this pandemic, we do not predict what will be the financial situation of our health system, which are already overwhelmed and getting a bit more more of the budget has been deviated towards COVID-19 and other surgeries that are very emergent in their own essences. 5 studies evaluated the risk of infection transmission, and one was for specifically COVID-19, and they were all convinced that the risk of transmission of infection, both airborne and bloodborne, is much more lower. Majorly, it is because of a reduced exposure between the patient and the health personnel, which can be both adequately protected against infection. So basically, you can just take more like you have to take the level 3 precautions for COVID-19 and just proceed into action. And the surgeon should be trying to use on simulated training workshop, have an approach to the labs, the operating labs and workshops. With special reference to COVID-19 and any other infective outbreak, I would like to say the COVID-19 reference, there's less human-human interaction, reducing transmission risk, and we need no more extra staff in the operation theater. According to STEM studies on a bigger picture, successful robotic assisted surgeries may prove the technique to be economically friendly. Application in patients with HIV and other infectious diseases is obviously there. Thank you so much. I think it's the test of time. Thanks again for listening.
Thank you very much, Dr.
I guess
Norm
that
Maria.
it would be the robots will be no more than an assistant for a doctor. But I guess it is no more than a very advanced level of equipment for the surgeon, because the brain of the surgeon cannot be replaced with an AI. Thank you.
Thank you very much, Dr. Norm Maria. I have to warn you, because I don't know whether it's me or not, but sometimes I felt your connection, internet connection, could be a little weak, you know. But anyway, I think we all could follow your presentation. That is very interesting. I have one question for you. I think we have to counterbalance the benefit of this robotic assisted surgery, the benefit and the cost. What do you think is, weighting more, the benefit or the cost? Because okay, please.
Exactly, sir. Sir, I do think that being from the low middle income countries, I don't think that it is towards the much for us, because the cost is much more than we weighting is the benefit. But for developed countries, maybe the other way, because they already have much better resources, and everyone who actually has on the other side, but not for us. It basically is something that is revolutionary, a bit more attractive scientifically in the wake of a pandemic, where we are just a bit more concerned about the infection transmission. So if we just keep that in mind, that the pandemic is more serious, then we can say in that case the scenario, I think that in short, I mean that it is basically depends upon the one's own circumstances and one's own scenario.
Thank you very much, Dr. Norm. And let's move to the next presentation that is also about to be done by you. I very much appreciate keeping it in the frame time, because we are a little behind the schedule. So next presentation by Dr. Norm Maria on open versus endoscopic surgery for craniosynostosis in terms of blood loss, infection, and hospital stay study from low and middle income countries. Please, go ahead. Can you share your screen?
Exactly, sir. I'm trying to. It seems to be stuck.
While Dr. Noor is trying to get her presentation online, Professor Goel, do you have any thoughts on robotic surgery for spine?
Yeah,
Naren?
Naren,
Yep.
you can hear me?
Yes, I can. Yeah.
Yeah, I understand technology is improving, technology is growing, and technology has to eventually grow. But what is more important is your understanding, your philosophy, your basic understanding of the spine, the basic understanding of biomechanics. And, you know, these things, according to me, are more important.
Next video,
Robotics is good, and robotics will eventually take over. Because, you know, we are technology driven, we are actually, you know, something is, Naren, there is some interference.
Sure. Just a second, thanks. Yes, sir. Please carry on.
Philosophy is, you know, the mother of science. And you have to understand the issue. Basic understanding is important, and basic conduct is important. Robotics and all will help. That is my answer to your short little question, my dear Naren.
Thank you. Thank you very much. I think certainly, you know, you are a master of spine surgery. Many of you are masters of spine surgery. I have done spine surgery as well, you know, and I've seen many people do spine surgery. The outcomes are tough enough in many cases. Certainly, you have to be pretty fantastically good on open surgery before you can do robotics. But by the time you become so good, I don't know why the time will, how much time, you know, you will probably do it so quickly that you will spend time putting the robotic. Miguel, how you see robotic surgery in spine yourself? I know that you are not, you do spine surgery, but that's not your main area.
Well, actually, this is a very expensive technique. And of course, as Professor Goel is saying, robotic is something that is domain in the world in every aspect, you know, just to make cars or to make anything. But I don't think in this particular moment the nascent technique is, you know, benefit cost, you know, interesting. I think the system available in Spain are quite expensive, and nowadays you have much less expensive system like intraoperative CT scan, and many of the experienced surgeons are pretty much happy and doing fast operation by means of fluoroscopy, classical fluoroscopy. So I think that as happening at the beginning of neuronavigation, I think the technique has been to evolve a little bit more, and the price has to be diminished in order to be more popular. This is my understanding.
Sure, thank you very much. Dr. Noor is trying to reconnect. I think, you know, the thing about technology is that, as we see, is that, you know, when it goes well, it is magical. But, you know, technologies are not as reliable as one would like to think so. And I know that Da Vinci has made big inroads in prostatic cancer, in urological surgery, but maybe that neurosurgeons are slightly conservative, that we don't necessarily jump on it like others. But I'm sure in the next 10 years, the technology might go so fast that certainly for some cases, it might be useful. Dr. Noor, how are you doing there? Dr. Noor, if the presentation is difficult to upload, you can just summarize your talk just by audio. That's as good as
Sir,
slides.
I've just um, plugging in my mobile network, so I think that it might work better.
Okay, that's good. In terms of Dr. Nimrod, Professor Nimrod, Dr. Srinivasan asked a question about, maybe it has been already answered to Professor Dwaknath, about bilateral STN lesioning. If Prof is there.
Sir, can you see my screen now?
Yeah, yep, you
Yes.
can see your screen. Yeah.
Sorry for the inconvenience. I was
No,
not.
no problem.
Thank you so much, sir. Sir, I'm really sorry for that.
No.
Thank you so much, sir. Sir, my next topic is on open versus endoscopic assisted surgery for craniosynostosis in terms of blood loss, infection risk, and hospital stay, which is a study from the low-middle income countries. Here, I'm very much thankful to all my colleagues and collaborators who helped me collect this data from many of the low-middle income countries that include Syria, Iraq, Afghanistan, and India. The introduction includes craniosynostosis, especially all we know that it's a premature closure of the calcareous suture that leads to deformation of the skull. And a timely correction is prudent that we traditionally performed through the open way. In Pakistan, most of the time we perform the open surgical procedure, that is the correction of the deformity. It is usually a lengthy procedure and an invasive technique, and not many much surgeons are well versed with this very cumbersome procedure. With the advent in endoscopy, the trend has shifted towards the endoscopic assisted surgeries. However, endoscopic surgeries are not quite widely used in our setup at least. So why endoscopic assisted surgeries in the lower middle income countries? They are not quite widely spread, and only a few neurosurgeons are well versed with these procedures. Although there is a growing trend recently founded by the neurosurgeons to join it, there is a need of training in pediatric endoscopic surgery. The methodology included the data was collected from pediatric neurosurgery units from various centers in the low middle income countries. A total of 14 patients were enrolled with non-syndromic craniosynostosis from both the genders with an age range from 4 months to 11 months. Out of them, 7 underwent classical open surgery, while the other 7 underwent endoscopic assisted surgery. The result includes for the endoscopic assisted surgeries compared with the open surgery, the operating time was much shorter. That was on average for endoscopic surgery. We found the time was 2 hours 50 minutes, versus for the open surgery it was 6 hours 15 minutes. The estimated blood loss was lower. That was just 87 ml for the endoscopic one versus 305 ml for the open one. The transfusion requirement was much lower. For endoscopic surgery, it was on an average 90.6 ml, versus for the open surgery, it was 22.6, 226.9 ml. The hospital stay was much shorter. These were very important points given the age at which the patients have been operated. The small children, it is very important to consider the blood transfusion requirement and the need in that age group. And obviously, the hospital stay is much more important in that age group and in the wake of a pandemic, where we are trying to just minimize the exposure and trying to keep our patient for as short period as possible in our hospital. This is a very important thing to consider, that in the given new scenario and the aftermath of this pandemic, I think this could be a very important point to consider, the induction of this technique in our hospitals. This is the pictorial, basically, presentation of all this. I think the graph has been changed because in my computer there was another graph. There are 4 graphs which I had nicely elaborated, so I'm sorry for that. So this was basically the comparison of the operating time in hours, the transfusion requirements, and the average hospital stay. So what we conclude is that the endoscopic assisted approach for craniosynostosis is much better than the conventional open surgery in terms of blood loss, the need of transfusion, the operative duration, and the post of hospital stay. However, in the low middle income countries, endoscopic assisted surgical option is not widespread and it is being done sparsely. So actually, I do think that it wasn't something that
was very hard to induct because many people, the adult neurosurgeons, they choose endoscopic surgeries such as the ETVs and other surgeries. And I think that there's a lack of basically awareness in part of the neurosurgeons to opt for pediatric neurosurgeries and pediatric endoscopic neurosurgeries, and these are not quite I don't think that for the people, there's another study we have conducted regarding the learning curve. So I don't think for this, to people who are quite well versed with endoscopic surgeries in adults can easily perform pediatric endoscopic surgery for CSO that is much less cumbersome than a conventional open surgery. So actually what we need is that we need endoscopic assisted surgery as an excellent option for CSO surgery, and we need to emphasize this technique and make it aware for the neurosurgeons to learn this. And there's a need to introduce this specialty in low middle income countries, and training, especially people can do fellowship in pediatric neurosurgeries and endoscopic neurosurgeries. And I think that is much more a much better option for many of the non-syndromic, at least the non-syndromic craniosynostosis to be proceeded with. So thank you. I've tried my best to put into the time frame because I'm sorry I had to, I took it too long for me to get along with it again because of some interruptions. Sorry for inconvenience, and thank you so much for listening to me.
Thank you, Dr. Noor. First of all, I'd like to make a comment. You are, amazing, because one of the things that defines surgeons or neurosurgeons is the way to overcome, unforeseen difficulties. And you did that in, in a very record time. So I do congratulate you for that. You have a, you have a place in my department. Come to see me. Okay.
Really,
so,
sir?
Any question for?
I think
yes, please come.
Thank you very much. I think first of all, I think I have to second what Professor Aras said. Well done, Noor. You turned it around. So well done. In terms of the endoscopic surgery, certainly the volume of blood is less than open surgery. And in Pakistan, how well are you looking at outcomes and how well is that? How well are you able to follow up the outcomes in Pakistan in the setup that you have?
Sir, we usually perform open surgeries for craniosynostosis. Actually, there is a whole center in my city, Lahore, for pediatric neurological surgeries. So people do follow them. And we even recently we received a patient in OPD who was operated for craniosynostosis and had Cruzon syndrome, and he was okay, doing fine. He just had a few problems with the vision, which he was concerned with. So we just do have a good follow-up, and the results are, this is very miraculous in that way, that the results are quite fine, and those people who get operated in time usually do follow and do have good results. But most of the time we have an open surgical option and not the endoscopic one, and that's a bit unfortunate.
Sure, thank you. Dr. El Gamal, I see you there. Dr. El Gamal is from, I think, UAE. So do you do endoscopic surgery in Middle East now?
Oh, thank you for the question. No, we don't do endoscopic surgery for some reasons. Most of the cases are referred to us late, after 3 months of age and sometimes 1 year of age. And I think endoscopic surgery should be done early when the child is like 3 or 4 or 5 kilograms weight. The second reason, actually, we need to have a learning curve for this endoscopic surgery. So only few cases have been done, but I'm not aware about other centers doing training surgeries here in UAE. Probably in other countries like Saudi Arabia, I believe they have some experience with endoscopic surgery for clinician surgery.
Thank you. I think we also are very keen on endoscopic, but we have the same problem trying to get the children at the right age, having enough cases to have the right learning curve, and some concerns still about the outcomes. Professor Hakan, if you can connect. Do you, sir, do you do endoscopic surgery for craniosynostosis in your department in Turkey? Thanks. Professor Hakan? Thank you. Professor Hakan, can you hear me?
Hello.
Hello, Professor Hakan. Do you do endoscopic surgery in your department, sir?
In our department, we don't do any endoscopic surgery, but there are some friends interested with that in other departments.
And the reason that you don't do like us, what's the main reason, sir?
Sorry?
What's the main reason that you haven't started doing endoscopic surgery?
Our department is a new department and we don't have any endoscopic equipment yet.
Okay, thanks. Thank you very much. That's brilliant. Thank you. Miguel, is that the morning session we have gone through?
Yes. Okay.
Brilliant.
Okay, thank you very much for giving me the opportunity to take part of this wonderful international webinar. And I think that we have heard very interesting presentation covering different topics with, you know, some good, let's say, comments and ideas. I think that sometimes it caught my attention, the presentation regarding the way of solving the problem of tremor. In the time of DBS, I think we have several parallel issues because DBS can be considered in the same way as robotic spine surgery. Well, this is something we all want to have, but sometimes we have to appreciate what we have now able to solve the problem with the least possible cost in the middle of these difficult times and the difficulties of LMIC situation. So, Naren, maybe you want to close this wonderful session and continue with the program. Thank you very much for all the participants.
Thank you very much, Professor Miguel Ares. Wonderful chairmanship, and thank you very much for taking time in your very busy schedule to moderate this excellent session. I think we learned a lot from you know the 3 different continents at least, and certainly great ideas. So congratulations to all the speakers, and thank you very much to Professor Kyrillos for that fantastic lecture. It's all on the YouTube, so you can go back and re-look at it. So a 10 minutes break to just stretch yourself and have a quick cup of tea, or you can have the tea in front of you, and see you in 10 minutes. Thank you. Okay. Hello, Professor Grotten-Hughes. Welcome. Wonderful to see you here.
Yeah, well, it took some time. I tried already to log in here at shortly after 9 Central European time.
And
for more than 2 hours, there was only, you will be let in soon. So, but
sorry about that. I think
I managed, so that's good.
Thanks. I'm trying to figure out.
Professor Grotten-Hughes, welcome. Wonderful to see you here. Yeah, well, it took some time. I tried already to log in here at shortly after 9.
I think it might be you have got the.
2 hours, there was only.
I think you have got the YouTube on as well, Prof. I think.
About that. I think I managed, so that's good.
Prof. Grotten-Hughes, I think your YouTube might be on as well, so you are getting a latent. Yes. So you might have to mute the YouTube, but I'll just see. That's great. Let me just. Yes, the Zoom has put this new thing with for security. These, people go to waiting room to be admitted. I have said I don't need that, but it's still having that problem. Let me just get the next speaker details. Dr. Multani, are you there? Let's see. So we have got 3 minutes, 2 minutes. Professor Multani, are you there? Prof. Goel. Hello, Prof. Goel.
Yeah, Naren.
Prof, if Karthik doesn't show up, or it might be just some communication problem, would you be able to go next?
No problem. Let us wait for 1 or 2 minutes. If he doesn't come, no problem. Okay.
Thanks. Thank you, Chair. Thank you very much. Okay. Professor Gaul, if I may please ask you to go ahead. Thank you.
Yes,
Chair.
yes,
Thank you.
sure,
Thank you.
certainly, my pleasure
Thank you.
and my honor.
Thank you very much. So welcome back to the late morning session. We are in treat for a fantastic presentation, starting with that of Professor Atul Goel, who doesn't need any introduction for the neurosurgical audience. So without further ado, Professor Goel, please. Thank you.
Okay, so my dear friends, I'm going to introduce to you a new concept, The concept is that instability is the issue and stabilization is the treatment and decompression is not necessary. So this is just mark these words and this line and let us see how we go. The entire story of spinal degeneration is historically based on disc. We talk of disc degeneration, we talk of disc space reduction, we talk of reduced water content and disc bulges. So we blame everything on the disc. So my concept is that disc is divine and disc is too big and too vast an issue. Disc is not the issue. That is my number one message. You see, the entire musculature of human body is based on the back, and all the muscles of the body are focused, or the fulcrum is on the facet. Facet is the center of activity and center of movement. And facetal problem is the issue. Muscle weakness due to disuse, abuse, and injury is the problem, and the injury is manifested at the facet. So that is the message number 2. Craniovertebral junction instability in degenerative spine. We talk of degeneration, we talk of C5, C6, C4, 5, but we never talk of C1, C2. My understanding is absolutely clear. C1, C2 joint is the most mobile joint of the body, and C1, C2 degeneration, spondylosis is the most common form of degeneration. Muscle weakness is the issue. When muscle of the nape of the neck is the problem. And when the muscles become weak, the joint space reduces. You see, the joint space is reduced. The next thing that happens is that buckling of the posterior longitudinal ligament. And then happens is the osteophyte formation. So my concept is that osteophyte formation is an indicator of spinal instability. Joint space reduction is an indicator of spinal instability. They are not primary issues. They are not the primary problem. The problem is instability and treatment is stabilization. This is the degenerative C1, C2. You see osteophyte in the region of apical ligament, osteophyte here, osteophyte here, osteophyte here. This is an indicator of an unstable C1, C2, and it merits the need of fixation and realignment if possible. It does not merit the need for decompression. This is not a problem. This is a solution, and solution to spinal instability. Retroodontoid ligamentous hypertrophy or pseudotumor was historically removed by transoral and other methods. But we mentioned that this ligamentous hypertrophy is secondary to atlantoaxial instability. You stabilize the joint, and this osteophyte-like structure will automatically, spontaneously disappear. And this we mentioned about 15 years ago, and now most of the units do atlantoaxial fixation for retroodontoid pseudotumor. So in 2004, I published this for the first time, that this is not a problem, this is a solution. Retroodontoid cyst formation is not a primary process. It is an indicator of atlantoaxial instability. You stabilize the joint and there can be immediate postoperative disappearance of this pseudotumor. So we should know that what is primary and what is secondary. Primary should be treated and secondary should be respected. This is a retroodontoid spannus. We said that this spannus is not primary. It is due to vertical instability. You stabilize the joint, realign the craniovertebral junction. In rheumatoid arthritis, there can be immediate postoperative regression of the pannus. Now we talked about the same thing for degenerative cervical spine and lumbar spine, and we said that disc is not the problem. Osteophyte is not the problem. Vertical facetal instability, is it the point of genesis of cervical spondylotic disease? I say yes. You see, we talk of listhesis as a cause in basilar invagination. This is C1, C2, but no one has ever talked of listhesis of the facets. My absolute understanding is muscle weakness leads to listhesis of facets, and that is the mother of entire process of spinal degeneration. So this disc bulges, you see this disc bulges is not the primary issue. This disc space reduction is not the primary issue. Osteophyte formation is not the primary issue. Multiple disc bulges are not the primary issue. They indicate that there is a vertical spinal instability, and that vertical spinal instability needs treatment. There is no need to do any kind of decompression, either from front or from behind. So initially, I'm talking of my historical growth in this subject. In the year 2010, we said that you introduce intrafacetal spacers and distract the facets, and this will reduce, this buckling of the ligament will reduce, this disc, there will be a new disc formation, the ligamentum flavum will unbuckle, and the patient will have remarkable clinical recovery. So this was my new concept of spinal degeneration. You see here, there is multiple disc bulges, ligamentum flavum hypertrophy and bulging, but I say this is not hypertrophy, this is not pathological, this is not primary, and after distraction, the whole thing has resolved. The ligamentum flavum is gone, the buckling of the posterior longitudinal ligament is gone, and the osteophytes will go. And you see there is a new disc formation at each level. So this is a magic, this is a revolution. There is no need for decompression. So let's go, and you see here, this is another disc. This is a new disc formation. The disc bulge is gone, ligamentum thing is gone, and there is stabilization or arthrodesis of the area. So in 2011, I published this article, and this is quite a highly cited article now, Facetal Distraction as a Treatment of Single and Multi-Level Cervical Spondylotic Myelopathy. This report we had published. So these are the spacers that we designed. Same concept for lumbar canal stenosis. Lumbar canal stenosis, we say it is stenosis, but I say it is not stenosis, it is multi-segmental instability, and you introduce these kind of spacers and a remarkable clinical improvement, no need for decompression. So decompression or compressed or deformed neural system has been the basis of surgical treatment for several decades. I contest that, I say it is wrong. Then as we matured, we understood that there is no need for even distraction. Only fixation for cervical spondylosis. In 2013, I published this article. And then recently, I have published my experience with 215 cases where there is no decompression for single and multi-level degeneration, only fixation, not even distraction. You see, there is a bulge here and there is a compression. So what I do is identify the best levels of fixation, and this osteophyte will disappear. And you have to read my articles on this subject. Remarkable clinical improvement without decompression. We said that in many situations, atlantoaxial instability is also commonly associated with subaxial spinal instability in multi. So we should not ignore atlantoaxial instability in multi-level cervical spondylosis. You see, this is multi-level disc bulges. It needs multi-level stabilization. But you see there is a facetal instability. It needs atlantoaxial stabilization as well. If you have this concept in your mind, this operation of decompression will certainly become historical in no time. Patients having severe myelopathy, if you understand that severe myelopathy patient will always have atlantoaxial instability, you have to stabilize. You see, this is severe myelopathy, nothing much as form of compression, but you see atlantoaxial instability, multi-level stabilization, including atlantoaxial joint, no decompression is the treatment. Similarly, we said that lumbar canal stenosis is not stenosis. It is multi-level spinal instability, period. No question about it. Decompression is absolutely redundant operation. It needs multi-level stabilization. I know it is a little bit difficult for people who are doing decompression for ages to accept this, but I welcome you to read some of these papers, which are all published in various journals. So with this disc bulge and multi-level disc bulge, it does not need direct intervention. These are indicators of unstable spine. These are indicators that the region is unstable. You have to stabilize, and this osteophyte or disc will eventually disappear. Most importantly, the patient will improve in the immediate postoperative situation like you have never witnessed. Same concept in ossification of posterior longitudinal ligament. We have said that ossification of posterior longitudinal ligament is a consequence of unstable spine, and it is not primary. So we have said that only stabilization is the ideal treatment of OPLL. This we published several years ago. And of course, now recently I published my further experience with 52 cases. Only fixation, no decompression as treatment of OPLL. So this kind of multi-segmental OPLL, you have to treat only fixation. And now I've introduced another beautiful concept, that atlantoaxial instability is a very common associate of OPLL, and you have to stabilize atlantoaxial joint. If you do not do this, you will land into difficult situation, and those who do OPLL know how difficult the problem can be. So this is multi-segmental OPLL. There is no decompression, only stabilization, remarkable clinical recovery, multi-level OPLL, I know I have only 10 minutes to introduce a revolution in front of my dear Naren, but Naren, this 10 minutes is good enough for me to introduce this new concept. I know there will be several questions, and if there are not too many questions, I will be surprised. So can decompressive laminectomy for degenerative spondylotic lumbar and cervical stenosis and OPLL become historical? I am saying absolutely. Is instability the nodal point of both cervical spondylotic myelopathy and OPLL? Absolutely. So my conclusion is that compression is never primary. Of course, I'm not talking of tumors and things like that. Compression is never primary. Decompression is never the treatment. Instability is primary and stabilization is the treatment. Thank you very much.
Thank you very much, Professor Goel. Once again, very impressive and thought-provoking, and certainly, look in your usual way, you look at it in a different way, and we usually kind of follow later on. So before I ask my questions, I just want to see what I think. I'm sure this is something to discuss. Professor Andre Grotenius, let's see whether Professor Grotenius here, let's see. In terms of, in terms of the number of operations that you have done on this, how many have you done, and are you planning any study in terms of
double blind kind.
yeah, double, even a single blinds, because the problem that we have is, Prof, I think what you are onto is great. I think it makes sense. The two issues is that one is that the old operation is it was successful as well, so it's very difficult to go from a successful operation to a new one, and if without a randomized trial of some kind, it's impossible to start in a hospital. Certainly in UK, they will not, and the hospital management will not give permission, and you will already have enough resistance in any department for new ideas. So it's really hard to push it to the next level without some sort of trial. That do you foresee any trials that you plan, sir?
Yeah. Now, Naren, I will like to answer this question. See, I have been working on with decompressive laminectomies. I have been working with anterior discoidectomies. I have been working with corpectomies. I have been working, you see, I have got a long career behind me, and I know exactly what is how the treatment evolves. And I have also seen the most outstanding outcome. You see, I have got now fellows from all over the world visiting here. In the last 10 years, I have got 315 international fellows who have visited me. So I have got a lot of support, and they have seen what I'm doing. Of course, this is an absolutely different kind of thought process. Of course, it is different from the existing thought process. Of course, it is different from what everybody has been doing for several years, and they have been getting whatever results they have been having. But you have also to realize that if you read the reports of multi-level corpectomies and single-level corpectomies, you see there are so many complications, and this kind of things have been discussed. And you read my recent article in World Neurosurgery, 215 patients, and if I say I have got 100% good results, there are only two options with you. One is you say I am speaking lies or something like that. And second thing is you have to agree to what I am saying. So if you think that I am saying in my whatever I am saying, it may not be correct. So the next option for you will be, why don't you, not only for you, Naren, don't try to understand what I am saying is, if you are impressed and if you try to analyze this concept, it may best be like for Chiari malformation, when I said only decompression is not a good operation, atlantoaxial fixation is a good operation. Many people have their ideas, no, we don't agree. And see, if you don't agree, then there is one option. Either you just ignore what I'm saying. Whatever I have said, you just ignore and continue with whatever you are doing. Second thing is, if there is some kind of inquisitiveness, some kind of some kind of questions that I have raised in front of you, and you think that might just be relevant. So one has to work on those things. One has to think about it. These are all my articles are published. More than 100 articles are published on this very subject in last 10 years. You can go to the literature and read, and most of my articles are published in very top-notch journals. They are not just a figment of imagination and I'm saying, yes, do this and do that. They are published very heavily. So it may be worthwhile for those who have an inquisitiveness on what I'm saying to either think about it, or why not come and spend some time with me. Like 315 international people have already come. Basically, many of them have come for Chiari, but they have seen what I'm doing for degenerative spine, for OPLL. More important than any other thing, I have video records of all my patients, and I can tell you without hesitation, I am creating magic. I am giving new life. I am giving wonders to these patients. That is my answer to your question.
Thank you, Prof. I know Professor Grottenhuis, if you are there, if you have been able to connect, what's your thoughts on what Professor Goel's presentation? I think Professor Zilali just joined. So anyone else has any comments on what Professor Goel had to say to us? can put it on the chat box, I'll bring you up. Let me see. Great. Is there? I'll just get Professor Zuleli.
See, also in the meantime, yeah, go ahead.
Certainly, what about in among your residence fellows who have now started doing it? Would they be in India? Would they be able to do a trial? The problem is that what we are certainly I'm a pediatric neurosurgeon. I'm not going to be able to do this, but without a trial, it's just that you are not going to get it maybe in time, but it's in terms of acceptance, I think sadly, rightly or wrongly, that trial makes things easier. It allows things to go further ahead.
Yeah, I was told to conduct trials on Chiari malformation.
Mm-hmm.
You know what results I am getting by C1, C2 fixation.
Mm-hmm.
What magic I am creating, what beauty I am doing, and why I should do decompression now when I have done decompression for 20 years. Similarly, you see, when we do for lumbar canal stenosis, or many people have advised do PLIF operation.
Mm-hmm.
For cervical, you have advised anterior discoidectomy and fixation.
Mm-hmm.
So many people in any case do fixation.
Mm-hmm.
So what one can do is you do fixation. And if the patient does not improve, decompression is always possible. You come next day and do midline decompression, or you come anterior and do anterior decompression. Nobody is stopping, and you have already achieved fixation. So one step is now not to be worried about. So you do fixation, and suppose your patient does not improve. Means if you are worried that patient will not improve, so next day you come and do decompression. But I have to tell you that I am doing this operation for over 13 or 14 years. I have never repeated an operation.
No.
Never.
I think certainly very impressive. I'm sure that it will get more acceptance. Certainly more people will start doing it. If you have any questions for Professor Goel, please put it on the chat box, please. Professor Goel, once again, I think you have come to a new, certainly which is certainly very clear and certainly very logical approach. I think it's for others to come and see. If anyone, as you said, doubts, then they have to come and see what you do and see your patients, and then they have to consider doing it or doing a trial. Thank you, sir. Thank you very much.
Thank you, Naren, for giving me this opportunity. I have actually, I have written on this subject for last 10 years.
Mm-hmm.
Because it is so big. I am always worried. I have been worried for 10 years that somebody will copy and will not give me credit. So I have never actually presented this material in a completeness. Like you gave me 10 minutes, but I have tried to introduce several things in this.
Mm-hmm.
So this is a concept, and concept is now introduced.
Mm-hmm.
Whether it stands the test of time, whether it tests the fury of time, whether it tests the love of time, whether it is ignored into oblivion, that time only will say. But as far as I am concerned, history is made, revolution is here for us to accept and undertake these kind of thought-provocative steps if you have to, or ignore it.
No, I think my from looking at your lecture and thinking over it, I think this will be in 10 years time. We will come back and probably look at this presentation. I think it certainly makes absolute sense to me. So congratulations again, Professor Goel.
Thank you.
Thank you very much, sir. Can I please invite Dr. Shah to share her presentation, please?
Yes. Hi, Dr. Naren. Can you see my screen?
Yes, absolutely. Thank you, sir. Thank you, madam.
Okay. So after this fascinating lecture by Professor Goel, I will present on limbic system, anatomical and surgical correlates. Again, I work with Professor Goel, and this is our work done in our department. So the limbic system is the most complex and least understood parts of the mammalian brain. If you look at this structure, all you can see is a complex interactions of various connections. It is how we will anatomically see and decipher these connections to understand how the limbic system is connected to each other and how the various constituents pass on their signals to other parts of the brain. So in this image, if you see, there are actually 4 circuits. There is a supracallosal circuit that runs from above the corpus callosum and goes to the hippocampal formation. There is another circuit that is the pappus circuit that runs from the hippocampus, goes to the fornix and comes to the mammillary body and then goes forward. There is a third circuit that is of the striae terminalis or the dorsal amygdalofugal pathway. And there is a fourth circuit, and that is the ventral amygdalofugal pathway. So we're going to look at all of this one by one and see it with anatomical images. Before we start, embryologically, when the primitive fishes left the oceans and evolved into amphibians, all they had was a brainstem with a thalamus on the top as its head. When they came to the surface, around this thalamus and brainstem developed the amygdala and hippocampus on one side and the olfactory and piriform cortex on the other side. Around this, there were some cortical rings that developed, and you had paralimbic structures, the insula, the parahippocampal gyrus, and the cingulate gyrus. When all these structures got connected, you had the limbic connections. So these are the various constituents of the limbic system. So the gray matter constituents are the hippocampus, the amygdala, hypothalamus, the nucleus accumbens, the cingulate, the prefrontal cortex, and some nuclei of the midbrain. And these are the white fiber tracts that connect the limbic components. You have the cingulum, the striae, longitudinal and lateral striae, the fornix, anterior commissure, tracts connecting the limbic system to the midbrain, the mammillothalamic tract, the stria terminalis, the dorsal longitudinal fasciculus, and the medial forebrain bundle. So we published this in our article, I think 10 years back, and it is quite a highly cited article. So to begin the dissection for the limbic system, you begin from the medial aspect of the brain. This is an image we are all very familiar with. You have the fornix, the thalamus, the choroidal fissure with the choroid plexus coming out in the region of the foramen of Monro. This is the ependyma of the lateral ventricle, and this is the corpus callosum. Once you remove the ependyma of the lateral ventricle, you start seeing the caudate head. Dissection in the region of the thalamus will start revealing the mammillothalamic tract as it goes up to the anterior nucleus of thalamus. You also see another tract going to the midbrain, that is the mammilotegmental tract. And as we dissect further, we will see the first circuit, and that is the connections of the pappus circuit. So as the dissection continues further, here you have the fornix that is becoming the columns of fornix, the mammillary body, the mammillothalamic tract, anterior nucleus of thalamus. And you have another tract that begins here in the subcallosal region. That is seen after you remove the gray matter of the cingulate gyrus. And this is the cingulum. As it curves around the corpus callosum, becomes the isthmus of the cingulum in this region and goes on forward to become the radiation of the cingulum. Here you see there are connections between the cingulum to the parietal cortices. It also has strong connections to the frontal cortex, which has not been dissected here. And this is the way the limbic system communicates with the higher cortex. Moving further, the radiation of the cingulum is now depressed downwards, and you see this region more clearly now. This is the region of the hippocampal formation, the hippocampus, the fimbria, the dentate gyrus, then the fimbria going on to form the fornix, the columns of the fornix, mammillary body, mammillothalamic tract, and anterior nucleus of thalamus. Still moving further, we have removed the dentate gyrus, and now you can clearly see the fimbria as it is forming into the fornix and going ahead to form the mammillothalamic tract. Now to further dissect for the pappus circuit, you have to remove this structure, that is the caudate head, to see the connections of the thalamic nucleus further on. So once you remove the caudate nucleus, you start seeing the anterior thalamic radiations, and the anterior thalamic nucleus straight connects to the anterior thalamic radiation, which connects to the cingulum and then goes on forward by the cingulate connections to the cortex. So now you can see the whole pappus circuit has been dissected out. It is beginning here in the hippocampus, the fimbria, the fornix, the columns of the fornix, the mammillary body, the mammillothalamic tract, the anterior nucleus of thalamus, the anterior thalamic radiation going into the cingulum, which curves back completely and ends here in the entorhinal cortex, which then projects to the hippocampus. So this is the complete Papez circuit. And the Papez circuit, we then dissected it out. And there are two missing connections of the limbic system here. That is the olfactory tract and the medial and lateral olfactory striae, which also connect to the Papez circuit. Moving further, so we've seen one circuit, we've seen the Papez circuit. Now let's go on to see the supracallosal circuit. That is the circuit runs above the callosum. So when you dissect here, superiorly, you see a thin layer of gray matter, that is the inducium griseum. Within that, there are two striae, the medial and lateral longitudinal striae. What are these? The inducium griseum is the region where the hippocampal actually turns down in a C-shaped manner when the limbic system is formed. The supracallosal part of the hippocampus is invaded by the corpus callosum, and some part of it remains above, and that is the inducium griseum, which connects all the way down in this region to the dentate gyrus. As you can see here, the dentate gyrus and some fibers of the fimbria going above here in the subscleral gyrus, going above the corpus callosum and continuing as the inducium griseum and the lateral longitudinal striae. And they go ahead and connect in the subcallosal region that you can see here. So this is your supracallosal circuit. So we have seen two circuits. Then we have one connection, that is the striae medullaris thalami, that connects the septal region to the habenular commissure in this region. The next circuit is your striae terminalis, which runs in the interval between the caudate and the thalamus. So this is a brain specimen dissected showing the choroidal fissure on one side, and this is on the other side. So the striae terminalis runs between the caudate and thalamus and runs all the way in the roof of the temporal horn in this region, as you can see in this image now. So this is the corpus callosum, this is the thalamus, this is the caudate. The striae terminalis will run in this region and go all the way above in the roof of the temporal horn here to connect with the amygdala. So this is your dorsal amygdalofugal pathway. Now we've seen already three circuits. We'll see the ventral amygdalofugal pathway. So this is the basal surface of the brain. And this basal surface, the basal forebrain region, is an important component of the limbic system. So once you start dissecting here, you have the region of the substantia and immunominata and the nucleus accumbens. You start seeing the anterior commissure in this region. And this is your connection between the amygdala and the septal area. This is the diagonal band of Broca. The amygdala also connects to the midbrain to the brainstem by some other tracts. And this is the anterior commissure, which is an important component of the limbic system. As it has been dissected on both the hemispheres, it connects the temporal lobes on both sides and also the olfactory areas on both the sides by this frontal connection. So you can see here the anterior commissure running all the way on the lateral aspect of the temporal horn. It is also joined by fibers of the Mayer's loop, which begin here in the lateral geniculate body and go all the way just underneath the fibers of the anterior commissure to form part of the optic radiation. So this is the inferior view. Once you turn the brain and see it, you will see this. This is the IFOF, that is the first layer, followed by the temporal extension of the anterior commissure, that's the second layer. And the third layer is the Mayer's loop, and all three of them combined form the sagittal stratum. And this is another image that shows the anterior commissure going all the way on the lateral aspect of the temporal horn, which is in this region, and hugging the temporal lobes on either side. This is your region of the nucleus of Maynard, substantia innominata. So we have seen all the circuits. So the hemisphere has been turned slightly. You can see there are three circuits in this region: the supracallosal, the Papez, the dorsal amygdalofugal pathway. And you have another circuit in this region, that is the ventral amygdalofugal pathway. And these are the main limbic connections that connect the diencephalon and the prosencephalon. So now, how do you apply all these anatomical knowledge to surgery? So we have used this anatomy of the limbic system to perform our epilepsy surgery. And this approach to amygdalohippocampectomy was first described by Professor Goel 20-25 years back. We use an approach through the middle temporal gyrus, as you can see here. So a corticectomy is made in the middle temporal gyrus. You start seeing the hippocampus, the body, the head, the body, and the tail. This is the middle temporal gyrus, and the image has been upturned so that you can have an operative view. So once you remove the cortex in this region, you start seeing the temporal horn and the whole hippocampus with the choroid plexus in the temporal horn. This is the region of the amygdala in the roof of the temporal horn. And this is the amount of tissue that you remove. This is the amount of amygdalohippocampectomy along with the neocortex you remove while using this approach, as you can see here. Now, the most important point of this approach is we enter in this region. You can see here that these fibers are initially, the fibers of the IFOF, the anterior commissure, and the optic radiations are initially in the lateral, in the roof of the temporal horn, and then in the lateral aspect of the temporal horn. So there is this area here which is devoid of fibers. So if you enter the middle temporal gyrus, as described by Professor Goel, you straight enter into this region without causing any injury to the fibers in this pathway. So we have applied this approach to also medial temporal tumors. As you can see here, this is a huge medial temporal tumor in the region of the parahippocampus. You can see all the fiber tracks are displaced either medially or superiorly, and you can safely enter this region by making a corticectomy in the either in the inferior or the middle temporal gyrus, which will avoid injury to most of the fibers. And you can see the radical resection that has been achieved by this approach. This is another patient with a pure parahippocampal tumor, as it is going above turning into the cingulum. This is the region of the parahippocampus. Again, operated using an inferior temporal approach with a radical resection of the tumor. Here you can see that there are no fibers. This red thing is the tumor, and you can straight enter here and remove the tumor. This is a tumor in the region of the cingulate gyrus. And for this, you can see here, we've described this in another paper, that the cingulate tumors are bounded by the vertical group of fibers. And if you enter from the interhemispheric approach, there will not be any injury to fiber tracks. So that is how we have operated this patient, by using an interhemispheric approach. And these are some operative images after removing, this is the image after removal of the tumor. And this is the post-operative scan. So we've seen most of the limbic connections. There are some more limbic connections between the telencephalon, diencephalon, and the mesencephalon. We've already seen stria medullaris. There is fasciculus retroflexus, which connects the habenular nuclei with the midbrain. And you have the medial forebrain bundle, which connects the septal and lateral preoptic region to the tegmentum of the midbrain. So these are all of the limbic connections that have been anatomically demonstrated. Thank you very much.
Thank you very much, Dr. Shah, for such a beautiful and illustrative dissection. Professor Kyrillos is still here. Professor Kyrillos, can I please ask you to comment on the presentation of Dr. Shah? Thanks.
I was just going to write on the chat, what a fantastic lecture that is. So you gave me the opportunity to say it. It is a complex way. The way it was described was beautiful, made logic with some embryology behind it. But this is the way that complex anatomy can make you design easier surgery. So the more knowledge you know, the more simple your procedure should be. So I congratulate you on such a very beautiful lecture.
Thank you, Professor Kyrillos.
I think just a small tip for those participants who might not readily have access to brain to dissect. That's a nice software that's sold by Thema from Novinsky. It's called, it's like the 2,700 parts of brain and neck. What they have done is they have broken down each part of the brain, each fiber network, each cortical matter, each neck area into units, and you can, like a Lego, put the brain together and look things at 3 dimensions. And for those who might not have handy a dissection lab, and who are interested in epilepsy, functional neurosurgery, it's a good software to have. It only works on the Windows though. And I'm just trying to see whether Professor Grottenhuis is there. Prof. Grottenhuis, are you there? Let's see. But Dr. Shah and Professor Goel, once again, congratulations on this beautiful work, and I'm glad that it's on the YouTube for many of us to relook at it for many times. Any other comments for Professor Shah? Thank you very much. We are slightly running what do you call head of time, or we are running slightly like a jazz in our own way. So I'm going to first of all invite Professor Zileli, Professor Mehmet Zileli, to give us his lecture on scoliosis. In terms of Professor Zileli, I had the great pleasure of meeting him initially in Bangalore at the Spine conference that was organized by Dr. Komar Prasad and Timpapa Hegde back about 5 or 6 years. It has been a real privilege and honor to have known him, and he's a great lecturer, and so I think you'll find this a great treat. Professor Zileli, I'll make brilliant thanks. I'll make you able to share. Professor Zileli is from Turkey, from Izmir. He's also the chairman, co-chairman of the spine committee of the WFNS. He's been instrumental in spinal education all around the world, very active with the World Spine as well. Professor Zileli, it's a real honor to welcome you to the WNWC. Thank you, sir.
Thank you. It's a great pleasure for me to be with you. Your programs are really very nice, I must tell.
Thank you.
This topic I will talk this time is mainly a topic of orthopedic spine surgeons, but I will try to cover all aspects of scoliosis surgery. First of all, the description is this. Sagittal plane deformity is kyphosis. Coronal plane deformity is scoliosis. So we see in practice many kyphosis cases, especially in the older ages, but scoliosis may happen especially in the adolescent ages, and then degenerative scoliosis in the later ages. I will first present scoliosis classification, patient management criteria, and surgical options. If I have time, I can present something about kyphosis, but if not, I can finish it there. As a description, if the cope angle is more than 10 degrees, we call it as scoliosis. If it is less than 10 degrees, we cannot call it as scoliosis. It may be a mistake of films or a reflex movement of the column, vertebral column. There are mostly an associated vertebral rotation. This is the cope angle, and this is probably 70-degree scoliosis in this patient. There are terminology and meaning the etiology of the scoliosis. If there is a vertebral development anomaly, it is called congenital scoliosis. Most of them are segmental maturation problems. There are asymmetric spinal loads because of neuromuscular diseases. Sometime in the past we had after polio, but then nowadays we have because of progressive muscular dystrophia and other neuromuscular problems, neuromuscular scoliosis we call them. For unknown reasons, actually, we have idiopathic scoliosis, mostly in the adolescent ages. And we have a degenerative scoliosis or de novo scoliosis in the elderly people, together with other degenerative diseases. Most common scoliosis are idiopathic adolescent and degenerative scoliosis. If you look at the incidence in the young ages, adolescent scoliosis, idiopathic scoliosis is about 51% of all cases. Syndromic scoliosis is about 20%. Congenital scoliosis, 16%. Juvenile idiopathic scoliosis, 7%, and infantile idiopathic, 5%. Degenerative scoliosis, I don't know the exact incidence, but it's more common. Most of them can stay without any symptoms. There are also such terminology. In idiopathic scoliosis, there is no associated abnormality, no neurology, even most of the cases, no pain. If it is after 10 years old, the patient, it is called adolescent idiopathic scoliosis. If the patient is between 4 to 9 years old, juvenile, less than 3 years old, infantile. There is another terminology, early onset or late onset idiopathic scoliosis, meaning that it is less than 8 years or more than 8 years. We always want to see AP and lateral radiograms of the patients. In the AP radiogram, we measure the Cope angle, then major curve, greatest angle curve, minor curve, and most of them are the adolescent idiopathic scoliosis cases. Most patients are female, and mostly they have a right thoracic major curve. So there are even a trend that if it is a left thoracic curve, you must search for other diseases, congenital diseases, because left thoracic curve is unusual. Yes, this is the Cope angle. This is the apical vertebra. And this is the end vertebra. The curves most, the curve ends here. There is also upper end vertebra here. The neutral vertebra is this, and stable vertebra is this. And there is a central sacral vertical line. This is a line drawn on the AP film from the mid of the sacrum. It must actually it must conjugate with C7 vertebra. If there is a shift between this line and C7, so then there is an imbalance. So in radiology, we measure Cope angles by looking the end vertebra, upper and lower, for each curve. For instance, in this patient, there is a major thoracolumbar curve and minor thoracic curve. So each curve, Cope angles are measured separately. The coronal balance is a C7 mid-sacral line. Here you can see in this line. If it is conjugating with C7, there is no problem. If it is between plus minus 2 centimeters, there is no problem. But sagittal balance is this from C7, a gravity line must meet the promontorium plus minus 2 centimeters. If it is more than this, then there is a sagittal imbalance. Besides, we must also look at the flexibility of the curve. So we must take a neutral AP radiogram and right and left bending AP radiograms. As you can see here, with the right bending, one of the curves disappears. The other curve is still there. So then the disappearing curve must be flexible. The other curve is mostly measure curve. It is structural curve. And we can have another radiogram under traction. So then two persons apply a traction to the patient from shoulders and from the legs. So there are such terminologies, structural curve and flexible curve. Structural curves are decided by bending films, and major curve is always a structural curve. Minor curve may or may not be structural. Another thing is the measuring the rotation. So the vertebral rotation may be measured according to the Nash and Mu technique by looking at the pedicles. If you see both pedicles and parallel, it is a neutral, 0. But if one pedicle is on the side, the other is in this line, the grade 1. Grade 2 is this, grade 3 is this, grade 4. In the grade 4 and 3, the other pedicle cannot be observed. The most common used classification in adolescent scoliosis is Lanke classification. After measuring the cope angles of all curves. Here you can see one curve upper thoracic, one probably major curve in the thoracic, and one minor curve in the lumbar spine. After measuring these, you can classify according to the Lanke in 6 groups. The Lanke 1 is main thoracic, Lanke 2 is double thoracic, Lanke 3 double major, triple major, and thoracolumbar-lumbar and thoracolumbar-lumbar main thoracic. These are according to the structural measure curves and non-structural curves. I will give you some examples. This is Lanke 1 main thoracic curve. As you can see, the deformity surgeons look at the films as they are on the film, as if they are on the film. Actually, the heart is on the left. This is left side, this is right side. So there is just one thoracic curve, main thoracic, Lanke 1. Lanke 2 is double thoracic. There is one major thoracic curve and one minor thoracic curve. Lanke 3 is double major. So then there is one lower thoracic curve and one lumbar major curve. So double major. Lanke 4 is triple major. There is one upper thoracic major, lower thoracic major, and lumbar major. So this is Lanke. Another thing that we must look at the film in the films and in the examination is the shoulder imbalance. If there is no imbalance, the correction is easier. If there is shoulder imbalance, we must take care of that. Another thing is the pelvic imbalance. If there is a pelvic tilt, you can see one of the iliac wing is in the up, that according to the other one. Another concern is the maturation evaluation. So if the adolescent patient has got past her menarche. Most of them are females, I have said before. So research science, looking at the iliac crest ossification centers or Y cartilage in the wrist, and sexual maturation characteristics, we can evaluate the maturation. If the research is less, this is the research sign in the pelvic radiogram. If the ossification is on the tip of the iliac crest, it is research 1. If it is going up till here, it is research 2, research 3, 4, and 5 is all iliac bone apophysis is ossified. So this is most mature age. It means these are less mature. So if the risks are 1 or 2, we will expect that the scoliosis will progress by the time. If risk is high, we don't expect it will progress. If you look at the treatment options, according to the Cope angles only, we can say that if the Cope angle is less than 20 degrees, we can just follow the patient. Between 20 to 30 degrees and more than 5 degree increase in follow-ups, we can use a brace. Our surgical indication is if it is more than 45 degree only and not controlled with brace. But you can still have no surgery option if the patient has too much mature, I mean research 5, and more than 45 degree angulation, because you will expect no progression of the curve. So if you look at the curve degrees and research together, these are the options. If it is less than 25 degree, follow. If it's between 25 or 45, brace. If it's research is much, brace or follow up. However, in case it is more than 45 degree, surgery is the option. Bracing is a live option for non-surgical management of the scoliosis. That probably somebody will question if there is a place of exercise. I must tell you that some or most of the spine surgeons do not believe that there is a effective exercise in scoliosis of adolescent patients. But especially physical therapists and some other surgeons still use exercise. Brace indication if the Cope angle is between 25 to 40 degree and skeletal maturity incomplete. If more than 20 degree increase of curve in the regular follow-ups, and the research 0 to 2. However, brace contraindication is if the curve is more than 45 degree, if the research is too much, and if there is thoracic hypokyphosis, and if there is a upper thoracic curve, which you cannot affect the curve with a brace, then you must not apply a brace. Actually, for a kid between 9 years, 10 years, or 11 years old, bracing is not easy thing. there are different types of braces: Milwaukee brace, Boston brace, Charleston, and dynamic braces. Most people apply 20 to 24 hours a day, 4 to 6 months duration, until skeletal maturation occurs. And some patients may not tolerate braces, and if she is not tolerating, then you can stop it. What about the surgical options? The history for adolescent scoliosis were many years before, were just casting. Then dissection systems have been started to be used. Harrington rod system is one of them, a very historical one. Then segmental systems have been developed, especially by French orthopedic spine surgeons. CD hooks, Lucu sublaminar wires were very nice options. Then pedicle screw systems were developed. So then nowadays there are few spine surgeons using wires or hooks. Instead, most of them are using pedicle screw systems. I will give you some examples of that. And another thing is the aim of the surgery, mostly cosmetic in the adolescent scoliosis. Actually, mostly they do not have any pain, no neurology. The reason they want a surgery, or the parents want a surgery, is that the high degree of scoliosis causing a cosmetic problem. Severe curves may diminish respiratory function, thoracic and thoracolumbar curves, but it happens after 90 degrees or more. A curve may still progress in adult ages, after adolescence, but the progress is very slow. The balance problem in sitting and standing in lumbar curves is one of the aims of the surgery, and pain may happen in lumbar curves, but it's not very common. Surgical principles: do not retard surgery after maturation, and the sequence of surgeries is first release, then correct, and then fix. We must avoid sudden column lengthening, and we must avoid over-distraction. And these can cause neurologic problems. So sudden lengthening or over-distraction should not be applied in our current knowledge. Surgical methods, if you look at them, posterior instrumentations, anterior instrumentations, or combined techniques may be used. Although I must tell you, most of the anterior or combined techniques are now a historical thing. Most spine surgeons are using only posterior techniques now. What are the advantages? We are more familiar with that: better control of sagittal plane and pulmonary functions. Disadvantage is we are injuring the posterior muscles. We are getting more motion segment inside the fusion. Lesser hump correction depends on segmental rotation, and more infection rates. What about the correction methods? There are many correction methods, but main basic ones are these. One is the distraction compression. Where do you distract? You distract on the concave side. You compress on the convex side. You can apply derotation and rotation, and you can apply translation and cantilever reduction. I will explain them a bit. First of them is the distraction compression technique. This is the principle: distraction on the concave, compression on the convex side. And this is one of the oldest cases. I have used hook systems and applied distraction and compression on it. The rotation is an easy thing. If you place your rod in the according to the curve, and then you just turn 90 degrees of it, and then you are then creating the apex of the curve as a kyphosis. This curve turns after 90 degrees to a kyphotic curve. So 90-degree rotation of the rod is an easy technique, but it is possible most in major curves or one curves only. Translation is another maneuver. You can place one rod and then pull the apex of the curve to the straight or neutral rod. You pull that apex to the rod. Cantilever reduction is placing two rods on the more thoracic region, and then you apply big forces to the rods. You correct it and fix in the distal screw heads. This is cantilever reduction. Another technique is in situ bending. In this technique, you can bend the rods to correct the deformity after applying your rods on all screws. However, there is a main disadvantage. Too much stress on bone and implant must be applied. So you can break something. You can fracture something. So a spine surgeon has done a correction method, segmental correction, distraction and compression and translation in each segment in sequence, so then you don't produce too much forces in one time. I will show you one example. You can start from the apex, go down, and in each segment you apply distraction and compression forces, and then together with some cantilever maneuver and segmental correction, you then achieve a good correction. And you can, in some cases, you must be applying different maneuvers at the same time. This is an instance, cantilever maneuver and derotation at the same time. What about release techniques? Actually, I have said before, we must first release, then correct, then fix. There are posterior facet resections, the so-called Smith-Robinson type of osteotomies, rib facet release, rib osteotomy, vertebral osteotomies, and anterior releases. Anterior releases may be done by a thoracotomy. Actually, anterior instrumentation, derotation, translation, and compression, mostly from convex side can be done, especially in the flexible curves. But nowadays, very few spine surgeons are using those techniques because you can cause some respiratory problems. Here, one example of anterior release and anterior instrumentation only. Anterior instrumentation disadvantages: technically difficult. There is a kyphosing effect and more pseudoarthrosis, as I said before, mostly abandoned. I will try to make a case discussion to show how my previous talking was applied in this case. This is a female patient, but she came to me at 23 years old, deformity diagnosed 10 years ago. She was a neglected adolescent scoliosis, actually. And the cup angle was about 110 degrees with right thoracic scoliosis. Again, right thoracic, this is heart, left. She has additional sickle cell anemia. So then anemic patient to get a very long surgery is a burden. And these are my measurements before surgery: cup angle 110, apical end vertebra is T7, caudal end vertebra is L2. This is a major curve on the thoracic, and minor curve is on the lumbar spine. There is no other curve on the upper thoracic. Pelvic tilt, there is no pelvic tilt. Shoulder imbalance, there is no shoulder imbalance. Neutral vertebra is L3, stable vertebra is L4, and apical vertebra is T10. So my plan was to make an osteotomy here because she's an adult patient, a neglected adolescent scoliosis, and one osteotomy here, another one, a smaller one is here. I planned this. So 2 units blood taken 1 day before surgery to give during surgery. We did 2 osteotomies at T10 and T8. On convex side, T9 and T10 ribs were cut. And on concave side, T8, 10, and 9 and 10 ribs were released close to the transverse process. So this led us to achieve a correction. Otherwise, this site is very rigid. Correction is provided by translation and some distraction on concave site after insertion of 2 rods. Approximately 70% reduction we could achieve. Total duration of surgery was 7 hours. Total bleeding was 1400 milliliters. 5 unit blood were transfused, 3 unit plasma transfused. This is the postoperative films. This is the postoperative films and pre-op and post-op photographs of the patient. I will talk something about the infantile and juvenile scoliosis. In those ages, growth-friendly techniques must be applied, like casting, rod lengthening, and minimum segment fusion. There are growth-friendly techniques: compression-based tethering and stapling, guided growth, leukotrolley, Sheila, and destruction-based growing growth and vector techniques. So actually, spine surgery is so a large area of applications. I must tell you that most of these surgeries are being done by pediatric scoliosis surgeons. I have not too much experience on that. I will give you some examples. This is the stapling. Yes, this is stapling. It can be applied by a thoracoscopic technique and retroperitoneal approach. This is tethering. Actually, you place screws by a thoracoscopic technique, and then in between the head of screws, one elastic band that is on the convex side, so it tethers the vertebral bodies. So then on the convex side, the growth of the vertebral column is restricted. However, on the concave side, it may grow. So then this is another growth augmenting technique. Growing rod technique is another thing. You can place a rod, and in 6 months or 1 year intervals, you can lengthen the rods by a magnetic device. You then make a superior dissection only, preserve interspinous ligaments and facet joints, contour rods according to the sagittal curve, and this is the application of magnetic lengthening. Another one with 2 rods. In some instances, even 1 rod can be applied. On the upper end and lower end, you can use even screws or hooks. In scoliosis, the goals of surgery: normalize sagittal and coronal spinal contours, prevent further progression, fuse the least number of segments, not all the segments, protect and decompress the spinal cord and nerve roots, improve cosmesis, and obtain solid biological fusion, and avoid perioperative complication. These are the goals of surgery in scoliosis. But as I said before, adolescent idiopathic scoliosis is mainly done for cosmetic reasons. The children at that age tolerate it well, and the complication rate is quite low. Actually, most neurosurgeons now are dealing with the degenerative de novo scoliosis in the elderly people, which are quite difficult to handle. Congenital scoliosis is more difficult to correct. Patients do have some neurologic problems. Great difference with adult degenerative scoliosis, because in adult ages, osteoporosis, premorbid diseases, and high complication rates are facing us. Then I will just give one table. Actually, I want to use this term, complex lumbar spine stenosis, if a spine stenosis patients have degenerative listhesis or scoliosis or previous lumbar spine surgery or postoperative adjacent segment stenosis and radiological instability. Those cases may need a fusion surgery, but then our time is okay. I think we must not give that. But the problems of adult degenerative scoliosis are mainly the osteoporosis. Those patients are having osteoporosis. However, in adolescents, they do not have any osteoporosis. More deformity, need longer fixations, more comorbidities, more complications, and outcomes are less satisfactory. Okay, I can stop here. I can forget the remaining. Thank you for listening to me.
Thank you very much, Professor Zileli. That's a fantastic talk, taking us through this complex field. As you mentioned, many neurosurgeons don't do scoliosis surgery, but I think understanding of scoliosis surgery is important in terms of putting our patients with scoliosis in perspective, how best to treat them. And also, I hope that more neurosurgeons will take it up. There are a couple of questions for you. You might have covered it. It was from the early. This is from Dr. Mawat. He's asking incidence of neurological deficit in scoliosis surgery and how important is the neuro monitoring?
Yeah. There are very nice studies, especially Scoliosis Research Society have done a multi-center study looking at the value of neuromonitoring, but they found that in most of the instances it's not necessary. However, because of malpractice issues, many deformity surgeons use monitoring during surgery, although mostly there is no incidence. Another issue is that in the past, we have used many destructive measures like Harrington rods, but nowadays we don't do it. So distraction is more risky for neurology than compressive or other corrective measures. Another one is we are asking too much MR images before surgery, even for the adolescents. I don't think it's necessary if there is no signs of congenital disease, but we are looking at we are ordering too much MRs, so then we are seeing that there is no intraspinal pathology like low conus, other things. If there is any, we must first manage this, treat this, and then correct deformity.
Thank you. There's a question from Dr. Kumar. He's asking you, in your practice, which side do you put the rod, on the convex or concave side first? Which side you put first?
Convex side.
Convex side. And in terms of another question from Dr. Kumar is that when most of the adolescent cases need long segment fixation, fear is it will hamper skeletal growth. How to balance correction versus skeletal growth, I presume.
Sorry, how to?
Whether the segmental fixation hampers skeletal growth. How do you balance that?
Yeah, it's not easy to balance it very well. Yeah, there are always concerns that we must fuse as minimum as possible, but we must fuse some levels, especially at the apex of the curve.
Thank you. This is a question from myself as well as Professor Goel. I'm just going to take it one step at a time with this question because it's a multi-level one. I often get patients with sent from orthopedic spine surgeons. My practice is pediatrics, that let's say that they have a patient whom they need to correct a scoliosis, but they only have syrinx but no Chiari or no tethered cord. In that case, what's your advice, Professor Zileli?
If there is no low conus, you can still correct deformity.
You can still correct.
Syrinx, it may be actually, I guess Atul is trying to ask, hi Atul, trying to ask if there is any craniovertebral junction problem. If there is, yes, we must first solve it and then look at the curve. He has reported some cases that after correcting the craniocervical problem, some kyphosis or scoliosis are improving.
Thanks. But what about if it is just pure syrinx? Sorry if I missed. If it's just pure syrinx and nothing else, you will still go ahead with and correct the scoliosis,
Right.
would you?
Right.
Okay. Thanks. Thank you. So thank you very much, Professor Zileli. It's once again fantastic lecture, and I think once again having it in the YouTube is great
Thank
opportunity.
You. It was
to
a great pleasure for me.
Thank you, sir.
Thank
Thank
you.
you very much. I'm just going to ask Dr. Ramesh to upload his presentation, please, Dr. Ramesh. Thank you, Dr. Ramesh. Dr. Ramesh is coming from Rainbow Children's Hospital in Hyderabad. Dr. Ramesh, do you want to share with us your experience of role of neuroendoscopy in your practice? Thank you, sir. You have to unmute. Good.
Yeah.
Thank you.
Good afternoon, everyone. I'm Dr. Ramesh from Hyderabad, working in Kamneni Hospitals and Rainbow. I'm here to present role of neuroendoscopy in management of hydrocephalus, our experience in last 2 years. As we all know, hydrocephalus is water in brain, and the management of hydrocephalus has evolved over 3 phases. Initial phase, pathophysiology was not clear, so medical or surgical was hopeless. In the second phase, physiology of CSF was slowly understood, but all the other treatment modalities were unsuccessful. In the third phase, after development of Shunt system, its surgical role has played a significant dominant role. More than 400 types of shunt available, but still now there is no ideal shunt. Best shunt is not to have a shunt actually. Now, for all practical purposes, we have classified into communicating and non-communicating. We see that communicating is a block at arachnoid granulation and is managed by shunt. A non-communicating block is proximal to arachnoid granulations, and it is usually there comes the role of neuroendoscopy. But in these days, we are managing communicating also with shunt, and there are new theories proposed. Even though neuroendoscopy started way back in 1910 by Spina, by using cystoscope, he has fulgurated choroid plexus, which was refined by Dandy called as choroid plexectomy. First ETV was done by Mixter in 1923 in a kid with a urethroscope and a probe. Neurosurgery is a continuous evolving process in the same way the neuroendoscopy. But neuroendoscopy never achieved popularity because of poor scope, poor illumination, insufficient instruments. Ongoing refinement like development of cold light source and miniature camera endoscopes helped in development of neuroendoscopy. These days, neuroendoscopy has become standard of care in management of hydrocephalus. The procedures usually done at our center are endoscopy, third ventriculostomy through floor and lamina terminalis, endoscopic septostomy, endoscopic aqueductoplasty, and transaqueductal fenestration of fourth ventricular membrane or arachnoid cyst in the posterior fossa, or managing multiloculated hydrocephalus. As we all know, standard ETV is done through Cocos point, precorneal burrhole incision. We have evolved from a vertical incision to a flap-based incision, and ETV is successful in high success rate is seen in aqueductal stenosis, especially in acquired, but very less success rate is seen in post-hemorrhagic or post-infectious hydrocephalus. Coming to illustrative cases, this is the aqueductal stenosis kid presenting with excessive cry and vomiting. After entering into the third ventricle through the foramen of Monroe, see the membrane was tough, so cautery was used to perforate, followed by Fogarty catheter for French here for dilate and to dilate the stoma. And end point of third ventriculostomy is to visualization of the naked basilar artery. I hope you can visualize. You can see here this visualization of naked basilar artery is the end point of third ventriculostomy. Sometimes there are Lilliquist membranes which has to be perforated so that it can lead to functioning of the stoma. If foramen of Monro is large, there can be a single shot view of both third ventricular floor and through the aqueduct as this. But in this case, you can, as foramen of Monro is not so grand, you have to see in two segments. This is through third ventriculostomy and this is the aqueductoplasty. Especially when foramen of Monro is narrow, see, this is a case with child presented with altered sensorium. We have to go inside due to raised ICP. When we entered into the third ventricle, we can see some blood coming and there is a contusion in the fornix, for which we have changed it to the, using the same sheath, we have changed it to the flexible neuroendoscope. And the third ventricular floor was perforated using the cautery and also dilated with Fogarty. Because as it is a flexible neuroendoscope, we can use only 3 French Fogarty. At the end, child it didn't require any VP shunt and child improved very well. This is a illustrative case showing aqueductal stenosis, which improved with aqueductoplasty. Usually, we attempt in short segment. This is another kid we presented with isolated lateral ventricle dilatation, especially right side. Intraoperatively, we can find there was a choroid plexus blocking the foramen of Monro, which was just managed with a endoscopic septostomy, communicating to the left lateral ventricle, which was in communication with others. As you can see, post-op scan showed normalized ventricles. This is a child where VP shunt was done earlier. We can see the ventricular end is disconnected from the peritoneal end, and it is away. So we are removing the ventricular end. We have removed the ventricular end with a grasping forceps and also done third ventriculostomy. So just removing the debris. Child did not require any shunt afterwards. We say non-requirement of another CSF diversion procedure as a success of the procedure. This is a child with diagnosed with tuberculous meningitis and hydrocephalus, which was initially managed with a VP shunt at other hospital. Now presented with raised ICP features. We underwent third ventriculostomy. We can see the well decompressed ventricles. But rigid endoscopy has widely used in the management of hydrocephalus, but it is limited in areas which are not in straight line with the operative field. So there are blind areas for rigid neuroendoscopy. So it is adjuncted by the flexible neuroendoscope because of its maneuverability. As we have already seen, whenever there is small foramen of Monro, we can do it through the rigid and flexible endoscope, keeping rigid endoscope in place. Having maneuverability around 90 degrees and around 180 degrees, it is added advantage to the managing hydrocephalus. But in all, rigid endoscope has a better images, better resolution, wider view, better color, better light transmission, and also because of stability had a good hand-eye coordination. When coming to advantages of flexible endoscope, because of its small diameter, its steerability, and you can be used through the same sheath and same burr hole, not requiring another thing. But only disadvantage of rigid endoscope being the less maneuverable, and if you want to use rigid endoscope, they have to for both aqueductoplasty and third ventriculostomy or posterior third ventricular lesion excision, we have to use separate burr holes and according to pre-planned. But in flexible endoscope, same burr hole can be used, but the problem is narrower view and small working channel and poor image. That's what I was explaining. Use of flexible endoscope in transaqueductal procedures, third ventriculostomy if in case of small foramen of Monro, or translaminar terminals third ventriculostomy, especially standard third ventriculostomy cannot be done, and visualizing or biopsy from the posterior third ventricle. This is a case of where third ventricular floor could not be identified, whether due to arachnoiditis or due to vascularity or narrow prepontine system or due to third ventricle because of the non-visualization of third ventricular floor, for which we use flexible neuroendoscope to do a translamina terminalis endoscopic third ventriculostomy. You can see the lamina terminalis which was open. End point of translamina terminalis third ventriculostomy is to visualize anterior cerebral arteries. And we have published way back in 2016. And out of 8 patients we have done there, it was successful in 6 patients. And it's always a feasible alternative to the standard third ventriculostomy. Nowadays we have become whenever we feel third ventricular floor is thickened or there are multiple membranes in the third ventricular floor, chances of failure, or then we always adjunct with a third lamina terminalis, third ventriculostomy. This is another case with an extra fourth ventricular arachnoid cyst compressing the fourth ventricle leading to the hydrocephalus. This is using the flexible neuroendoscope. You have entered through the aqueduct, visualizing the arachnoid cyst, which was punctured, fulgurated, and ventricular cystonostomy was done. Post-operatively, child improved well with opened up sulcal faces and had started improving with milestones. This is a case of fourth ventricular outlet obstruction. Child was admitted for surgery, but child deteriorated in the night, for which we have taken up. Sorry for the poor video because the biomedical was not there and recording was to be done by a non-medical person. So here we entered into the aqueduct. We can see the fourth ventricular membrane, which was obstructing the flow near the choroidal plexus, which was perforated using the 3 French Fogarty catheter and also dilated with it. So this is a retrospective study. Duration was 2 years. Done at Kamneni and Rainbow Hospitals by a single surgeon. Around 52 ETV were done.
Dr. Ramesh, you have got 5 minutes, so thank you.
Finishing, sir. So other various factors study were etiology of hydrocephalus, postnatal complications, age at ETV, head circumference, and previous shunt. Most of the kids were equally distributed within 2 first year and 2 years, 28 in first year and 24 in second years. Most of the kids were males. Etiology of hydrocephalus were varied, including from aqueductal stenosis, posterior third ventricular lesion leading to obstructive hydrocephalus, communicating hydrocephalus, and with post-infectious hydrocephalus also. Preterm IVH. Around 10 children had postnatal complications. Previous shunts were done in 8 children, which were presented with shunt failures. Interesting point is, more out of 10 patients in less than 6 months, 6 patients were successful. When we started doing neuroendoscopy, it was that it's like ETV or endoscopy is not useful when less than 1 year. Now we can see that with increasing use of all adjuvants, we can increase we could have the good success rate. As we all know, aqueductal stenosis have a higher success rate than other etiologies. Postnatal complications were significant factors in our study. Postnatal complications are usually post-infectious hydrocephalus. The baby was in the ICU for a prolonged time, leading to the meningitis and ventriculitis leading to hydrocephalus. So, coming to out of 52 children who underwent ETV, 33 had a success with not requiring another series of diversionary procedure. That is 64.1. ETV should be offered in infants and children less than 1 year. ETV was successful in aqueductal stenosis around 75% of cases, but in communicating hydrocephalus are only 39% of cases. No surgeries without complications. We have seen significant intraoperatively bradycardia, bleeding in floor of third ventricle, delayed recovery. For postoperatively CSF leak, pseudomeningocele, wound desiccation leading to exposure of the reservoir. Sometimes the reservoir is completely into the ventricle, including in our study, ETV was successful around 64% of cases. In our study, postnatal complications and infections are the poor prognostic factors. Success of ETV in less than 1 year or 2 years is equally comparable to adults. It should be offered as a first line of management for shunt-free survival. ETV should be offered in previously shunted children also. Sir, is time there?
I think we are on the time. I think if we can go to questions, if that's okay. Is that okay with you, Dr. Ramesh?
Yeah, sir.
Dr. Ramesh, that was a fantastic presentation. Certainly beautiful videos. You covered a really nice gamut of uses of the endoscope, both rigid and flexible. I will, while the questions come from the others, I was certainly liked how you did that lamina terminalis opening. My question is that how far back you go to get in terms of the burr hole to enter so that you can do the lamina terminalis? Is there a danger of going too backwards into the motor area?
No, sir, through the same burr hole. When you have a flexible neuroendoscope, we keep the sheath in the place near the foramen of Monroe, and through that we only remove the rigid endoscope. Through that, flexible endoscope is passed, so it will help in anchoring the flexible endoscope also.
Okay, and how much always the worry with endoscopes is that when you are trying to get a good view, that as much as you can use the flexibility, how much of angling is happening on the brain? Have you had any post-op MRI scans to see how much brain edema or gliosis after these procedures? But I certainly like it, but I just wanted to know.
Yeah, sir. Actually, in initial stage when we were learning curve, children and adult around 10 years, 12 years, they're complaining of diplopia, especially in lamina terminalis ventricularis, where we always rush on the optic chiasm to open up. But with the time and learning curve, we are able to do the translamina terminalis without injuring the optic chiasm.
Thanks, thank you. Certainly, thank you for your very honesty about your whole presentation. Dr. El Gamal, do you have any comments, sir?
No, it was a great presentation. Actually, the role of neuroendoscopy in treatment of hydrocephalus is very, very wide, and the spectrum of its users is too many. And the introduction of flexible endoscope makes it also very user-friendly, as they say. It is the standard of practice in our patient treatment of hydrocephalus, especially obstructive type in children. The only thing that we face is the preterm low birth weight children when they have obstructive hydrocephalus due to the aqueduct stenosis. We found the success rate is not great in these cases, and we opt to shunt them from the beginning. However, endoscopy is as I said, it is one of the best options in treatment of obstructive hydrocephalus.
Thank you. In UK, we don't use flexible endoscope. This was relating to the mad cow's disease. Do you use a flexible endoscope in your practice?
If you are asking the question to me, I'm using the rigid endoscope, but to the presenting neurosurgeon, what do you think? Do you use flexible for every case, or just you use it in certain cases?
Dr. Ramesh, I think it's a question for you. Do you how often do you use the flexible, and how often do you use the rigid?
So 90% of our work is done with rigid only, sir. When we feel that ventriculostomy, all the other things is not helpful, and when we want to go through aqueduct, massa intermedia is obstructing narrow foramen of Monroe, and standard third ventricular floor is not correct, we adjunct all other options with rigid one. We don't promote flexible as a standalone because of lesser image quality, we only small working channel.
Thank you. I think certainly, no shunt is the best shunt, and endoscopic procedure, if it goes well, it's fantastic. But I think, I think we can have a whole day discussion about that. But certainly, I don't want the audience to think endoscopy you know,
No,
the
Shunt
shunt
always
is
have a role.
the shunt is, and
is
also if you are going to
irreplaceable.
do endoscopic operation, you really have to monitor the patient very carefully for CSF leak, failure. It can't be an operation that you do and let the patient go, and then you have to have very close follow-up, head measurements, etc., etc. So, but fantastic talk, Dr. Ramesh. Thank
I
you very
really
much.
accept that comment, sir, because whenever the people come from rural India, we, even though it is acute ductal stenosis, we don't offer a endoscopy because they don't usually want to come for a follow-up. Whereas the educated patients who we see, these are the symptoms and signs of raised ICP, you have to be careful. Then we offer them, we tell them clearly options, and shunt always have a role. But having neuroendoscopy, you should try first.
Thanks. Thank you very much. Well done. Thank you. So thank you very much to all the speakers for a fantastic session. We had the lecture from Professor Goel. As often, you know, he moves the paradigms again and again. For one person to do that, I think what he talked to us about degenerative surgery and aiming more at the facets, I think, you know, this is probably way ahead, but I will look forward to other groups reporting as well. But I think it's everyone well worth reading. Then Dr. Shah gave us an absolutely beautiful talk to us on the dissection of the limbic system. I think that will be a classic, and we will review it many more times. Professor Zileli gave us again a masterful exposition on scoliosis surgery, which, as I said, I hope most neurosurgeons will do, but otherwise better to understand it. And certainly you will be get referred by the orthopedic spinal surgeons, patients with Chiari and syrinx and low-lying corners, and other way around, you will refer patients to them as well. And so that was fantastic. And then Dr. Ramesh gave us a great lecture talk on his experience of endoscopy. So as we come to the lunch break, I call it lunch break because it's lunchtime here. I know that many of you are joining all the way from Indonesia to Chile. We have a fantastic session in half an hour, starting with Professor Andreas Unterberg, Professor and Chairman of Neurosurgery at the famed Heidelberg Department of Neurosurgery, on the current state of management for high-grade gliomas. Then we have got Dr. Komar Prasad giving us a lecture, a talk on from Bangalore on carotid endarterectomy. Then we have another keynote lecture from Professor Khan, Tariq Khan, who's the chairman of the neurotrauma committee of the WFNS, on a role of current status of decompressive craniectomy on head injuries. And then we have a talk on the role of web education during the pandemic from Dr. Noor ul Huda Maria from Pakistan. So, you know, we have a fantastic session. So please take some rest. So we will rejoin in exactly 27 minutes. Thank you very much. Thanks to all the speakers again.
Hi, Naren.
Hello, Professor Unterberg. How are you, sir?
Fine. How about you?
Oh, very well, thank you. We had a great session.
Sitting?
Sorry?
That's it. Do you have a screen behind you?
Yes, yes.
I'm sitting in my office.
Yeah. Well, it's nice to connect with you by the Zoom. It would be lovely to actually have it in person, of course. But
of course, yes.
But I remember coming to visiting you. You know, the days of airplane and quick travel. I remember when I wrote to you, and then Dr. Haba sent you an email. I said, "Can I please come?" And then picked a plane and came a couple of days later, which is all taken for granted. Then now, it's amazing. So we had a great.
Painful. So painful.
Oh, it is. It is. It's. I mean, I think, to be honest, we are lucky at the moment. The doctors at the moment. Yeah, slightly lucky at the moment because our jobs are secure, but you know the people, many people, you know, they are all very worried, and we don't know where it's all going to go, but have to be positive. But I thought in Germany they have had a good control. How are things?
Well, here in Heidelberg, the situation is moderated, I'd say. You know, we have some cases, and there are some patients on the ICU ventilated and on ECMO treatment, but not many.
Not many.
Just a few. And there is still capacity. So we are running neurosurgery as usual.
Wow,
at about 90%, 95% or so.
Wow.
But during the lockdown in March and early April, we had to close half of our ICU, and also to send 2 of our physicians, registrars, to treat COVID patients, you know.
Wow.
But now it's better, and we are running all theaters at the moment.
Excellent.
Who knows how long, you know?
I know. I think one has to be prepared that everything will end tomorrow, and everything will not end for a very long time.
Yes.
So what I'm going to just go and do is I'm just going to make some announcements on the
let me introduce somebody who you also know.
Oh, is Christine there? Hello, Christine. How are you?
I'm fine, Aaron.
Oh, no, fantastic to see you.
Good to see you.
You know, we were so close to going to that. To Mysore.
Go to India.
To India.
Exactly. To be honest, you know,
very relieved actually.
Exactly. Going to Mysore was my childhood dream, and you know, and even
I would have loved to go there, but my husband was very relieved.
I think you
cancelled.
You were hard. You were even more harder than me. You were like, you know, I don't care COVID. I'm going.
Exactly. You're not allowed to.
I think it was the government that you stopped.
It's a pity.
But we will go. We will go.
Exactly. Good to see you on the screen, online.
Exactly. You know, pleasure's mine. Pleasure's mine. Yeah. We had a really good morning session, and the afternoon session looks fantastic. I'm just going to go and make some announcements, and so I'll be back in a second. Is that okay? I'm still here, but I'll just go and some announcements.
Just to make one quick question. We would like to load up the presentation.
Oh, sure, sure.
How can we do that?
You can do it now. If you see below, it says share screen.
Yeah,
yes,
it works.
Good.
And now just hit this one.
Yeah.
Then you have to hit.
Okay. Yeah, I can do that later on.
Exactly.
But you can try it. That's fine, and we can.
Yeah.
Yes, absolutely fantastic.
Perfect.
You can leave it there. That looks fantastic.
Okay.
Oh, brilliant. So you got 9 minutes. You know, I told you I'm more German than German.
So Naren, you look official, and I just put on my tie, which I'm not used to anymore.
I did tell you I'm more German than German. I spent about 20 years traveling in Germany. So what do you call? So I'll lovely to see you, and really look forward to your lecture. So I'll just go and make an announcement that you will be starting soon.
Give us an idea how many people will be listening. Approximately.
I think from this end it will be about somewhere between 50 to 100, but it's also being transmitted on the YouTube, and the people from Facebook can join the YouTube as well.
Oh, okay.
And it's been recorded on the YouTube, if that's okay with you. It's not
fine with me, yes.
Okay, so then it can become a nice reference, so for people to go back and look at it. So I think, and it automatically.
Unfortunately, I can load it up only once. You know, this is in former times you could travel with such a lecture.
Oh yes,
all year round. You know, 20 times.
Yeah, absolutely right.
No copyright though.
You can go with one lecture from across the world, and now it is a bit difficult. I have my craniosynostosis lecture. If I give once, I think I'm done. I'll just be back in a second. Thank you.
So, jetzt können wir da unten. Eigentlich könnten wir doch mal. Stumm schalten. Da haben wir noch einen Wecker. Ja, muss für alles vorbereitet sein, oder?
Das darf man nicht mehr nennen.
47 sind da oben. Okay.
Stimmt, da sieht man so auch die Teilnehmer.
Oh, das ist doch schon gar nicht so übel.
YouTube-Channel. Dann muss Muss man das ja auch gar nicht heute anschauen.
Nein.
Können Sie dann in der Badewanne machen.
How is the medical school doing, Professor Unterberg and Christine? Are the medical students allowed to come to your ward?
Not to the ward.
No.
Most of the, let's say, lectures are given as digital meetings, you know, webinars or so. At the moment, there is no practical education, no training on the ward.
Wow. I had 2 German medical students wanting to do elective like the old days. I said, what do you call, I'll check with my administrators, but even our medical students don't come to our wards. I haven't seen them for ages now. And it's a bit worrying because for them as well. And, you know, even when we studied so hard as a medical student, it took a long time to get it into the system, into the culture. So kids not spending time with the patients is always hard. And now, what about traveling to different cities in Germany? Is that restricted, or is it you are otherwise?
No, you can travel freely, but
okay.
Yeah, within Germany, it's not a problem.
Okay.
But to go out of the country and come back, then you have to go on quarantine.
Or you automatically have to go on quarantine?
Not automatically, but from most of the countries, even from the EU.
Oh, wow.
And for example, if you travel to Switzerland and you come back, you have to go into quarantine, you have to have corona testing, and then the earliest to go back to work is after 5 or 7 days.
Okay.
Some parts of the country even 10 days. And this is also, since we are a federal state,
yeah,
you know, it's depending on the state you're living in.
Yeah, that's quite a lot. But certainly, I think Germany has the least cases, and I have to say, you know, in the world that has been going mad everywhere, you are quite, you know, I don't know, you know, usually not necessarily.
We are doing quite well compared to other countries.
Yes.
Not perfectly, but quite well. So we don't have to complain. But maybe this is due to German discipline.
I think so. I think you have all pulled together, and actually you have a very good leader. You know, one person who's certainly respected around the world. You know,
he's very cautious.
Yes,
but, and this is not really. This is not my 100% opinion.
Yes,
it should be a little bit more liberal.
Liberal, yeah, absolutely.
But I mean, the population, it's very, very different. You know, if you talk to patients and to people on the street, some of them are extremely cautious and others are not. So it's, of course, also depending on your age and the situation.
That's great. Prof, so that people can see you, is it okay for you to just drop the presentation just for the second so people, and then I will introduce you, and if you unshare for a second the video, and
here we go.
And so everyone, you know, it's nice to have the human side of things. Prof, how's the German Neurosurgery Societies doing?
I think they are doing also, the society is doing well. And I mean, we don't have direct contacts to each other. I mean, everybody is somehow constricted to their own city. And our annual meeting was also a digital meeting, one of the first digital meetings in Lübeck. Nobody was there, but the meeting was in Lübeck. It was in the cloud.
The cloud. So
and
you got.
We had the first members meeting, you know, and elections, digital elections. And this was also a legal problem that could be solved.
You have to always have elections. So thank you very much, Professor Unterberg. I'll just introduce my co-chair, Mr. Lowe, who's just joined, Mr. William Lowe. So welcome everyone to this afternoon session of the first World Neurosurgery webinar conference. In fact, this might be the first webinar conference, but the listserv had been running internet conferences previously for 9 years, from 2005 to 2013, and we did have an element of webinar, but certainly nice to come back to our medium. And in the meantime, between those times, we had a lot of courses that we had actually run, and Professor Unterberg was very instrumental in that. So it really gives me a great pleasure, privilege, and honor, distinct honor, to introduce Professor Andreas Unterberg, Professor and Chairman of Neurosurgery at the University of Heidelberg, a preeminent center in Germany and in around the world, and former president of the German Neurosurgery Society. And he's going to give us a lecture on high-grade gliomas. I certainly came across Heidelberg very long time ago in my career. Certainly, if my recollection is right, they had the first intraoperative MRI scan. And I had the pleasure of visiting Professor Unterberg's department, and it was a very impressive setup. So without further ado, Professor Unterberg, please welcome, and we are greatly looking forward to your lecture. Thank you, sir.
Okay, Naren, thank you so much for this very nice introduction and the many compliments. And it's my pleasure and an honor to contribute to this international course. I was able to participate in persona years back. Well, nowadays, due to the pandemic, we can have this digital meeting only, which is not what we would like to see, but nevertheless, let's make the best out of it. And with this first slide, I would like to introduce my co-worker, Christine Jung, also from Heidelberg. And she also has participated in many of the meetings before. And together we set up this lecture on high-grade gliomas. And it's our pleasure to give you our thoughts and on the management and also on the controversies. Now to continue, whoops, how to proceed? Over there. Here we go. This is one of my introductory slides. Here you can see 3 patients, actually MR scans, and top you can see the T1 with contrast enhancement, and below flare sequence of these patients. And it is no wonder for you that these 3 patients really are harboring a high-grade glioma, a glioblastoma, and only the one on the left would easily be diagnosed as a glioblastoma, whereas in the middle and to the right, those patients, they have tumors with very little or no contrast enhancement. Nevertheless, this is the radiological view, and for a long time also the neurosurgical perspective. And there is another perspective. Here you can see all of them glioblastoma with IDH wild type. And I would come back to this a little later. Now there is a neurosurgeon's perspective looking at those tumors. For example, we are talking in this lecture about glioblastoma and anaplastic astrocytoma, WHO grade 3. And there is also a neuropathologist's perspective. And let's go into this in the beginning. High-grade gliomas, and with this cartoon, what you see is not always what you get. And this is my first take-home message. My second take-home message, this is a sketch about a table about high-grade gliomas as they were looked into in former times by neuropathologists as primary and secondary glioblastoma. And of course, grade 3 and 4, they were classified as high-grade gliomas, and they needed adjuvant treatment, as you may know. The game changer was the detection and introduction of IDH mutations. If there is IDH mutations, patients are running much better in terms of clinical outcome, whereas the wild type patients, negative patients, do far worse. And you all know this meanwhile, and this is the cornerstone publication by Hartmann and others in Acta Neuropathologica 2010. And here you can see that both overall survival and progression-free survival was so different in IDH mutated patients, whereas IDH wild type patients. And I would like to let you know that in the era of molecular diagnostics is of course most important to stratify the surgical series for IDH mutation status. However, those series before 210 and even 215 or 217 have to be interpreted with caution, because in terms of survival data, because many of them are not stratified for the IDH mutation status. And looking at radiographs, again, MRTs and whatever, a low grade, or let's say many of the high grade gliomas, they are suspected low grade gliomas, and you have seen this in the very beginning. We have had a chance to look at our own cases in non-enhancing lesions. And this is our series from 2012 to 2019, from 1,640 gliomas, 112 had non-enhancing tumors. And here you can see that they were equally distributed to WHO grade 2, 3, and 4. And all of them were non-enhancing tumors. And if you look at grade 3 and grade 4 tumors in those, they sum up to even 64%. And if you look at the IDH mutation, this comes up, these are only the dark bars now, this comes up to 44%. So the next take-home message is, even in non-enhancing tumors, there is a high chance that this might be a glioblastoma or an anaplastic astrocytoma. And the factors predicting malignancy are, of course, and this is well known for a long time, age and the no T2 flare mismatch. This is not as well known, but nevertheless, age is a very, very important factor. So to sum up this, it is most important to select patients at risk of high-grade glioma, of course also in surgical series, and how to treat them surgically. You have to be prepared that non-enhancing lesions then finally turn out to be a high-grade glioma and need maybe a little different surgical treatment. Now, what is the current surgical management of high-grade gliomas? It's always a tightrope walk between maximized extent of resection and preservation of function. These two issues are most important: maximized extent of resection and preservation of function. And at this point, I could close my lecture. However, you expect to hear more about this, and I will try to highlight some issues that I think are important. Now, the most important factors in high-grade glioma, and not only in high-grade glioma, but probably also in low-grade glioma and other diseases as well. Number one is age. Number two, the functional status before you start treatment, and the molecular markers. And of course, a minimal residual disease. And to come to this goal, minimal residual disease, you need surgery, and surgery with all tools and the equipment that is available nowadays to achieve this goal. Because a minimal residual disease impacts outcome, facilitates the following adjuvant treatment, and improves quality of life. Now, looking again at a typical glioblastoma in the right frontal area. On the left, you see with a blue demarcation the contrast-enhanced lesion, whereas on the right-hand side, you see also the area highlighted, dotted in blue with the T2 or in the flare changes. And the question is what to resect. This is not trivial, but it's a very important question. And years back, and also nowadays in many analyses, only the contrast-enhanced lesion is looked at, whereas it might be more important to look at the whole tumor itself. Now, if you go and analyze the benefits of maximized resection, this is a cornerstone publication by Walter Stummer and others from 2008, and this gives gross total resection, and the benefit is +5 months in overall survival. Gross total resection versus partial resection. And this, in a further publication from San Francisco, was analyzed by Neda Sanai. This is 2011. They could show that even the stepwise improvement in extent of resection ended up in a prolongation of survival. And so there is clear evidence nowadays to say that the more you resect, the better your survival and the longer you survive. Again, a little caveat, these data were not stratified for ADH mutation status, but these are data from our center. Here you can see glioblastoma, 285 patients with gross total resection in blue and subtotal resection or biopsy in red. And you can see both progression-free survival as well as overall survival is prolonged with gross total resection. So this is nowadays, even in multivariate analyses, very, very clear and highly significant. Of course, this question has also been addressed looking at meta-analyses, and this is a systemic review from 2016. And here you can see that altogether more than 1,000 papers have been screened, but only 37 studies could be included in this systematic review and meta-analysis, looking at overall survival and progression-free survival. The overall survival at 1 year was significantly improved in gross totally resected patients, and the number needed to treat was 9, which is quite high if you compare it to many, many other studies, for example, in internal medicine. And at 2 years, it of course is less pronounced, but it's still significant, and the number needed to treat is of course higher. There are some caveats, and looking at these 37 studies, but I don't want to go into further details of these, this criticism. Now, this is a slide which is very simple, and maybe this is a slide for elderly neurosurgeons. Comparing overall survival grossly, if you have best supportive care and you do a biopsy and nothing else, taken from data 2013, this is a German analysis, these patients survive for 3 months. Then if you go into therapy, adjuvant therapy, radiochemotherapy, and you do a biopsy and add radiochemotherapy, that leads to a prolongation of overall survival of about half a year, 6 months. The next step with partial resection, about 1 year, 12 months, and complete resection about 1.5 years. This is, again, 7 years back, and nowadays data should be a little higher, but still this holds true. You always need complete resection and then adjuvant therapy to lead to gain the best overall survival for your patients. Now, this is the STUP trial years back. This was published in 2005. This is radiotherapy plus temozolomide. And temozolomide adds 2.5 months to overall survival, whereas gross total resection in the Stuma trial added approximately 5 months to those who were resected grossly. Again, these the STUP trial was not stratified for extent of resection, and in the Stuma trial, the post-op radiotherapy was only done and not the temozolomide given in addition. Now, this wraps up how to manage altogether high-grade gliomas nowadays. Take out as much as you can by all means. What are the controversies? And I would like to come to this part now as a second step. There are many right ways, as is indicated over here, but still there are points of discussion. For example, number 1, supramarginal resection. Is this helpful or is it not? Resection for recurrences, how to treat elderly patients, number 3, and how to deal with deep-seated lesions, number 4. I will touch these 4 issues a little more in depth. Now, number 1, supramarginal resection. You have seen this patient, this MRT already. This is a glioblastoma, right frontal, with the red lineage gives the contrast enhancing lesion, whereas the flare altered tissue you can easily detect by yourself. And the graph on the right is just a sketch to demonstrate that you can find tumor cells not just within the core, within the contrast enhancing lesion, but even centimeters far beyond. And so is it of benefit if you do more than taking out the contrast enhancing lesion? I think yes, it is. And there are some papers already. This is a paper by Lee, 2016, Can We Do Better Than Gross Total Resection? Let's have a look at their data. Some 1,200 patients and gross total resection in 71 patients. And if you look at patients with gross total resection, overall survival is 15 months. If you resect more than gross total, but less than 50% flare, there is no prolongation. But if you do more, if you do a resection, a gross total resection, plus a resection of more than 50% of the flare-enhanced tissue, then you see a significant increase in overall survival. One argument to do more than just contrast enhancement. Next. And if I can go back, there is no significant increase in overall or neurological post-operative morbidity, which of course is also very, very important because you do not want to interfere with quality of life. You want to do no harm. Okay, let's have another look at two publications. The one on the left is survival benefit of lobectomy over gross total resection. This, of course, can only be done in non-eloquent area. And on the right, there is, again, surgery for temporal glioblastoma. These resections were also based on a lobectomy basis, which can be done, as we know, if you are within the safe margins. And below, you can see the benefit of lobectomy in both series, some months in addition. So again, the take-home message is, if you can go for more, do so, or consider to go for more. PFS and overall significantly prolonged after lobectomy with comparable Karnofsky score. But data on quality of life and neurocognitive function are still missing and should be added in the future. But again, this is a pledge and this is an argument to go even for more. Number two, how do you deal with recurrences of glioblastoma? Left, there is a right frontal recurrency, whereas on the left, you see a left insular cystic and not well demarcated recurrency. Of course, these two patients are so different, but you can easily realize that it is always a very individual decision to go for a recurrency. What is the survival benefit? These are the results of a German analysis, the so-called Directors trial that was published in 2016. And here you can see that only those recurrent glioblastomas who had a complete resection, CRET, number is 40, they had a significant benefit and a prolonged survival. And later, an American study by Oppenländer showed that even a stepwise further resection was also beneficial. So not just a distinction between gross total and subtotal, but the more recurrency you resect, the more you see prolongation of overall survival. There is a stepwise survival benefit. So repeat surgery should be considered in at least selected patients. Of course, you have to take into consideration and look at Karnofsky score, age, the social situation of the patient and whatever, but it might be a consideration to repeat surgery. And this, of course, leads to a lot of biases and a selection in errors. And it is not easy to give a clear algorithm how to proceed with such patients. Also in resection for glioblastoma recurrences, there is a meta-analysis I would like to show you, but I do not want to go into very detailed analysis. This is again the director trial highlighted over here. And you can easily see that the extent of resection in repeat surgery is also associated with the benefit of survival. You can see that the overall benefit is highly statistically significant. And maximal resection for recurrent GBM prolongs survival, independent of the extent of resection at first surgery. This is another take-home message. What else can be achieved if you go for recurrences? You get more tissue and you can send it to neuropathology. And the glioblastoma over recurrency of, that has been treated by surgery, by adjuvant radiochemotherapy is changing. And these mutational changes can be analyzed looking at the molecular analysis of these glioblastoma, and the resampling might end in detection of novel changes, and they might lead to a more sophisticated and a more personalized chemotherapy in the following. So to wrap up this topic, resection of recurrent glioblastoma prolongs survival and may augment targeted therapies. Next, how about glioma in elderly patients? You see on top 3 elderly patients. The question is, who is elderly? Angela Merkel, our chancellor, she's above 65. Joe Biden is 78 as of today. And Queen Elizabeth II is above 90. So no question, she is elderly. But the question in general, who is regarded elderly, and where to, let's say, put the boundary, the hurdle to say this is now regarded as elderly. And to be honest, I'm also elderly because I'm also above 60 meanwhile, and this should be taken into consideration if I would carry a glioblastoma. Here you can see that the incidence of glioblastomas increases with age, even worse with meningiomas. But look at the different interventional ages in different trials worldwide, and there is no, let's say, consensus as to what and as to when patients should be regarded as the elderly population that might be treated differently. But if you look at the data so far available, overall survival above 65 or 70, also in the elderly population, there is a benefit in survival. And this is a case-controlled study, 80 patients above 65, matched for age and whatsoever. And this is a study comparing biopsy versus partial and gross total resection in elderly patients with high-grade gliomas. Again, a systematic review and meta-analysis. They looked at overall survival, progression-free survival, Kanofsky score, and all were improved with increasing extent of resection. And morbidity and mortality were also reduced and with increased age. So this is again an argument to proceed and to handle these patients as if they were younger patients, let's say below 65, 70, 75, or whatever range you're looking at. Maximized resection is meaningful in elderly patients as long as it is safely achievable. And safely achievable is, of course, a question if you look at the fourth controversy, resection of deep-seated lesions. This is a 37-year-old patient that we have seen with a progressive left-sided hemihyperesthesia and neurocognitive deficits. And we did more than just a biopsy, I have to admit. We operated, we did more than a biopsy, we resected. And the patient survived, had no more deficits than preoperatively, so they could be stabilized, and then the patient had adjuvant radiochemotherapy, and it could safely be achieved. But this, of course, is a very tricky situation, and of course, many of even experienced neurosurgeons would argue and say, this is too risky, don't touch the tumor itself, you may take a biopsy, but no more. And this is an ongoing discussion, and there is a paper by Sonnabend in Neurosurgery in 2017, and they looked at resectability, extent of resection based on the anatomical location and whatsoever, and surgeon factors. And if you look at these, this graph taken from the publication, you can see that patient number 17, it's the upper row, all surgeons that were asked how to proceed propagated or proposed surgery, whereas for the patient in the middle, patient number 19, only one surgeon pledged for surgery, and to the right, there were some who said, well, resection should be done as gross total resection, and others said only subtotal resection is meaningful. So there is, of course, a broad variety in meaning and, let's say, of even experienced neurosurgeons how to proceed with such patients. There are tools where you can say we might attack even deep-seated lesions. You might use a neuroendoscope, a tubular retractor. You can do fluorescence guidance. You can maybe even use an exoscope. But so far, it has not been shown that in addition, laser interstitial thermal therapy or photodynamic therapy is really meaningful, significant, helpful. These are more or less technical reports rather than a systematic evaluation, and the survival benefit using each of those adjuncts still has to be shown. Now, in the end, let's say in the last 20% of my presentation, I would briefly touch the various resection guidance tools that are available nowadays to do or to go for good or even for better in our patients. Resections guidance tools may be just based on imaging like neuronavigation, intraoperative MRI, intraoperative ultrasound. They may include biochemical markers, fluorescence, intraoperative Raman spectroscopy, or others. One word about fluorescence guidance. We have talked about the Stummer trial already using ALA. This is taken up by malignant tumor cells and then is giving fluorescence intraoperatively. Maybe you can use also fluorescein, which is not a marker of the tumor itself, but a marker of a disrupted blood-brain barrier. So it is much more difficult to use this, but it is, of course, also very, very much cheaper to use it. And there is no answer to the question as to whether fluorescence-guided resection with 5-ALA directly staining the tissue and maybe extending beyond the tumor and beyond the contrast enhancement is better or superior, for example, to image guidance. And this again is citation of Stummer's trial showing that the 5-ALA treated patient group is doing better, and they have, of course, better resection. If you now go to intraoperative high-field MRI, this is our setup in Heidelberg. We have been using this system for many years now. We are using it, the intraoperative MRI to maximize extent of resection in glioblastomas as well, sometimes even in association with 5-ALA. These are our data. We are using our intraoperative magnet more than 250 times a year in glioma surgery, and also very often in glioma surgery. This is just some sketches. These are just some sketches of our setup. The patient within the coil, which the patient is being brought via a lavette into the MRI next door, so that we are using and can use the usual microscope and the usual tools for resection. And this is also just one example where the intraoperative MRI showed a residual tumor that could be taken out as a second step. There is one study from Senft in Frankfurt, published in 2010, that using intraoperative high-field MRI is able to maximize resection. Here, the original data are shown. EOR is increased and gross total resection more frequent. Now, this poses the question, what is superior, 5-ALA or intraoperative MRI? And we are tackling this question, trying to answer it by doing a trial where we compare intraoperative MRI and extent of resection in newly diagnosed glioblastomas in a parallel group that is being resected by 5-ALA. Recruitment for the trial has been halted as intended, and we are awaiting the results. They should come up by next year, and we are all looking forward to see which is superior. What is another intraoperative tool? This is intraoperative histology. You may have heard about Raman spectroscopy, and it has been used already. This is a very recent publication from Nature Medicine 2020, and it is meanwhile as good as intraoperative H&E staining. So all neuropathologists that are still dealing with intraoperative staining and looking at fresh tissue might be not necessary in the future. And this is maybe a dream of a neurosurgeon that has to wait for a long, long time to get the intraoperative H&E staining. The diagnostic accuracy is comparable. And here you can see from the same publication just some pictures. And the semantic segmentation method was used to identify tumor-infiltrated diagnostic regions. So you can take tissue from suspicious tissue and diagnose directly intraoperatively. Within a couple of seconds, you will get the histological result as to whether this is tumor or not. This might be a future application for intraoperative resection control. Now, my last point is looking at function. Maximizing resection is, as I said already, always a tightrope walk between minimal residual disease, meaning maximal resection, and preservation of function. How to prevent and how to preserve function. You can use direct stimulation, dynamic mapping, and awake craniotomy. And this is, for those of you who are well known with the literature, an important cornerstone paper from San Francisco, again, 2012. This is a meta-analysis of 90 observational studies, glioma resection with and without intraoperative monitoring in more than 8,000 patients. And the answer is glioma resection with IOM leads to a reduced rate of late severe neurological deficit. It is helpful, it is beneficial, and this is, I think, even as important, a higher rate of gross total resection. So you are doing beneficial effects in two ways to the patient. Less deficits and more resection. This is just one case which we did here in Heidelberg. This is a huge glioblastoma. And here you can see how it was operated, and you can see our setup with intraoperative monitoring, and everything we could use has been used in this patient, MEPs, SSAPs, dynamic mapping, and whatsoever. And I can tell you that, here to the right, you can see that there was a nearly complete resection. More than 97% of the tumor could be taken out with no additional deficits. And the patient, of course, had further adjuvant therapy and really benefited from the many technological equipment we used in his case. Now, finally, one word about awake craniotomy in glioma surgery. Awake craniotomy is being used in, of course, eloquent areas of the brain, like the speech areas, Broca and Wernicke's area. Mapping can be done, and speech disturbances can be induced. And so you can decide as to whether continue or not with your resection. And this is a slide taken from a not yet published paper of Christine Jung, where she can demonstrate that there is increased extent of resection using the intraoperative MRI and awake glioma surgery in combination. And it could be increased by both methods to preserve and to look for function and to go for radicality as well. Awake glioma surgery and MRI, they are complementary adjuncts to maximize resection while preserving functional integrity. Now, finally, to end up, I would like to just share with you two things. How about adjuvant treatment? This is not surgery, but neuro-oncology in general. This is a global map showing how many trials are going on in November 2020. There are more than 300 trials recruiting, and you see most of them in the US, but also in Europe and in other countries. And if you go back into history, in 2005, temozolomide was introduced, and since then, we have seen only few really studies that could ameliorate adjuvant therapy. That many immunotherapies have already been tried, but none of them was really convincing. And the only additional treatment that could be introduced, but at least in our country, is only used maybe by 30% of the centers, are tumor treating fields and not in very many patients. And if you see how much this adds to radiotherapy, this is the cornerstone paper by Stupp. This is adding 2.5 months, and Stupp with tumor treating fields is adding another 5 months of survival. How to continue, how to proceed, how to go into the future. This is what we are doing with some patients, in particular patients with newly diagnosed glioblastoma with an unmethylated MGMT promoter. This is a so-called umbrella trial and a specialized genetic analysis of the tumor cells is being performed, a so-called 450K array, a panel sequence, and then many experimental groups are being filled up with patients, not just from Heidelberg, but also from other centers in Germany. And of course, such umbrella trials will take a long, long time to maybe find out some additional beneficial adjuvant therapies. Nonetheless, one very final slide about neoadjuvant anti-PD-1 immunotherapy in recurrences. And this is also a multi-center randomized clinical trial, which to us appeared very, let's say, interesting and promising. If you have your recurrent glioblastoma and you do a treatment with this PD-1 pembrolizumab, and then you do surgery, then you reduce, after first treating with the PD-1 inhibitor, then maybe you can induce a systematic activation and a clonal selection of tumor cell-specific T cells. And if with this, let's say, neoadjuvant therapy before surgery, you might be more effective than just giving it after treatment, because you will have a certainly reduced residual antigen amount and a less tumor cell-specific target for your following treatment. So we are very highly interested to see how this will turn out. There are data already available that this prolongs progression-free survival, and this might be helpful. And we would see for the future, when more data will come up, whether this is a therapy that might be helpful, at least in recurrences. So to finally wrap up, after 45 minutes, this is a very long talk and a lecture. Modern glioma surgery, and this is a cut of a brain illustrating the diffuse infiltration of glioblastoma cells throughout the brain, is always a tightrope walk between maximized resection on one hand and preservation of function. And if you have, in addition, molecularly informed treatment, this might help to prolong the survival of inflicted patients. But this means that you are on a way, and we are all on a way, to an individualized surgical strategy and treatment of our patients with high-grade gliomas. And with this, I would like to thank you for your attention, and I'm open for your questions.
Thank you very much, Professor Unterberg, for this very thorough and also very covering all the aspects of the current state-of-the-art management of high-grade gliomas, and a very eloquent lecture. There are many questions for you on the chat box, but for want of a time, may I ask you one question from the chat box? And if you have time, I would be grateful if you could answer the others. I think one question is from Dr. Teza Win. His question is that in case of a tumor, a hemorrhagic tumor that appears high grade with the patient with a reduced GCS, which treatment option is best for this condition? Would you...
I would say take out the tumor, because okay. This is, when I was a resident, my first chairman in neurosurgery, he said, this is a rare condition, this is an apoplectic glioblastoma, and go for it as soon as possible, even during night calls. Take out the space occupation, the bleeding, and try to take out as much as tumor as you can. And many of such patients, I think, will improve even with in their neurological function.
Thank you. I'll put another question as well. I said there are many questions, but this question probably you can take a whole day to answer. When do you decide at how many times you are going to operate on a recurrence?
Nowadays, we have become very liberal to go for a first recurrency. And if it's possible, if you can take out safely the whole contrast enhancing recurrency, we will go for it. If Karnofsky is okay. And if the patient says, okay, I'm ready for the second surgery, because there are also some patients who don't want to have a second surgery. But I would also go for those where you can safely take out, let's say, 90%. Or if there is a cystic component with space occupation. So I think during recent years, we have become more and more liberal in going for recurrences. But it's always, of course, an individual decision.
Thank you. I think my one question is starting to become more than one. The last one, I'm a pediatric. My interest mainly is pediatrics, but for me, getting old is also pediatrics. And so, in terms of elderly patients, what's the oldest patient that you have operated? And if a head of a state who's 95, 96 comes to you with a GBM, what would you do? Thanks.
Well, depending, age by itself is not the most important thing, what is seen in your passport. Mm-hmm. The biological age is, of course, the important thing. And I think the oldest patients I operated on were between 83 and 87 for a glioblastoma. Mm-hmm. Now I can tell you certainly know Peter Hutchinson.
Yeah, of course.
From Cambridge.
Yes.
And he once visited us. This is years back, I think in 2003. And he was very, very, let's say, irritated and questioning. And he saw a patient I operated on, and she was 83, a lady. But she was not acting like 83, maybe like beginning of her 70s. And she pledged for surgery. She said, please take out as much as you can, because I want to get rid of the tumor, which of course is not possible. All of us, we know, but she did well, and she survived for 2.5 years. And the decision to do it or to leave it is always a difficult one. If you have to discuss this with the patient, and it's also a philosophical, a humanistic question, if possible, I try to ask my patients, what are your plans for the next years? And if there are specific plans, for example, new kids in the family, or let's say a jubilee, anniversary or whatsoever, I try to tell them, yeah, let's go for it. And this is now your goal, because we know that you will not survive the tumor itself, but you have to look for goals in your further life.
Thanks. It's a good thing I don't drink, because if I say this is the last drink, I'll probably be now in the fourth drink. Professor, one important question for me is this MDTs for brain tumors. And in many centers, for practicality, the patients from a peripheral department, they refer the patient scans and the history, and then there's a MDT in the central hospital, and then not necessarily all the patients are seen, particularly if they are not for surgery. What's your practice? Do you see every patient that's referred to you and say to look them in the eyes and say, sorry, surgery is not for you? Or do you give them the option to come and see you? Or if they say that, they really want an operation, what do you do? I think it's a philosophical question, but it will be good to have your thoughts on it. Thank you.
Yeah, and I think it's also a question of your healthcare system. I think in Germany, most of the patients are diagnosed or get their diagnosis of a brain tumor outside, not within the hospital. And they are, let's say, being diagnosed by neurologists, by family doctors, and by radiologists. And as soon as they have the diagnosis of a brain tumor whatsoever, most of them are being sent to us and not to neuro-oncology or somebody else. So we give them our advice, our views, and we can say, we would do this or that. So they usually come directly to us. Some of them do come in, for example, with an acute neurological deficit, like hemiparesis or something, especially in those tumors with intratumoral bleeding or sudden edema or whatsoever. They are seen first by neurology. But then at least in our hospital, they are always also sent to us, and we see them and we give them our opinion, our advice.
Thank you.
I would do so, of course, because I think as neurosurgeons, we can judge best what is, let's say, acceptable, or if you see a patient, talk to him and his family, you can also judge what is he willing to take as a risk, because all types of surgery are, of course, also a risk, and there are potential complications. And then you have to take into consideration their general health status. Do they have, for example, anticoagulation and many other factors?
Thank you very much again, Professor Unterberg. It's again a privilege, honor, and personal pleasure and distinct honor to have you again with us. And I hope, I'm sure you will kindly help us again in the future. As I mentioned, there are a number of more questions on the chat book should you have time. Thank you very much, sir. Thank you very much, Dr. Young. Thanks, both of you.
Here she is.
Thank you. Thank you very much. Much obliged. See you soon.
It's been our pleasure, Naren. And we will go into the chat and try to answer these questions as well.
Fabulous. And look forward to meeting you in person very soon. Thank you.
Yes.
Thank you. Thank you.
Take care. Bye.
Thank you very much. Yes. Bye for now. The next talk is from Dr. Komal Prasad. Dr. Komal Prasad is a senior neurosurgeon at the Narayana Institute in Bangalore. He's a very great friend of the listserv, and it's a pleasure to have him give us his talk on carotid endarterectomy. We had planned our course in Bangalore earlier this year. Just weeks before, we had to, because of COVID, we had to postpone it indefinitely. But again, it's my distinct pleasure and privilege to get Dr. Komal Prasad to give his talk. Thank you, sir.
Thank you, Naren. Thank you very much for this opportunity. In spite of this COVID pandemic, you're managing to have academic fees now and again. And this is one more World Neurosurgery webinar. I'm very grateful to be a part of your international conference once again. So after a wonderful talk by Professor, this is a short talk on carotid endarterectomy, the tips and tricks of the procedure in itself. There's a lot of literature on carotid stenosis particularly. And most of it easily available, and it is something which comes under the jurisdiction of neurosurgery, but for some reasons in some units it is done quite rampantly, quite frequently, whereas in some others it is only very sparingly done. So because this is a short talk, I want to keep all the theoretical aspects and statistics and the trials apart and concentrate only on some technical tips, take-home messages of two kinds. One for those people who are on the verge of starting practice and are interested to do this, some take-home messages to show how simple and elegant this procedure is. And second is for, like any group, any unit which does carotid endarterectomy will develop its own technique and variations over time, and to showcase what we have learned over time and which may benefits other teams who are doing this quite often. So I'll concentrate on these heads, case selection, investigations, the key instruments, which are definitely quite different from what we use in our brain surgeries or in spine in general. And some take-home messages on key steps. So we should always remember that carotid endarterectomy is the gold standard for treatment of symptomatic carotid stenosis, no doubt about it. Whatever studies are done for carotid artery stenting, we'll look for non-inferiority of that versus the gold standard carotid endarterectomy. So moderate to high-grade symptomatic carotid stenosis, the gold standard treatment is carotid endarterectomy. And our typical indications are this: ipsilateral non-disabling ischemic stroke, TIAS, within the past 6 months. And it should be a surgically accessible carotid artery lesion. It should not be too high bifurcation, because the more high it is beyond the mandible, it will be much more difficult and morbid because of the hypoglossal nerve and much beyond. Theoretically, we can do a mandibulotomy and go, but it is better to consider those cases for carotid artery stenting. We should remember that risk of perioperative stroke and death for those cases in those units who take up carotid endarterectomy should be less than 6%, because otherwise the natural history would be better than doing any intervention. And in continuity with age factor, this is particularly well suited for elderly people. Fit patients over age of 75 do really well with endarterectomy than with stenting. That is surprising, but it's true. Studies have proven that endarterectomy is a much better option than stenting as the patient ages. So investigations, there are some units which do with Doppler, whereas in our place we generally will like to have at least a CT angiogram and preferably a DSA before we take up for endarterectomy. What we see, the extent of stenosis, how the perfusion is compensated from the opposite side, location of carotid bifurcation. One landmark is to see how above or how below the mandible is the bifurcation. And to see the structure, how the plaque is, whether it's a calcified thrombus or a floating thrombus. These are two typical indications. Some of the cases will come directly to interventionists who will be ready to do a stent, but after seeing calcification, which is a contraindication for stenting, they will be considered for, they will be referred for surgery. And sometimes there will be floating thrombus, especially in younger group of people, where it will be dangerous to manipulate that when they attempt a stent. That is another indication which will be where these cases will be referred directly for endarterectomy. Nowadays, with the passage of time, the initial interest and the enthusiasm for stenting is slowly toning down, and it is getting accepted that the first option, the gold standard, is endarterectomy. The choice will be given to the patients who will choose between stenting as otherwise endarterectomy, depending on their choice, basically. But it's always worthwhile to say that the better treatment, the gold standard, is endarterectomy. So what we need to note here is, as I said, high carotid bifurcation, whether there's a bilateral stenosis, whether there's a near total occlusion. Sometimes when the DSA, sometimes when the CT angiogram or Doppler shows 100% totally occluded, DSA shows it is 95% or so with some distal flow, and those cases needs to be considered, whereas if it is a total occlusion, it is a strict no-no for surgery. So some key preoperative points: aspirin has to be continued on the day of surgery. Aspirin is very important, whereas clopidogrel, when the patient's on dual antiplatelets, it's better to stop for a day or two at least, because we have seen neck hematomas, not from the suture line of arteriotomy, but from ooze from the surrounding structures requiring sometimes evacuation, very rarely. So better stop clopidogrel for a day or two. General anesthesia is preferable. Some people do under local, but general anesthesia for the neurosurgeons, it's much more comfortable both for the surgeon as well as the patient. Head-on horseshoe support, which we are used to with neck extended, will give an additional space near the neck to work around. Avoid scrubbing skin for preparation because that may dislodge the thrombus or a plaque and create a new embolic stroke. We prefer a linear skin incision parallel to sternomastoid. The instruments I was telling is a little different from what we generally use intracranially or in the spine. So these are the spectrum of instruments: vascular clamps, bulldog clamps, aneurysm clips, Jewelers forceps to safeguard the endothelium, dissectors, micro scissors, soft tipped suction so that we won't injure the intimal layer, and Prolin 6O for closure. We'll always keep shunts ready. Shunts are small tubings for proximal to distal shunting in case if it's required, and a Gore-Tex patch to put a patch for the arteriotomy closure. But most of the times, both of these will not be used. And we give a bolus of 5,000 units heparin at the time of clamping, just before clamping. And for flushing the area, we used heparinized saline. The key step in carotid endarterectomy is to find the dissection plane. If we see serially the steps in carotid endarterectomy, we'll miss out this important step where things can go wrong. We'll have to get into the right plane, and finding the plane is a learning curve, we can say. So, and this is the time when we had to take the operating microscope that helps in getting the clear plane between the plaque and the vessel wall. Expect calcifications, expect thrombus within the plaque, and then when you're resecting out the plaque, limit your aggressive resection when going towards the CCA. Though it is a ICA ICA plaque, it extends proximally up to CCA for a centimeter or so, and the thicker part, and then it thins out and it goes as if it's going much further into the proximal towards the arch of aorta. We should limit when it gets reasonably thin and not attempt to pursue it further and further. Similarly, when we go towards the ECA, it's immaterial to take all of the plaque towards the ECA. So you just etch out how much ever is easily coming and limit it there. And always open internal carotid artery clamp to see how the backflow is. That will give an indication how the brain is getting perfused. That's a better neuromonitoring technique than using BIS monitoring or EEG. And it's more practical and simple and easily doable. No need for any extra instruments. So this is some of the unusual cases where we get floating thrombus, very dangerous. Sometimes managed medically with keeping fingers crossed so that the embolic phenomenon doesn't happen with anticoagulation. But sometimes if it is repeatedly throwing emboli, we'll have to do endarterectomy and take it out. So these are our findings in our series. As I noted that the 7th decade is the commonest presentation requiring endarterectomy. We use GA. Shunt was not used in any of the cases. Primary closure is a norm, most of them except 1 or 2. And all cases were for symptomatic carotid stenosis, not for asymptomatic ones. And there were no neurological deficits in any of our cases. So I will go through a series of photographs from surgery for want of time. I'll go quickly. So now we can see the orientation. This is the superior thyroid artery, which is clamped. It's better to keep it clamped, otherwise there will be constant pulse when we do arteriotomy. So these are the 3 clamps. This is the ECA, ICA, and CCA. The clamps are applied and held with the umbilical tapes. Then the arteriotomy is done after clamping. Before that, heparin has been infused 5,000 units, and we are seeing, and this is the plane where we need to go. Carefully, we'll have to create a plane there. This is the Julius forceps, and then with the sharp dissector, we create a plane there, and it's the natural plane is there actually. But if we go more towards the vessel wall, we may go through and through. So now we have created a plane. The plane is elevated, and the plaque is slowly removed. We are seeing the inside there, and this is our calcified plaque is being edged out from the ECA part is something which gets stuck. That is the thing which comes out in the end. And I am as you can see, we are not going too much proximally towards the CCA. You'll have to limit, you'll have to take a decision where to stop. Those frayed edges can be an nidus for thrombus formation. So sometimes you need tacking sutures to take care of them. That feathery things should be nipped off. Tacking sutures, when you are using microscope, most likely will not be required. But in case if you are having any rough edges, you can take 1 or 2 tacking sutures to the intima. And when we are closing, so we generally close with a 6-O-prolene, starts from distal to proximal and from proximal to distal, start from this end as well as this end. And you'll have to, before actually completing your arteriotomy closure with 6-O-prolene, it's a running sutures of prolene 6-O. And we are seeing this soft tipped suction. So there is this acronym we would have heard of how to clamp and declamp, ICE and DICE. So, but it's not as simple as it is theoretically said. Like there is 3 steps in that actual technique to obsessively clear off all the debris. This is another important step. So before closure of arteriotomy, you'll have to open briefly external carotid, internal carotid, and CCA sequentially, and allow blood along with whatever debris is collected out, and then close the arteriotomy. Then again, open and close briefly, external carotid, common carotid, and clamp again. So whatever is there from CCA side will get into ECA. And then again, external carotid, internal carotid are open, and then again clamp, so that whatever is there in ICA, upper stump, gets into external carotid circulation and flushed away. Finally, you release, this is the de-ice part, which we generally say as a part of mnemonic. External carotid, CCA, and ICA are sequentially open and left like that. Then a thorough wash is given. Arteriotomy, if there is any ooze from any side, 1 or 2 sutures may be required sometimes. I'll be happy if I see some ooze from the arteriotomy closure line rather than if it is not. We need not be tying it too tight. It should be just enough to snugly hold it in position. If there are 1 or 2 places where it is oozing, I will close it with, again, free running sutures of prolene. Then place a surgical over it, and most of the cases we keep a drain, though nothing comes generally. We just keep it for a day in most of the cases. So the key points for technical aspects, to summarize: general anesthesia is comfortable. I'm closing, Naren. This is my last slide.
Thank you, Chair. Thank you.
Yeah. So this is one important step, is to rehearse with all the instruments. It's not a routine surgery that we do every day. So rehearse your steps before you actually clamp. Use operating microscope. Dissecting plane is the most important step to get into the proper dissection plane. Flush out the debris obsessively. Shunt and patch are only selectively required. Neuromonitoring is also very selectively required. Clamp time, you need not bother too much about clamp time, because it's the emboli which are more common than ischemia time. You can take up to 1 hour. Our initial cases, you used to be panicky and close within 20 minutes. But we need not compromise on the perfection of your arteriotomy closure. We can take up to 1 hour without any major neurological problems. And continue aspirin perioperatively. Thank you very much.
Thank you very much, Dr. Prasad, for that elegant talk, taking us through the tips and tricks. Fantastic. For the want of time, I'm going to move to the next talker. You were well within the time. Thank you very much. And I'm going to now introduce my co-chair, Mr. William Lowe. He's a consultant pediatric neurosurgeon in Birmingham Children's Hospital. He's a colleague of mine, trained in Birmingham as well as in Toronto. Mr. Lowe, if you could please moderate the rest of the sessions, please. Thank you.
Good afternoon, good morning, and good evening to everyone. Thank you, Naren. It gives me a great pleasure to introduce the next speaker, Professor Tariq Khan from Pakistan. He's going to deliver to us a keynote lecture on the current status of decompressive craniectomy for severe head injuries. Professor Khan is a professor of neurosurgery and chairman at the Northwest General and Research Center in Peshawar, Pakistan. He's the chairman of the Neurotrauma Committee of the WFNS. He's very active in neurosurgery education in Pakistan and also in South Asia, and very active globally on neurotrauma, being the chairman of the WFNS committee. Professor Khan was one of the co-authors of the consensus report on the role of decompressive craniectomy in head injury following the publication of the Rescue ICP trial. We look forward to your keynote lecture, Professor Khan.
Thank you very much, Professor Law. Good evening from Peshawar to everybody. I hope you can hear me clearly.
Yes, we can. Yeah.
Thank you, Naran, for inviting me to this meeting, wonderful meeting. I hope everybody is doing well under the circumstances of the pandemic. So my talk is on decompressive craniectomies, and if there's a consensus built on it yet. You know, there's been a pendulum going one way and the other. Sometimes too many decompressive craniectomies done, sometimes too little done. So I'll just start with some basic steps. You know, you all know the measures required to reduce the ICP is because the cerebral edema and intracranial hypertension leads to decreased cerebral perfusion pressure and followed by cell injury, and a vicious cycle starts. So to interrupt this cycle, various measures are taken. As you all know, osmotic diuretics like mannitol and hypertonic saline, sedation, oxygenation, mild hyperventilation, moderate hypothermia, and CSF drainage. The recommendations of the Brain Trauma Foundation, again, are the same: head elevation, neutral position, normothermia, sedation, volume resuscitation. And then the first line therapy, CSF drainage, hypocapnia, mannitol administration, 3% saline. And then the second tier, high dose barbiturates, intense hyperventilation, increase in mean arterial pressure, mild to moderate hypothermia, and then, of course, decompressive craniectomy. But we also know that many of these measures have complications, like mannitol can cause pulmonary congestion, electrolyte imbalance, seizures, rebound, increase in ICP. Barbiturates may cause decrease in blood pressure and depressed cardiac function, and hyperventilation may cause rebound, increase in intracranial pressure. So what is the role of decompressive craniectomy? It increases the buffering capacity of cranium. It allows outward herniation, preventing compression of the brain stem structures, and reconstruct brain perfusion. And ICP reduction varies from 15 to 85% depending on size of bone removed. And neurotomy further decreases the intracranial pressure. So the main condition, as we all do it for, is traumatic brain injuries. But we also get asked by the neurological colleagues when there's a malignant cerebral infarction, and occasionally in cerebral venous sinus thrombosis, intracerebral hematoma, metabolic encephalopathies. So the types of decompressive craniectomy is prophylactic or primary decompressive craniectomy, which is any surgical decompression performed with or without brain tissue removal. And secondary decompressive craniectomy, when you're doing continuous ICP monitoring and when ICP is refractory to first and second line of medical treatment. So in lower and middle income countries, you would see mostly prophylactic decompressive craniectomies, and sometimes they are even done to prevent raised intracranial pressure instead of reducing intracranial pressure. And these are conditions where people cannot afford to do more than one CT scans, and the data is from the clinical picture from the GCS and the first CT scan. So I just give you some indications about how we do it in decompressive craniectomy without ICP monitoring, which is very common in LMICs. So in trauma, the CT scan finding the diffuse brain edema with or without brain contusions and subdural hematoma, the effacement of basal cisterns and ventricles, and midline shift of that's equal to or greater than 3 millimeter. These findings may be initial or in repeat CT, or Glasgow Coma score of 9 to 12 with a drop of 2 degrees from previous. And importantly, we look at the age because we all know that there's a high mortality of age over 70. Patient selection is very important when there's failed pharmacotherapeutic intervention, early versus late, signs of brain herniation, GCS at least 8 to give you a better survival, and age less than 70. Poor patient selection is when there's primary brainstem injury, pupillary findings with dilated pupils, ICP percentage higher than 40, and again, age over 70. So surgical technique, they can be unilateral, bifrontal, bitemporal, and of course, durotomy with augmentation, neuroplasty. So the size is very important, should be minimum of 12 to 15 centimeters fronto-temporoparietal, and to go as low into the temporal fossa as possible. If the frontal sinus is open, it can be pneumatized. Bifrontal may have a midline strip left or removed and cut the forks to make it into one compartment. So this should be the size and the shape of the decompressive craniectomy. We know that two very important studies were conducted. One was the DECRA study and the other one was the rescue ICP. The DECRA study was published in the New England Journal of Medicine. And basically it said that it reduces bifrontal temporoparietal decompressive craniectomy, decrease in the cranial pressure and the length of stay in ICU, what was associated with more unfavorable outcomes. And there was a lot of critique on it because there was a number of crossover patients and there were many patients with fixed dilated pupils. So this was an article written by Stephen Hannibal, and it's basically said that the role of decompressive craniectomy when ICP continues to increase greater than 20 remains to be established. The ongoing rescue ICP trial hopes to address this issue. So then the second trial was done, a trial of decompressive craniectomy for traumatic intracranial hypertension by Peter Hutchinson and his group. And its conclusion was that at 6 months, decompressive craniectomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in lower mortality and higher rates of vegetative state, lower severe disability and upper severe disability than medical care. The rates of moderate disability and good recovery were similar in the two groups. So basically, the number of survivors was more, but it led to a bigger number of patients in vegetative state. So there was a question mark on whether one should be doing it or not. So this was the bottom line, basically, that it's a life-saving procedure, but we must discuss with the family regarding the quality post-operatively. So an international consensus meeting was held in Cambridge in September 2017 to discuss regarding primary and secondary decompressive craniectomy, the indications, the surgical technique, and cranioplasty. And this was a group in Cambridge at that time. And this paper was published, consensus statement from the International Consensus Meeting on the role of decompressive craniectomy in the management of traumatic brain injury. So the main points from this meeting which were taken was that primary decompressive craniectomy, after evacuating an acute subdural hematoma, if the brain is bulging beyond the inner table of the skull, intraoperatively consider leaving the bone flap out based upon clinical and radiographic findings, and 100% consensus on that. After evacuating an acute subdural hematoma, if the brain is very relaxed and the preoperative CT imaging is not in keeping with a high risk of progressive brain swelling, the bone flap should be replaced, example in elderly patients or low energy mechanisms. So there was a consensus of more than 87%. For the intermediate category of acute subdural hematoma patients, brain neither very relaxed nor bulging, surgeon judgment must be used to decide whether to leave the bone flap out or not. 97% people agree to that. After evacuating an isolated epidural hematoma, the bone flap in general should be replaced. In a primary decompressive craniectomy, the bone flap should be of large size, at least 12 by 15 centimeter. Decompressive craniectomy is an option for patients with contusions in whom contusions are not being evacuated. If there are well-circumscribed contusions, intraparenchymal hematomas are present, surgeon's judgment should be used to decide whether to evacuate the contusions and intraparenchymal hematomas or not. When the bone is replaced, an ICP monitor should be placed where available. So there was a consensus of 74%. And ICP monitor should be placed following primary decompressive craniectomy if available. In situations where no invasive continuous ICP monitoring is available, CT imaging should be used to monitor progress. Areas of uncertainty regarding primary decompressive craniectomies for mass lesions were that if intermediate category of acute subdural hematoma patient were following evacuation, brain is neither relaxed nor bulging, it is not clear if performing decompressive craniectomy instead of replacing a bone flap provides any additional benefit for the patient. The trials of the rescue ACDH are awaited. The use of hinge craniotomy required further evaluation to determine effects on outcome. And the consensus on secondary decompressive craniectomies were, where available, ICP monitoring is needed as a component of decision-making for secondary decompressive craniectomy. So there was a consensus of more than 95% on that. Secondary decompressive craniectomy is effective in decreasing ICP, but underlying brain pathology and pathophysiology contribute to overall outcome. The optimal candidate for secondary decompressive craniectomy is a patient whose ICP elevation is the primary contributor to poor outcome and the primary injury is deemed compatible with acceptable recovery. That's very important. Where available, ICP monitoring should be used in conjunction with CT findings and neurological examination to decide on secondary decompressive craniectomy. And there was a 100% consensus on that. Use of ICP monitoring is recommended according to regional availability of resources. Non-invasive monitoring methods to establish refractory intracranial hypertension can be used. While secondary decompressive craniectomy is a potentially useful operation, it should be applied selectively as there is uncertainty as to which severe TBI subgroups will truly benefit. So as I said, the pendulum swung from one to the other. Previously, everybody was having a decompressive craniectomy, but it's very important to hold back and think how helpful will it be to the patient. Decompressive craniectomy may decrease mortality, however, it is not benign and is associated with significant risks of complications and potentially increased risks of disability. Before contemplating secondary decompressive craniectomy, providers should conduct frank discussions with family members, surrogates regarding the risks, benefits, alternatives, and potential prognosis. And I think it's very important, as Professor Hannibal once said, that you must think whether if you were in such a situation, would you like to have a decompressive craniectomy done or not? I think that's very, very important to consider the outcome, the prognosis, and consider the burden on the patient and on the family. Simple and standard ICP thresholds alone are not sufficient to determine eligibility for secondary decompressive craniectomy. Sustained refractory ICP elevations in conjunction with other clinical parameters, examination, imaging, non-invasive technologies, other monitoring modalities, status of underlying brain physiology should be considered when making the decision to perform secondary decompressive craniectomy. ICP monitoring should continue after secondary decompressive craniectomy. Thresholds for intervention after decompression may be reconsidered. We recommend a large decompressive craniectomy with opening of the dura to effectively reduce ICP and reduce incidence of secondary cortical injury from reduced venous drainage. Bifrontal or unilateral are options in the surgical treatment of diffuse TBI. Skin incision should be larger than the intended craniotomy and pinna should be avoided. Bone flap size should be large and incorporate removal of bone to the middle cranial fossa floor for both unilateral and bifrontal decompressive craniectomy. The dura should be opened and primary dural closure should not be performed. Expansile dural graft should be used. sutured neuroplasty or onlay. So it's not necessary to suture, but would be good. Avoidance of techniques that will contribute to secondary injury is important. That is galeal adhesions to cerebral tissue, migration of dural graft material, excessive graft or hemostatic material volumes. So the areas of disagreement or uncertainty regarding surgical techniques were the optimal materials for neuroplasty. And I suppose that was because in lower and middle income countries, it is very expensive to use artificial dura. So people use mostly pericranium or facial lata or, or galea. And the necessity of sutured expansile neuroplasty, whether you should suture it or leave it open, and the role of lobectomy and contusion removal. The method of bone flap storage, again, because very few places in lower and middle income countries have access to bone banks. So people might be putting the bone flaps in the abdomen. We have seen them being placed in the occipital region. And today I saw one patient who had come with a bone flap in the thigh also. So the other point was the removal of bone overlying the superior sagittal sinus when performing bifrontal decompression and superior sagittal sinus division. And the role of hinge craniotomy was left for further discussion. So the Neurotrauma Committee looked at the guidelines in different countries and wondered how the lower and middle income countries could develop guidelines for brain injury. And this very good paper was done by Andres Rubiano from Colombia on recommendations of the Colombian Consensus Committee for the Management of Traumatic Brain Injury in Pre-Hospital Emergency Department Surgery and Intensive Care, beyond one option for treatment of traumatic injury, a stratified protocol. And myself and Dr. Mumtaz, we wrote an article on it, commentary on it, from standard-driven protocols to resource-driven guidelines for neurotrauma management in low and middle income countries. I think these two papers need to be studied by the young neurosurgeons. It would give them different options regarding management of brain injuries. I just want to move to something else. A very interesting paper, Best Tip Trial, written by Chestnut and all, provided the only tested non-ICP monitored treatment protocol. This trial found no evidence of outcomes difference for monitored and non-monitored patients. And this trial compared ICP monitored patients versus non-monitored patients, that is by imaging and clinical examination, called the ICE protocol. And then this paper was published talking about consensus-based management protocol, revised protocol for the treatment of severe traumatic brain injuries based on imaging and clinical examination for use when intracranial pressure monitoring is not employed. So it's not a substitute, but a supplement for empirical evidence. And the idea is that to decide when you want to do a decompressive craniotomy or when you want to continue with the initial treatment. So efforts to provide for the vacuum left by absence of evidence-based guidelines, and it was done by 43 intensivists and neurosurgeons. And the management protocol was looking at the Marshall score on CT brain and doing interval CT scans, looking at the clinical score due to worsening and the pupillary response. So it was a 4-tiered management response. Just want to move on to the consensus on cranioplasty. So this was done in 2018 in the ICRAN in Naples by Professor Corrado. The paper is still not published yet, but it was discussed that why cranioplasty is important. People thought initially that it is just for cosmetics. No, it is to restore physiology. It can help in reducing hemiparesis. It can help in hydrocephalus and help in headaches. And the thing which we discussed was the timing, the material, whether to use a VP shunt or EVD, and how important it was. Discussion was based around the material, whether autologous or homologous, methyl mercurate, titanium, 3D printing, or PEEK. The cranioplasty complications are there, of course, that because of the storage in the abdomen, infection in storage area, infection after cranioplasty, bone resorption, hematoma, formation, and seizures. And very important in decompressive craniectomy, we must realize that when we do a decompressive craniectomy, you are going for 2 surgeries, not 1 surgery. So we must be very careful in what we are doing at that time. So we can think of hinge craniotomy. It's a technique where bone flap is left attached to the temporal muscle and may or may not put a couple of loose sutures, so that can save you a second operation. And some preliminary work is being done on it now, and we are looking towards a study which would be very good to see whether this can be helpful in, especially in lower and middle income countries. So this is the thing which we started back in the 90s, that importance is how to prevent yourself and your family from head injury. I think that should be our goal, so that we can prevent decompressive craniectomies. Thank you very much.
Thank you very much, Professor Khan, for a wonderful and comprehensive update delivered so succinctly, and bringing other relevant studies together as well. And I can't see very many questions coming quite yet, and I think we are doing relatively well in time. So perhaps maybe I could, I'd like to ask one question. You talked about the non-consensus of the dura or the way of dura opening. What is your view of the slit opening of dura, where you don't open the dura all the way up, and therefore you reduce the risk of the brain herniating out in a very fast speed? Has that been discussed in the consensus meeting? Was that something people talked about?
Yes, thank you. Yes, there was many ways people talked about doing it, but ultimately consensus was that no, it has to be opened, and we have to ensure that the corners are not tight, because that is where you can cause damage to the venous return, and then you need an expansile graft, whether you suture that or not was the thing. But this all were discussed, but the consensus was that it has to be fully opened and to do that. Of course, we have all had instances where literally you had to then just close the scalp and close the skin only and do that. But those are things which one has to take into consideration. I think it's important. One thing I've seen that if you delay too much, then you're running after your tail. And then, those are the patients where you get into trouble, where the whole brain literally ruptures out. So the consensus was that it has to be a fully open.
Can I ask a question, Mr. Lowe?
Sure.
Professor Khan, in terms of the dividing the sagittal sinus and the falx, do you do that? We used to, when I was an adult neurosurgeon, I often did that. But what's your thoughts on that? Is there any studies comparing both or not? Sometimes you do see frontal hyperdensities bilaterally. Very difficult to say whether this is just resolving hematoma or whether this is from the division of the sagittal sinus. Thank you.
Yes, thank you. There was discussion on that also, and I personally believe that it makes sense that if you ligate the anterior 1/3 of the sagittal sinus and then open the falx, that you make one big compartment rather than doing a bifrontal and really not joining the 2 compartments. So I think I personally, there's no studies to compare, but I feel personally that it would help in if you're doing a bifrontal correct.
And in terms of EVDs in your institution, do you use EVDs often?
So because for us, we don't have proper ICP monitors with the interparenchymal, so we do EVDs. And I remember when I was training in Belfast, we had become very good at putting it into the ventricles. People think that it might be difficult to do that, but we found even here in Peshawar, when those patients whom we don't take straight away for decompressive cranectomies, we would put in an EVD. So that helps in aspirating CSF to reduce the ICP also, and you can then measure the ICP and go for a decompressive cranectomy in a more scientific way. The ones we could not then put in a EVD, those were the patients we put on the Crevice protocol that was on GCS and regular CT scans and treating them accordingly.
Thanks, thank you.
DVDs, yes.
I can see Mr. Chris Uff from Royal London here. He has I used to be a colleague of his. He has a very large head injury practice. Chris, how has the decompressive practice changed since the rescue ICP in your department, which has the largest, I think, head injury practice in UK? Thanks. If you can join, that'll be great. But in terms of the cranioplasties, I think the two things are the infection and hematomas. And you know, the rescue ICP study, Professor Khan, I can't remember it including the complication rate of the decompressive, the cranioplasties. Did they ever combine the outcome of the decompressive craniectomy with the cranioplasties and look at whether medical or the surgical was better?
No, I don't think they compared the cranioplasties. So this consensus meeting, which was done in Naples, there a consensus was developed on the cranioplasties. I think it will be published very soon from there. And I think that gives a very good idea of what to do. And there, both in Cambridge and in Naples, this thing came out regarding the hinge craniotomy, so that you can avoid infections, etc. And it was found really that you know, if you put the bone in the abdominal cavity, the rate of resorption is more than compared to, you know, in the bone bank. So suggestion was that it should be done quicker, the cranioplasty, if you put it into the abdominal cavity.
Thank you. Mr. Uff is online. Chris, I was asking you in terms of decompressive craniectomies, since the rescue ICP trial, how things have evolved in your large neurotrauma practice.
So thanks, Naren. I think that things have become more rationalized since the publication of Rescue ICP, and I think that I think we use it more sparingly. I think that certainly with patients who we perceive have reached an age where the where the potential for neuronal plasticity is significantly less, we are less likely to do decompressive craniectomy, and we are, but I think also with those patients, we are also less likely to use barbiturate coma for them. So in a, I think also the general involutional changes which occur with age, any patient in their 70s or 60s who has a head injury which is bad enough to give them refractory intracranial hypertension that requires either barbiturate coma or decompressive craniectomy to save their life, in our experience, very few of these patients have a good functional outcome. And I think we are probably almost equally sparing about our use of barbiturate coma or our use of decompressive craniectomy with these patients.
Thank you very much, Chris. Certainly, the study had great effect, and good to know what currently is happening in your center. Prof. Khan, just a small observation. I've been in Birmingham Children's for 2 years, and I think in the 2 years, we only had to, one of my senior colleagues had to take one kid to decompressive craniectomy. It just might be that, children don't have as many severe head injuries, or when they have severe head injuries, as severe as the ones that adults have. But, our ITU liberally uses hypertonic saline and then EVD, and we somehow managed to avoid decompressive craniectomy, and the outcomes are very good. And of course, when you do take a patient to decompressive craniectomy, I think usually we are taking them quite after extreme medical management, and then the outcome is not great, I think. But once again, we have had one case of it. I know that the rescue RCP trial was on the adults. I know there's a slight difference between the pediatrics and head injury groups in the WFNS. Is there any collaboration between your committee and the pediatric neurosurgery committee to look at head injury management in children?
Very good point, Narayan. No, but I think you put planted a very nice idea in my mind. I think we should have been collaborating. Although Tony Fegacci from South Africa is part of our committee, being a very well-known pediatric neurosurgeon. But I think we should discuss that with him and with other pediatric neurosurgeons from their society, definitely.
Thank you, Prof. Khan. I'll leave it, Mr. Lowe, it's back to you. Thank you.
Thank you very much again, Prof. Khan, for a wonderful lecture and generating so much interesting discussion. Thanks again. We'll now move on to the presentation of papers. There are 4 papers following this. The first one will be by Dr. Noru Huda Maria from Pakistan on the title of The Era of Web-Based Education During Pandemic. Do we need to listen to the call of the void to take the leap of faith? Thank you, Dr. Huda Maria.
Thank you so much for inviting me to this very prestigious webinar. I'm really honored to share my work with you. Actually, this was based on our survey in which we try to evaluate the efficacy of web-based teaching and web-based lectures, especially on its impact in neurosurgical training. As in the name, as the area of web-based learning and its impact on neurosurgical training. Do we really need to listen to the call of the void to take the leap of faith? This is a very famous painting, may not be needing that much to describe because it's very famous. It is how Rembrandt would picture the anatomical lesson of Professor Nicolas Serbs if it was to be in 2020. It's a very famous painting where a very famous surgeon of that time is demonstrating the hand musculature to his students. It was originally considered as the mise en scène, that is a very beautiful name for a painting that is more than just a painting, or rather a depiction of a theatrical depiction of a very wonderful work being done in a very scenic way. So that was how he would picture the same painting in 2020. There is a simple introduction to this. As we all know that the COVID-19 pandemic has got a huge impact on every aspect of medicine. That includes interruption in the training of the residents, as routine learning activities has largely been suspended. We no longer have those long academic rounds when all the residents were questioned and thoroughly questioned, and residents knew they had to prepare the cases as well, and no more classes in the ward as well, not like the one that we have during the pre-pandemic times when all of us would be had regular CPCs or regular classes to learn. So there's a lot of hindrances in those way, and those who are junior who have just started residency have suffered the most, because these are the years when they need to learn more about neurosurgery. And academically and theories, academics and theory is very important for them to build up their residency and specialty later. So in an attempt to minimize this impact, we are very thankful to all the legends of neurological surgery and all the great mentors who spare from their very precious time to deliver web-based lectures in order to keep the neurosurgical education going. And that's a very huge step for them, and we are very thankful to them. And I think this is the responsibility of the residents to take advantage of this very big opportunity that was otherwise very difficult, especially for many of the residents, the junior ones especially. Again, I would say, because many of them need the most of this, and in those years there are much financial constraints for them to go abroad and learn and attend workshops, etc. So in an attempt to minimize this impact, much educational activities have sought the help of online teaching. With our study, we wanted to basically evaluate the efficacy of this new teaching methodology. We conducted an online survey with the neurosurgical trainees and also the junior consultants regarding their views on how the new online educational activities have been successful in teaching. A total 237 responses, which constituted about 57% trainees and 43% junior consultant neurosurgeons, and they were from 80 different countries. So what they point was 100% of them agreed that the learning from daily body experience alone, book alone, and web-based learning alone is not sufficient. 65.5% show satisfaction with web-based learning. 100% agreed that web-based learning should be combined with a textbook and also web-based training programs. 84.6% agreed that the web-based learning should be continued as a part of neurosurgical training even after the pandemic is over. 76.9% agreed that the web-based learning should be integrated as a part of future neurosurgical training. 53.8% agreed that they do not have stress during web-based learning as compared to the traditional learning programs. 38.5% agreed that they remain more attentive during web-based learning as compared to their one-to-ones and classes. On a scale of 1 to 5, 38.5% graded it to be 5, while 30.6% gave it a 4. 69.2% agreed that the web-based learning caused them to learn more per duration spent during the web-based learning program as compared to the same number of hours spent during the conventional learning method. This is the graphical picture, graphical demonstration where the agree is the decrement is being shown with the color green, and this is the color blue is showing yes. As you can see, most of the people are much satisfied with web-based learning. It is about a boosting level of 65.5%, and everyone agreed that it should be combined. So how we concluded, I guess that we have the conclusion that web-based teaching is an effective method of teaching and should be integrated in the residency curriculum and in the new teaching methodology. And it is quite evident that this is this is a digital era. Most of the people are much familiar with laptops and smartphones. Much of the time we use these devices and apps to learn and do interactive things. So many people are much more make it more comfortable to have their device in hand and to keep learning. So I think that it is going to reach out more people, and it is a much interactive way, and you can be anywhere in the world, and you can just get connected and you can learn from anyone you want to if you have the urge and the will to learn. So basically it's the part of the resident that if he has or she has the choice to learn and will to learn, then he can gain much more than just a little book knowledge. So in a world where everything is being digitalized, it is important to consider web-based learning as an integral part of neurosurgical training. Web-based webinars and conferences provide a platform where people from all around the world can come together and share their experiences. It provides opportunity to many residents from the lower middle income countries to interact with the best mentors that will ultimately lead to improvement in neurosurgical training and practice in these countries. Another thing is very important that I wanted to add here was the financial constraints. Many many of the trainees do not have that much finances to go abroad and learn. Again, this is a very huge thing, and I don't think that it is something that is free. And I think that it will be having a lot of impact later on in the surgical practices in all of the low middle income countries. People are learning day by day, and they are getting introduced to several new things that they need to know. And of course, in the web-based program, several rare cases have also been discussed, which we sparsely actually face in real, or very rarely if a resident is lucky enough. So I think that is a very good way. Again, I'm really thankful to you for listening and for your kind consideration. I guess it's a very short message for me. Thank you.
Thank you very much for a study on a topic which is very much current, and it's reassuring, I'm sure, for the senior neurosurgeons and educators to know that education or neurosurgery teaching can be conducted in a modern way, and it is acceptable for trainees or younger surgeons.
A comment from me.
Any questions here? But perhaps I could ask one question. What is your feeling about the clinical aspects of neurosurgical education? How do you feel that as we shift to the more online-based learning, the clinical aspects requiring in-person interaction is not neglected and could be augmented?
Exactly. It cannot be ignored at all, and nothing can take place of that interaction that is very important. So I guess that the only thing is that the web-based learning is augmenting that. That is, it is augmenting it. It is like when we read a book. It is just like a manual, like we buy an electrical appliance and we get a manual. That's how we treat the clinicals. That we go to the hospital, we learn, and then we have that manual to complement that. And along with that manual, we should have these webinars that actually add up and augment, like you said. It augments, it does not completely replace that, and that stands true. In this current scenario, something is better than nothing. So I guess that those who have just started training would have a better vision when they will be back to normal in the clinics. They will have a better vision. They will have a theoretical base inside of their mind, so they can just put it into practice. And those who are senior would keep on learning. They have already done in the clinics, so they will be keep learning and building on what they already have done. So in that case, it is like a continuation. It is, and later on, after the pandemic is over and everything is back to normal, may God make it as soon as possible. In that case, it will be able to augment those experiences, those clinical experiences. So obviously, yes, it is an augmentation, not a total replacement.
Okay, thank you very much. I think we'll see you back in 8 minutes. In the meantime, I'll introduce our other speaker, Dr. Rahu Srinivasan from India. He's going to give us a presentation on the association of May-Turner syndrome in spine clinic.
Hello. Hello.
Yes, we can hear you. We can see the presentation. Yeah, well done.
You can see the presentation.
Yeah.
Okay. Okay. Good evening. I'm myself, Dr. Rahul Srinivasan. I'm coming from the southern part of India. So I'll be talking about a May-Turner's syndrome, which we have encountered in our spine clinic by examples. Okay, May-Turner syndrome is nothing but an iliofemoral deep venous system thrombosis. Basically, it's due to anatomical variant of the vessels. So if you could see the IVC here being formed by the left common iliac vein as well as the right common iliac vein. The right common iliac vein has a vertical course, whereas the left common iliac has an oblique course, which it has to go from the left to right to form the IVC, whereas the right iliac artery has to go from the right to left to form the aorta. Now, this is it is at this mark that the right iliac artery has to come is just lying top with the left common iliac vein, and it can compress against the vertebral body and cause slowing and stasis of the blood flow, and it can cause DVT. Now you could clearly see in this image where the left common iliac vein is being compressed by the right common iliac artery. So this is the classical May-Turner syndrome. Now this was introduced in 1950. Later on, further literature have classified them based on CT into simple as well as a degenerative May-Turner syndrome. Now simple is nothing but the vascular phenomena what I spoke about now. The degenerative May-Turner syndrome is formed by the osteophytes, the anterior disc prolapse, as well as spondylolysis, which can cause traction or compression over the vein against the artery and cause this compression and lead to stasis and DVT. So I will cite two such examples how did we work up at all. So this is a 44 years old lady who presented to our clinic with low back pain and left leg swelling and pain which is acute, and the low back pain for which she was at outside hospital treated on traction, and obviously on examination she had a DVT features and she couldn't walk, and we immediately suggested a Doppler as well as a reference to an interventional radiologist. Now she came with this MRI where you could see that there is a degeneration in the L5 and S1, and you could see the disc, there's no gross disc herniation, though you could see the end plate changes here. Now based on the Doppler finding of iliofemoral DVT, we have done a venogram where you could see the left common iliac vein. You couldn't see the IVC because of proximal obstruction. There's some collaterals running here.
Sorry.
Okay, there's some collaterals running here, and after removing the thrombus, you could see the recanalization. Now see, still the collaterals are being seen. So now this is not a good sign. Now immediately after 2 days, she developed a left recurrence of DVT. Now this is the image we retrospectively we just saw that what is the cause of the recurrence. So we could see that all the vessels are maintaining the patency except for the left common iliac vein, which is not seen. So based on the MR venogram, which we later did, you could see the left common iliac vein is being compressed by the arteries, and you could see this right common iliac vein maintaining its patency. So this is the case 2, which 61 years old male with a history of long-standing low back pain was treated conservatively, intermittently. He was happy with that. And later on, he also had come with a left leg swelling as well as left leg pain for a few days, and then DVT signs were present. We sent him for a reference with a Doppler. Now, in this case, based on our prior experience, we directly moved to a CT venography where you could see this osteophyte being compressing the vein against the artery, and you could see the axial section clearly demonstrating that osteophyte is compressing the left common iliac vein, and this is your right common iliac vein, which is maintaining the patency, which is about to form the IVC, whereas the arteries are maintaining the patency. And in this, you could see the bottleneck appearance of that obstruction at that level. And after the stenting, we could recanalize the whole of the vessel. So follow-up is not on any anticoagulants presently. 1 year follow-up, no recurrence. So regarding May-Turner syndrome, it was initially introduced in 1950 by Dr. May and Turner, also called as Cockett syndrome. Now prevalence is on retrospective CT scan is around 25%, but only 2% will go on to develop this DVT, and it's most common in females than male. And regarding the presentation, typically it presents with all the DVT signs and symptoms, but sometimes it can present with radiculopathy, which can be a sciatica mimicker. It is due to the proximal obstruction. There will be a congestion of veins, and that can compress the root nearby the root and cause sciatica. And the clinical decision, the decision is basically by the clinical evaluation and the supporting diagnosis, which you can make by the Doppler, CT and MRI and intravenous ultrasound. Whereas the CT can classify into simple, or you're dealing with a degenerative May-Turner syndrome. And why we should treat identify and treat this, because it can cause migratory embolia and can cause stroke and TIA symptoms. So treatment includes all anticoagulation, aspiration, stenting. Stenting is the gold standard. Also, there are some literature dealing with the degenerative disc causing radioablation, but ultimately they are to also shift to stenting for ultimate recovery of the patient. So concluding my talk, so what do you learn from this two cases? The first case was a typical vascular phenomena of May-Turner syndrome. So she had been put on the intermittent traction, and already there was anatomical narrowing at that particular point. So traction has triggered her, and that's how she developed the DVT. And the second case, it's due to the osteophyte, which has caused the compression of the vein and which has led to the DVT. So all this case gives an insight that how if some case presents in such a way, so how to work it out, and always you have to ask the radiologist to look around the venous abnormalities around the spine to pick up the one such syndrome. Thank you. Thank you so much. This is my hospital. Yeah. Hello.
Yeah, thank you very much for educating us with this interesting phenomenon and sharing your successful experience in treating it. I just wonder, with so many people with wear and tear problem in the lumbosacral spine with bilateral claudication, how many of these we may be missing, or just attributing it to neurological leg problem rather than a vascular phenomenon. What's your view on that?
So this is very rare actually. What we have in our 5 years experience, we have seen only 2 cases. That's what I have presented now. But it has to be always thought of. There is some kind of, you can get a compression at that particular site, and that can lead to this claudication, those kind of. And very rarely, some literature has been quoted that even it can present mimic as an sciatica mimicker. So due to the congestion of vein compressing. So everything can be demonstrated. Basically, you have to ask your radiologist, and you have to sit with the radiologist to find out what is the problem. Yeah.
Thank you again. I would now like to invite Dr. Huda Maria back to present her next talk on the comparison of surgical clipping vs endovascular coiling for posterior projecting anterior communicating artery aneurysms.
Hello? Hello, can you hear me?
I can hear you.
Okay, and can you see the slides as well?
Yes, we can see it.
Thank you so much. Again, thank you so much for inviting me. Here we are sharing a very short experience of comparison of surgical clipping versus endovascular coiling for posterior projecting anterior communicating artery aneurysms. As we all know, we usually deal with the anterior and superior projection of anterior communicating artery aneurysms. So here we want to basically just share this experience that we wanted to evaluate the feasibility, the results of endovascular treatment using coils in patients with posteriorly projecting anterior communicating artery aneurysms, and we wanted to compare the surgical clipping procedure with the endovascular coiling procedure for the posterior projecting anterior communicating artery aneurysms in terms of perioperative technical feasibility and the possible complications such as rupture, perioperative complications, and post-operative mortality and morbidity. As we can see that about 3 to 40% of the intracranial aneurysms are the ACOM aneurysms, and 10 to 15% of them are of the unruptured ones, are the ACOM ones. ACOM aneurysms are more likely to rupture than the other types of intracranial aneurysms due to their anatomical and hemodynamic characteristics. Most of the time, we deal with the anterior and superior projecting, as I have told before. For posteriorly projecting aneurysms, the recurrent artery of Wimner and the contralateral A1 segments can be injured while exposing the aneurysm. As we all know that they do have perforators as well, and so in that way, the posterior projecting inner artery and ACOM aneurysms are very tricky to deal with during surgery, and usually we have to go through the intrahemispheric route, as we all know that, or that's a bit of a cumbersome thing because you have to take the proximal control as well. That is very cumbersome in the intrahemispheric approach. So and obviously you have to expose the dome first, and that way some people use the supraorbital ones so that they can just address the both problems, or they can just do into a low intrahemispheric approach and the combined hybrid as well. But here, when we have to have got this endovascular techniques available, actually this paper has been in collaboration with our angio suite, where I also work for that as well. So we can just evaluate that it is a very easier way to do a coiling that is very short duration and very easy to do, much easier than the surgery. In fact, it is much easier than the surgery for aneurysm at all if the conditions are met by the aneurysm, or all those that are being met with the endovascular one. So for the posterior projecting aneurysm, very coronary, and however the risk of rupture for posteriorly projecting aneurysm was found to be less than that as compared to that for the interiorly projecting one. Maybe it is due to the incidence, which is because the anterior projection ones are much calmer, or otherwise obviously the hemodynamics are in the favor of spurting into the anterosuperior route. That is the way it is more common as well, and not in the posterior route, that is antigravity. The materials and methods, actually we studied 6 cases with a posterior projecting ACOM aneurysm. 3 of them were operated by surgical clipping and 3 underwent endovascular coiling. The average age of the patient was 52. 90% of them were hypertensive and 80% were smokers. All presented through emergency with subarachnoid bleed. 2 of them and each surgical and endovascular group presented at ER with an HNH of 3, the other were at HNH of 2. The average time for hemorrhage to surgery was about 22 days. An outcome assessment was done using the modified Rankin score of disability, and the score 2 was considered to be satisfactory. The results showed that the surgical treated arm, 2 patients had an MRS of 2, while the third one has an MRS of 4. In the endovascular coiling group, 1 had an MRS of 1, 1 had an MRS of 2, and the third one has an MRS of 3. Although there is a big difference, but we can say that in the endovascular group, at least 1 patient had an MRS of 1, while none in the group of the clipping one had the MRS score of 1, while 1 patient in the clipping group reached the score of 4, while none of the coiling group reached a MRS score of 4. So the worst was the 3, the MRS of 3, that was the worst one. Actually, this is already an observation-based study where we have actually noticed that all such aneurysms do have a better result and outcome using those endovascular coiling techniques. So we can say that it is slightly better to perform the endovascular coiling for such patients. And nowadays they are also performing flow diverters and web services, that is the vascular web, not much used in the ACOM, but flow diverters and etc. So we can conclude that endovascular coiling is much better in treatment of the posteriorly projecting anterior communicating artery aneurysms. The truth, that's the truth be told, that actually, again, I want to say, and I want to emphasize that it is basically depend upon the individual, expertise, the individual expertise of your surgeon, who all those surgeons who are dedicated vascular surgeons can do it easily and do have good results. But since there's a lot of new generation that is coming up, and we have a lot of workload in the hospital as well, I personally believe that the learning curve of such surgeries is a bit, it's steeper. So, and we, all of us are not much exposed to independent vascular cases as well. So in that way, I think that being a neurosurgeon, we should also learn the endovascular techniques. These are much shorter, much safer, as compared to like in the pandemic situation, like nowadays in COVID-19. Much of the cases of aneurysms can be well operated using the endovascular route. So we do admit that this is operator skill based and lacks experience hand. We state that to meet the criteria for endovascular treatment. Thank you so much for listening to me and for your kind consideration.
Thank you again for a second presentation.
Will, can I ask Mr. Kyrillos and Professor Mr. Kyrillos, do you have any thoughts on? I know it's a small case series, but Dr. Noor has presented it nicely. How would you manage? Is it endoscopic or endovascular or clipping in your practice?
If you, because endoscope was introduced a little bit later at that time, if you are familiar with microscopic view, it adds very little to the practice. Not saying that every time you put a clip, it is perfect. But don't forget, every time you introduce your endoscope, you have to be really familiar. You can cause injury as you introduce that. It's not that easy.
No. Thank you. Thanks a lot. That's brilliant. Well done again.
Thank you.
Dr. Noor, any other comments? Okay. Thanks, Will. I'll give it back to you.
So much.
Well done.
Thank you. Yeah. So we'll come to the last presentation of this session. This will be delivered by Dr. Shekhar Ramesh from India. The title of his presentation is Bobble-head doll syndrome in multiloculated hydrocephalus. Dr. Ramesh, please. Thank you.
Dr. Ramesh, yeah, that's. Dr. Ramesh, do you want to share your presentation? Thanks. Dr. Ramesh? Dr. Ramesh? Might have, while we still have time, while we are on it, Professor Quintana, can you hear me?
Yes.
Hello, welcome, Professor Quintana.
Hello.
It's an honor to have you here. Certainly, we had a vascular talk, and it will be good to hear your views. I know that you're a doyen of vascular neurosurgery, Chile, South America, and world. In Chile, how has the practice changed in terms of microscopic to endovascular management of aneurysms?
Oh, yes. I want to say some words related with the doctor.
Please.
With I think all depend on the school you are studying.
Mm-hmm.
In my clinic, surgery over endovascular may be 80 against 20%.
Mm-hmm.
So the case that the doctor presented about the a common arrest in the posterior direction, usually we perform taking account the relation of the neck with the dome.
Mm-hmm.
Because all the aneurysms are not the same relation between the neck and the dome. The other point is to avoid the artery of central artery of corpus callosum. If we have a very clear imaging from the radiologist, usually we perform surgery because it's very easy.
Mm-hmm.
to enter with the dominant A1, avoid, of course, humeral artery, and you can see really freely the neck, A2 contralateral, A2 ipsilateral, and you dissect the two A2 and put the clip. And after that, of course, there is a revision of where is the clip is located. But I think if you have a very good endovascular, you can discuss with him. If he agree, he can put the coils. But the first option in my clinic is clipping. That is my experience, and that is my school. Maybe old school, I don't know. But the percent is 80% clips, 20% coils.
Thank you, Professor Quintana. Professor Kyrillos, what's your percentage? And if Mr. Christoph is there, what's your percentage? Thanks. Ramesh?
Yeah, sir.
appears that Dr. Ramesh
is away.
oh,
Okay,
you mean you mean
Kyrillos.
Okay.
Shall I continue?
Just a second, if I can just bring
Hold on.
Mr. Kyrillos. Ramesh, Kyrillos, in your practice for these aneurysms, what would your preference be, endovascular or clipping, the ones that Dr. Noor showed? Maybe we are not connecting. So we'll go back to Dr. Ramesh. Dr. Ramesh, do you want to?
Yeah.
Thank you. Cheers.
Good afternoon, everybody. Coming to a presentation on FLASH. We have a bobble-head doll syndrome in a kid with a multiloculated hydrocephalus. So it was initially described by Benton et al. In 1966. It is characterized by rhythmic forward, back and forth, or side-to-side nodding of head and neck on the trunk. It is usually associated with arachnoid, suprasellar arachnoid cyst, or craniopharyngioma, or choroid plexus papilloma, cavum septum pellucidum. It has been reported in for most of the etiologies. So our pathophysiology is unclear. What happens? What is the reason for it? But there are so many mechanisms proposed, being there is a dysfunction of the thalamic and red nucleus or its connections. But Weiss et al. Has clearly shown that it is a learned behavior by which they intermittently empty the cyst so that the pressure comes down. His thesis was also supported by serial metrizamide CT cysternography, which documented the decrease in size of the cyst with bobbling movements. Even we have published suprasellar arachnoid cyst presenting with bobble-head doll syndrome way back in 2015 in three cases. Now this is a case where a 20 months old child, known case of hydrocephalus treated, now presented with excessive cry, vomiting, and abnormal head movements. He has delayed milestones, unable to hold neck, unable to sit without support. You can see the movement. In this case, it is a side-to-side movement. And once he calms down, he starts irritability, slowly starts its movement. After the movement, he again calms down. This was at hospital. He was having repeated nodding of the head side to side. Coming to his child, this was the first scan done at 6 months of the age, diagnosed to have aqueductal stenosis, and right ventricular peritoneal shunt was done at local hospital. But a child had ventriculitis and meningitis, which was managed conservatively. Child had delayed milestones and irritability. They were managing conservatively. Interval CT scan done showed built decompressed ventricle except for trigone of lateral ventricle and right side, and some loculations in the left side. So and they have been managing it conservatively. At 20 months, child presented with abnormal head movements with excessive cry and vomitings. This is the new neuroimaging showing multiple loculations, the right temporal, left temporal, and left frontal. You can see the sagittal image. Everything is loculated and not connecting, leading to no Sulci-Gere pattern here. So the child was under having raised ICP features. We have taken up, as any multiloculated hydrocephalus, aim is to communicate all loculation into a single cavity and drains through a shunt if feasible, endoscopy if anatomy is conducive. But in this case, anatomy was not conducive. We cannot see the third ventricular floor. So we went with a breakage of loculations into a single cavity. As it is a flash oral presentation, I'm not showing the video. It helped the child post-operatively. There's a significant decompression of the ventricles on left side, and we are following it with this right temporal horn trigone region. So as of now, child is improving clinically. Started walking without support. Now is with support initially. Afterwards, walking without support. Total abnormal head movements all disappear. So as we know, multiloculated hydrocephalus is multiple separated isolated compartments which may progressively enlarge. It is the most difficult form of hydrocephalus to read. It can present with just like any hydrocephalus, but in our case it was a Bobble-head Doll syndrome along with the raised ICP features. So our literature, sir, did not reveal any association of multiloculated hydrocephalus with Bobble-head Doll syndrome. Thank you.
Thank you very much, Dr. Ramesh. Impressive imaging and nice videos. Can I just ask, when the video that you showed, the child had the Bobble-head syndrome or movement of head in a supine position, and you've mentioned that the child has poor head control because of his illness. How certain are you that that is not just his movement of the head, which hasn't gained anti-gravity strength yet, and rather than a repetitive left to right movement itself?
So actually, even we were in that doubt whether it is really a learned behavior or a Bobble-head Doll movement. So the only thing that when the child was made to sit with support, head was lagging on the neck, on the trunk. He was able to support, but he was lagging because of the pressure symptoms, I suppose. But there is a clear-cut change after the surgery or due to decreased symptoms. He's nicely holding the neck. He was not able to hold the neck previously. Maybe he has that power because of the heaviness of the head. He may be lagging.
Okay, so I guess what you're saying is there is still a degree of uncertainty, or maybe there are two components to this. One is
definitely, but he was not holding neck without support. That's for sure. He was able to do it with the when gravity is removed, but in gravity presence, when he was holding in the lap, he was slowly keep going forward, backward to lean onto his mother, and he was not able to control his. Either he should say that whenever the child is developing milestone of head holding the neck, there is a midway between the lagging and the neck holding. He was in that phase.
All right. Thank you very much. So this brings us to the end of this early afternoon session. Thank you very much to all presenters and also the keynote lecturers for the afternoon. And I'll hand back to Mr. Naren, and he will let you know about the next session, which will happen very soon. Well, we are going to have a coffee break now from London time 3:30 to 3:45.
Well, can I just make a comment before we close it? Sorry, I was on mute when I talked. Beg your pardon. So thank you very much, Mr. Lowe, for a fantastic moderation of this session. We had a really great session. We started with Professor Unterberg giving us a panoramic exposition of the current state of glioma surgery, and then we also had a lecture from Professor Tariq Khan on the current consensus regarding decompressive craniectomy. We had a lovely lecture at just now, talk on Bobble-head, which was resolved, and also the nice May-Thurner syndrome that Dr. Rahul showed us that we can keep us in the back of the mind. Dr. Noor gave again two really nice presentations, one on the endovascular and versus surgery, and also on the use of web as a tool for teaching even after, hopefully, once the pandemic is over. What we have is a fantastic evening session as well. I'm sure you have seen the program. There are many highlights, and we'll start in about 15 minutes. How are we doing? We finished exactly on time. So we have 15 minutes, and we will have running up to the lecture from Professor Dr. Robert Spetzler, Dr. Michael Lawton, and then Dr. Servio from Argentina on their series of brainstem cavernomas, and the talks from Nairobi, and a fabulous session left. So please stretch your legs and have a cup of tea, and we'll meet again in 15 minutes. Thank you very much, everyone. Thank you, Mr. Lowe.
Thank you.
Thanks a lot, Will.
Thanks, Naren.
When you're in the train, you can follow us. Thank you.
Yes, I better go and see my patients now.
Good.
I've neglected them for a bit.
And get your little daughter to join us on the webinar for the weekend. She should be ready for neurosurgery very soon at the rate you are training her.
Any excuse to watch the television or a computer screen, I'm sure she'll want to do that. All right.
Excellent.
Okay.
Thank you very much. Take care. Cheers. Thank you.
Hello, dear friend. Hello, Naren. Hello, Naren. Good evening from
Hello, hello, Nicholas. How are you? Nice to hear your voice. Let me see you. Hello, how are you?
a little bit terrified from
Oh, you'll be
coronavirus.
fine. You'll be fine.
Okay. Naren,
Yep.
may I make a question?
Mhm.
I don't know how is the procedure about the posters. I have to send it to you and
Yes, yes. If you send it to me, then I'll post it on
okay,
on our website, and then people can view it tomorrow and then ask any questions.
okay. I will send it to you with an email. Okay.
Yeah, please. Thanks. Is that okay?
Thank you very much.
Thanks a lot.
We are okay with the time. Yes, with the
Yeah,
schedule.
we are very good. We are very good with the time.
Greetings also to Boris and to Desiderio.
Sure, sure.
Where are these guys? I was expecting to meet them also here, but
They are working today. Hello, Maurizio.
Hello, Naren.
How are you?
Fine.
Great to have you. Thank you very much.
Thank you. Thank you to you for your friendship and consideration. Thank you.
Privilege.
No, it's privilege for me.
Thank you, sir. Thank you. I'll just have a, we are doing good in time. Let me see who's the next speaker. Let's see. Yes, Dr. Manga. Good. I'll just see Dr. Manga is here.
Good evening, sir.
Oh, you are there? Great. Thank you.
Yes. I can upload my presentation?
Yes. What's your name? What name are you under, Dr. Manga? Dave.
Dave.
Okay, Dave.
Yes.
Good. Excellent. Good. So we are on time. So yes, if you could please upload. Maurizio, are you ready?
Yes.
Excellent. So good afternoon. Welcome back to the late afternoon or early evening session of the World Neurosurgery Webinar Conference. We had 3 great sessions already and promises to be another 3 absolutely wonderful, in a interesting and thoughtful and informative lectures. We are going to start with Dr. Dave Manga, and we have got talks from Professor Quintana. We have got lecture from Professor Spetzler, talk from Dr. Russell Andrews, and then finishing off the night with a lecture from Dr. Lawton. So it's also my distinct pleasure and honor to introduce Professor Maurizio Iaconangeli. He's the professor and chairman of neurosurgery at the Department of Neurosurgery in Ancona. He's a great surgeon with his interest in skull-based surgery, but a great educator, and runs fantastic course in Ancona where I go and enjoy teaching. So thank you very much, Professor Iaconangeli, for joining us. So without
Thank you, Naren, for the opportunity and this great educational opportunities for me and for all the attendees. Thank you.
Thank you very much, Professor Iaconangeli. We have also got fantastic participants with many distinguished neurosurgeons here as well, so we can always call upon them to give their thoughts on the talks. So without further ado, may I please invite Dr. Dave Manga to give his talk on the assessment of severe head injuries in Kenya using the Helsinki computer tomography. Dr. Dave Manga is originally from Mauritius, and now he's just finishing his residency in Kenya. So welcome, Dr. Manga.
Thank you, sir. You can see my slides and can hear me?
Yes, absolutely. Yeah.
So thank you. Good evening, friends. I'm Dr. Dave Manga from University of Nairobi, Kenya. So I will be presenting my topic is an assessment of the prognostic value of the Helsinki computer tomography score in severe traumatic brain injury at Kenyatta National Hospital. This was my master thesis, and at Kenyatta National Hospital is one of the referral hospital in Eastern Africa and is affiliated with the University of Nairobi. So I have no disclosures. So traumatic brain injury is considered as a global burden which confer the high morbidity and mortality. Hence, it is important to determine a classification that correctly diagnoses and predict its outcome. Even though in the early assessment, the GCS provides clinical information, it is restricted in determining structural brain lesions. And the GCS is error-prone in patients with alcohol intoxication, sedation, and intubation. In the European Brain Injury Consortium in 1998, the GCS was found to be reliable and accurate in 56% of severe TBI. So millions of CT scans are done yearly, and these CT scans, they contain information that can be used to determine prognosis. In comparison with developing countries, some developed countries have other modalities like biochemical markers, ICP monitors, which are readily available and not expensive in developing countries. So currently there are several CT scan scores which exist. We have the Marshall CT scan score, the Rotterdam score, the Stockholm score, and the Helsinki. The latest one being the Helsinki score, which was developed by Raj et al. In Finland in 2014, where they studied in the period of 2009 to 2012, 869 patients and correlated them to the Glasgow outcome score and found that it was able to prognosticate outcomes of mortality and disability at 6 months. It is like the Rotterdam score. This score is easy to calculate and more granular. So what does this score constitute of? It constitutes of the hematoma type, where it is given specific points for the different lesions, the hematoma volume, the IVH. The IVH presence is given more points as compared to the other lesions, as has been shown that the IVH favors more unfavorable outcomes, and the suprasellar system status is weighted as compared to other systems like the Marshall score, as which evaluate the basal systems. In total, the Sun score ranges from -3 to 14. In the study, in the original study of Raj et al., we found that the prognosis at 6 months for mortality ranges from 3% to 79%, and for unfavorable outcome from 71% to 94%. So why the Helsinki score? In Telling et al. In 2017, what he did, he evaluated the Helsinki and the Stockholm score in a large cohort of 1,015 TBI patients in 2 large centers in Europe. And in the analysis, they found that both the Stockholm and the Helsinki score outperformed the Rotterdam and Marshall score. Yao et al. In China, what they did a retrospective study, cohort study, where they analyzed the relationship between the initial Helsinki score with the Glasgow outcome score at 6 months in 302 patients. They found that the Helsinki score was deemed to be an independent predictor of mortality and unfavorable outcome. They also noted that the Helsinki score was also precise in predicting mortality with an accuracy of 74.5% and unfavorable outcome at 71.5%. So in Kenya, being a developed country with a limited intensive care facilities, it was necessary to incorporate new outcome predictors for severe TBI patients to canalize resources to patients. Moreover, the Helsinki score having outperformed previous CT scan scores in the European and Asian continent, it was necessary to assess its clinical utility in the African subcontinent. So what we did, our broad objective for this study was to investigate the prognostic value of the Helsinki score on the outcome of severe traumatic danger at 6 weeks post-admission. Our specific objective was firstly, we established a baseline GCS of physiological parameters and demographic characteristic. Then we evaluated the predictive value of the 6 weeks of the Helsinki score. Then we did a correlation analysis of the Helsinki scores and the clinical parameters on the outcome of severe TBI patients at 6 weeks interval. So our methodology was this study was a prospective observational study which was carried out over 4 months. The location was at the Kenyatta A&E and the critical care unit. So how we did it, we patients with diagnosis of severe TBI was recruited, and those met the inclusion criteria. The data was collected in a standard questionnaire. Initial admission CT scan, Helsinki score, and the clinical parameters were evaluated. Then the patient was followed for 2 weeks and 6 weeks post-injury. We estimated the mortality, favorable outcome, and unfavorable outcome at 2 weeks and 6 weeks. And then we did an association of the Glasgow outcome score with clinical parameters, GCS and Helsinki. We performed logistic regression analysis to determine which one is an independent predictor of outcome. And we also calculated the sensitivity, the specificity, and the area under the curve for the Helsinki score. So what we found in the results. So first of all, in the post-association GCS, we group it in 3 groups. And then we found that in the GCS of 7 and 8, the number of deaths was were 23 patients with a number of deaths of 14, for 5 and 6, 16 patients with a number of deaths of 10. Between 3 to 4, there was 3 patients, and all of them passed away. So as we saw, as the GCS improved, the mortality decreased. For the Helsinki score, as I told you earlier, it ranges between -3 to 14. We found that we calculated the initial Helsinki score on admission and found that the largest group constituted of patients with score of 9 were 15 patients out of 42 patients, with a resultant mortality of 66.7%. Patients with a score of 4 had a 33.3% mortality. Those with Helsinki score of 11, there was 100% mortality. In terms of the Glasgow outcome score, we determined it at 2 weeks and then at 6 weeks, and we dichotomized it into unfavorable outcome for Glasgow outcome score 1, 2, and 3, And then for 4 and 5, it was a favorable outcome. So what we found was most of the mortality was occurring at 2 weeks interval at 2 weeks interval in the 25 patients passed away at 2 week interval, whereas 2 patients passed away at 6 weeks interval. So at 2 weeks, there was 25 patients which were dead, 7 patients were in persistent vegetative states, 9 patients was severe disability, and this constituted the unfavorable outcome, which came up to a 97.6%, and the favorable outcome at 2 weeks was 2.4%. Whereas at 6 weeks, there was 9 patients who had favorable outcome, which constituted 21.4%, and 33 patients had unfavorable outcome at 78.6%. Then we did the correlation analysis of the Glasgow outcome score with the Helsinki score on the outcome, and we found that for the GCS of between 3 to 4, there was a 100% unfavorable outcome. For 5 to 6, 87.5%, from 7 to 8, 69.5%. Whereas for favorable outcomes, they were only present in the group of GCS of 5 to 6 and 7 to 8. Whereas the Helsinki score, we found that as the Helsinki scores increased from 4 to 11, the outcomes worsened from 33% to 100%, and all patients with a Helsinki score of 3% had unfavorable outcome, whereas those with a Helsinki of 2 had favorable outcomes. So in summary of the results, using the Spearman correlation analysis, we found that the Helsinki was significantly associated with the Glasgow outcome score at 6 weeks, and for mortality with a p-value of 0.09. Though there was no significant association with a GCS, which was not statistically significant, the GCS remains a strong predictor. Other variables were used to analyze for correlation were sex, age, systolic blood pressure, random blood sugar, and the pupil reaction. And only the age was statistically significant correlated with the Glasgow outcome of 6 weeks and mortality, and the systolic BP at 0.043. Then we did we performed a logistic regression analysis to see which one can be Helsinki can be an independent predictor of outcome, and we found that it had an odd ratio of 9.1 for mortality and odd ratio of 5.6 for unfavorable outcome. And then we did a receiver operating characteristic curve analysis to see the AUC values, and we found that the Helsinki has a AUC value of 0.71 for mortality and 0.69 for unfavorable outcome. The specificity was 88.9% for mortality, a sensitivity of 53.3%, and for unfavorable outcome it was 88.8% and 55.6%. So in this study, we analyzed 42 patients. Majority of our patients were male, with a ratio of 9.1 in comparison to previous local study done by Bogombe et al. In 2007, which was 5.1. 25:1. The mean age was 33 years old. At previous studies by Anderson et al. In 2011 found that it was 46 years old. The mortality rate was significantly higher, 64.3%, which was higher as compared to the local study done in 2015 by Mohan et al., which found 51.3%. The average time to CT scan done was from time of injury was 11.45 hours. The average time to surgery from time of injury was 12 hours. So 45% of our patients needed surgery, and among those 45%, 60% of those patients passed away. Our average number of days to mortality from the time of injury was 3.7 days. In previous study in 2015, it was found that the average days were 13.7%. So the most frequent cause of injury in this study was road traffic accident followed by assault. In this study, we also found that as the GCS improved, the mortality decreased and also the unfavorable outcomes also decreased. The values of the AUC we got were consistent with the studies by Yao et al. And Raj et al., the original study, which imply that the Helsinki score has a moderate discriminating ability to predict mortality and unfavorable outcome at 6 weeks. So in conclusion, we found that severe traumatic brain injury still is a frequent source of mortality and acquired permanent acquired persistent disability among young individuals. So this study has shown that the clinical utility of the Helsinki score in predicting outcome to severe TBI and has correlated well to 6 weeks. So hence we think that we change to a newer computed tomography score may be warranted, and the Helsinki score can be used as a predictor of outcome in the Kenyan population and in the African population. These are my references. Thank you.
Thank you very much, Dr. Manga. Congratulations on a very well thought out study. I will see. I'll ask the first question now, while others put any questions for you. The question for me is that one of the problems that I have with the prognostic score is that they are very good in terms of giving you a probability, but they don't exactly answer definitely the outcome. So to apply to an individual patient is always difficult. In the sense, if it is your mother or my mother, I rather you do everything and then see things go from there, rather than predicting prognosis from the outset from a CT scan. But do you see this as a way of prognostication and talking to patients, or do you see this Helsinki score useful in terms of auditing your results, that for different scores the outcomes are the same year after year? What's your thoughts on that?
My thoughts, first of all, is the Helsinki score. It can be used, for instance, if you have, because remember this study, we did it on severe traumatic brain injury patients. It's not on moderate or mild injury patients. So in severe traumatic brain injury patients, we must know, are we going to intervene? Are we going to, because the question comes in developing countries, we have limited resources as compared in developing countries, we have limited resources as compared to developed countries. So it's basically this prognostic value for a decision-making process to inform what are we able to canalize those resources to this specific patient or not.
Sure, I think you make a very good point in a circumstances where resources are not necessarily open. Any questions from the audience? Maurizio, do you have any questions for Dr. Manger?
It's very fluent and clear, at least for me.
Yes. Excellent. And are you going to use this when you go to Mauritius, Dr. Manger?
Yes, because the thing is, the question is now, we have evaluated it, we have seen that in European continent, it has been validated, in the Asian continent has been validated. So now this is the first study that is done in the African continent about the Helsinki score. So the thing is now, I will try to, before even using it, my next step will be to see the differences, which score is better, the Marshall, the CT scans, the Helsinki, and then see further forward how we can use the Helsinki score.
And you might also even try to think whether there's a score that you can develop that's better suited for your local. Well done. Thank you very much. So I'm going to pass the baton to Professor Maurizio Iaconelli to chair the next talk, but I will get Dr. Julio Martin to share her presentation. Thank you. Dr. Martin, you should be able to share your presentation.
We see you.
I'm trying. Do you see the presentation?
No, we see you.
Okay.
Better than presentation. No, I joke. The presentation will be good as well.
I'm trying.
The title is a metabolism-related gene profile as a prognostic biomarker source in primary glioblastoma.
Yes.
Good. Excellent.
Okay.
Do you see it now?
Yes, you put on presentation mode.
It's okay now?
Yes, perfect.
Okay. Thank you very much. Well, good afternoon. My name is Julia Martin. I'm a third-year resident from Reina Sofia Hospital in Córdoba, Spain, and I'm going to talk about metabolism-related genes profile as a prognostic marker source in primary glioblastoma. First of all, we did focus on this type of tumors because it's the most frequent primary malignant tumor in brain. For the past century, the classification of the CNS tumors have been based mostly in the neuropathology of the tumors, but recent studies in the last decades have clarified that the understanding of the genetic basics of these tumors may contribute in the classification of the tumors. So in the 2016 classification of the World Health Organization included the IDH gene as a part of the classification. So we have a mutant, wild type, and not otherwise specified. Apart from this, also other molecular classification that includes more genetic factors of gliomas can help in distributing it in different types. That for us, the most important is the mesenchymal type, that would be glioblastoma. That gives information of prognosis, survival, different clinical subtypes, biomarkers that may give us predictive, prognostic, and diagnostic information, and maybe in the future will provide us for some new therapeutic targets. So for the metabolism of glioblastoma multiforme, and to help us to select the genes that we were going to study, we did based in the biology of high-grade tumors in general, that they have increased glycolysis, decreased ATP production, and increased glutamine levels. Also, more specific of glioblastoma is the cellular heterogeneity, the genomic instability, and the apoptosis resistance. And also, it's really important, the metabolism of lipids, of the glutamine and of the glucose. We see that the IDH is part of the Krebs cycle, that is related to the lipid synthesis, and it catalyzes the oxidative decarboxylation of isocitrates in alpha ketoglutarate, and it's bound with tumor growth and treatment resistance for glioblastoma. So, as we see that the mutations of the IDH gene have demonstrated to be able to distinguish or to set differences between the glioblastoma, the aim of this study was to determine the prognostic value of other metabolism gene related, depending also in the IDH mutation type. So we started recollecting samples from 2016 until last year, and we have an amount of 28 patients. We used our platform, neuralgia, to obtain all of the clinical history of the patients, and CareStream to select the images. And with the Biomedical Research Institute, we performed the gene expression data with different kits and tools. So our patients, we recollected the clinical symptoms that they showed when their first time were diagnosed. Most of them had symptoms related to intracranial hypertension or focal neurological deficit or epilepsy. We did different localization to see if they were fully resectable or either when an eloquent area or frontal lobe. The perfusion grade, in the surgery we use always the 5 ALA, and in some of them intraoperative monitorization. We also see after the neuropathology, and all of the patients selected were with total resection, and in all of them they give all the adjuvant treatment with chemotherapy and radiotherapy. For the study of the molecular data in the surgery, we gave samples that were freeze under -80 Celsius degrees. We later processed it and obtained the RNA information. Then we quantified it and used all of the process with the help of the Institute of Investigation to finally obtain the levels of the genes. After that, we did perform the statistical analysis, first descriptive and then univariant, and after multivariant, to see if all of the different variants we have may be related between them or just one by one, because this was a preliminary study and we didn't have as much patients as we would like to. So in the descriptive analysis, the age of our patients was around 60 years, 55 plus minus 9. There was a slight predominance of female patients. All of them were primary glioblastoma, and all of them were IDH wild type. They have lobar distribution, and in all of them we did the total resection. The time to progression established with the MRI image was 23 weeks, more or less, with 18 weeks, and the survival rate in our patients was 20 months. From the 39 molecular variables that we studied, there were some of them described as risk factor. First, we did perform the univariant analysis, and after that, we did an univariant Cox regression. So in those, we found statistically significant with the p minus 0.05 in the genes that are underlined. From all of them were really important for us, the glucokinase A, because it was related with the phospholipid synthesis, and they have proven to be increased in highly invasive regions of the glioblastoma, and some studies have tried to find some pharmacological inactivation of this gene. Also, the insulin-like growing factor that stimulates cell growth and proliferation, and it's overexpressed in glioblastoma, and it has been found as a risk factor. Also, the pyruvate carboxylate that it is involved in the glucose metabolism, and it is related to the metabolic answer to glioblastoma in the absence of glucose, and it related also in the increase of growth in the glioblastoma. And finally, the serine hydroxymethyltransferase 1 that is related with cell apoptosis and the adaptation of glioblastoma. When we did the multivariant analysis, we found statistically significant results in the glutaminase and glucokinase. The glucokinase was not specific for glioblastoma because, as we said, we studied genes that were also important from highly grade tumors, but it was found to be a protective factor. And the glutaminase that was shown to be a risk factor, it has been described as increased levels of glutaminase are related with apoptosis and edema, that it benefits cell growth, and the glutamine metabolism that is important for glioblastoma, it's altered in these patients. There are not specific treatment for this yet, but there are some studies that in mouse. So we hope that in the future, as we increase the number of patients we have for this type of studies, we will be able to establish a strong relation with this, and in a future it will be target therapies that may increase the life survival time in glioblastoma. Thank you very much.
Thank you, Julia. Is there any question from the audience for this evolving field? No, no. Julia, do you think that, of course, this will be the future, I suppose, the individualized and personalized therapy. But do you think in some way the surgical treatment can be, how say, imbricated? There must be a combination with the target therapy and the surgical treatment.
Of course. There was a lecture this morning that they were studying if supramarginal resection may increase the survival time. I think that is also really important. But at some point, they always come back, and if you have a tumor in a place,
Scusa Rossella, chi è?
Of course, that is the glioblastoma is a diffuse therapy, as Scherer said in the 15 years ago. But in some way, I suppose that you are right. The extent of resection still will have a role.
And I think it's mostly important in those patients where resection might not be possible because of the location of the tumor.
Yes. Thank you.
You're welcome.
Naren.
Well done, Julio. Nice work, and I think this is the future, so keep it up. Thank you very much. So I will now introduce Dr. Lukasz Antkowiak from Poland. Dr. Lukasz, do you want to share your presentation, please? Dr. Lukasz is coming from, hello, welcome. Dr. Lukasz is coming from one of our close listserv friends, Professor Marek Mandera. So I'm really looking forward to this talk, and you have done a good job. It should generate good questions, certainly from me. Thank you.
Thank you, sir, for introducing me. I'm very grateful for being there. And I'm honored to present the results of our international multi-center study, which focused on the impact of syringomyelia on the post-operative outcomes in patients with Chiari malformation type 1. I have no conflict of interest to declare. The objective of our study was to assess the impact of syringomyelia on the short and long-term clinical outcomes in patients with Chiari malformation type 1. Therefore, our data came from 6 medical centers, including Katowice, Gdańsk, Wrocław, Szczecin, and Hamburg. Patients who underwent posterior fossa decompression with duroplasty or posterior fossa decompression with duroplasty and tonsillar resection between 2010 and 2018 were included. We have chosen those 2 techniques due to their highest effectiveness in clinical and radiological improvement, which has already been proved by recent studies. Our experience also supports this thesis. We excluded patients with significant comorbidities, such as basilar invagination, platybasia, or those who underwent previous neurosurgical procedures within head or spine. Therefore, 31 patients met all above mentioned criteria and were included in the study. Patients obtained during the hospital and also as short-term outcomes. Both clinical and radiological data were also collected at the last follow-up visit, meaning long-term outcomes. Long-term clinical outcomes were also assessed using Chicago Chiari Outcome Scale, which will be noted as CCOS later. Mean follow-up time was 45 months, ranging from 6 to 117. Finally, 31 patients were divided into a syringomyelia group consisting of 13 patients and a non-syringomyelia group composed of 18 individuals. The assessment of short-term clinical outcomes, meaning those evaluated during the hospital stay, revealed a slightly higher percentage of patients who improved in the non-syringomyelia group, but the difference was still non-significant. Furthermore, clinical improvement evaluated in the last follow-up visit was higher in the syringomyelia. However, it also did not reach statistical significance. And therefore, we can notice a more prominent decreasing tendency in the non-syringomyelia group than in the syringomyelia group when comparing short and long-term clinical outcomes. Patients were evaluated using the Chiari Outcome Scale in the last visit. Our analysis showed no difference between both the syringomyelia and non-syringomyelia group, and it correlates well with our previously showed clinical improvement evaluation at the last follow-up visit. We also performed a correlation between radiological improvement, meaning syringomyelia reduction, and clinical improvement in 13 patients with preoperatively diagnosed syringomyelia. There was no significant correlation between clinical improvement and radiological improvement. It implies that clinical improvement cannot be associated with syringomyelia reduction, and because all patients without syrinx cavity reduction improved clinically, and some patients with syringomyelia reduction experienced clinical worsening. So therefore, there is no correlation between clinical improvement and radiological improvement. Regarding clinical worsening, which was assessed in the last follow-up visit, there is a slight higher percentage of patients in the syringomyelia group, however, without statistical significance. Finally, we evaluated the differences in reoperation risk between both groups. Reoperation was defined as an additional surgical procedure within the operation site after discharge from a hospital after previous operation. These data were collected either by follow-up visits or direct phone calls if the data was insufficient. Differences between both groups almost reached statistical significance, but still can be considered as non-significant. It is worth mentioning that the presented data comprise preliminary results from our multicenter study, including small patients groups, so statistical significance can probably be expected in the final manuscript. We also reviewed the current literature regarding that topic. These data are quite inconsistent. A study performed by Heckman et al. Indicates syringomyelia as a positive prognostic factor, which correlated well with high Chicago scores. On the other hand, Tucker found no association between CCOS scores and syringomyelia regression, when Wetien et al. Stated that clinical improvement could result from syrinx cavity reduction. Our data does not fully support Heckman's and Wetien's data, which is a reason for further multi-center cooperation. Summing up, syringomyelia does not influence clinical outcomes and Chicago Carey Outcomes scale score. Clinical improvement does not correlate with syringomyelia improvement. Patients with syringomyelia are not at a greater risk of clinical worsening than non-syringomyelia ones, and risk of reoperation can be higher in patients with syringomyelia. However, it still needs further investigation, and that's all. Thank you very much for your attention.
Thank you very much, Dr. Ankowiak, for that fantastic, well-designed study. In terms of, you looked at the important aspect of syringomyelia and not syringomyelia, and you found that having syringomyelia didn't really change the outcomes. Do you think, why do you think that's the case? Is it because it's a certain particular subpopulation of syringomyelia, not very worse syringomyelia? Do you have any thoughts on why you found there was no difference?
Syringomyelia is, although a very interesting topic regarding the coexistence with Chiari malformation, and the recent data regarding the correlation of syringomyelia and Chiari malformation with diffusion tensor imaging shows us a little bit more about microstructure of spinal cord, and the data suggests that even in patients with syringomyelia and Chiari after posterior fossa decompression, the parameters within the posterior column of the brainstem and cervical spinal cord would not improve after operation. So it's stressed that patients with Chiari and syringomyelia can have some microstructure abnormalities. However, this data is still with a very small support, so it is unknown precisely assess the impact of syringomelia. So that's why we wanted to share our experience and define if it's really relevant or not.
Thank you. Thank you very much. Just one more question. I appreciate, the syringomelia chiari. It has put neurosurgeons in a knot for so many years, and it's so difficult to tease out one from the other. And even looking at chiaris, there are like 1,000 different chiaris when you look at hard enough. But in the patients that you had syringomelia, how many patients had symptoms relating to the syringomelia, or most of their symptoms were related to the chiari?
Well, typically we observed patients with syringomelia having, let's say, typical symptoms for some spinal cord abnormalities, like some motor weakness, some limbs weakness, and sensory deficits. So it was mainly observed in patients with syringomelia.
Great. Thank you very much. Well done. Congratulations.
Thank you very much.
Thank you. I'm now going to pass the baton back to Professor Aikananjali, and it's Professor Krishna Sharma, who's the president of the Nepal Society. Professor Aikananjali, I'll pass it to you.
Professor Sharma will talk about the secondary effect of occult the dystrophism, the scenario in Nepal. Thank you, Dr. Sharma.
Namaste. I bring greetings from Nepal. I thank Dr. Naren and all the organizers for giving us this opportunity. I'm talking about the secondary effects of occult spinal dysraphism scenario in Nepal. Spinal dysraphism occurs in 0.5 to 8 cases per 1,000 live births. It is an incomplete fusion of the spine during embryology development and encompasses a spectrum of congenital anomalies that can affect the spinal cord, nerve roots, and the vertebral column. There are two types: open spinal dysraphism and occult spinal dysraphism, and the occults are most common. This occult spinal dysraphism primarily present with dimples, cutaneous markers, and malformations. However, they are more apparent with their secondary effects, with tethered cord syndrome affecting musculoskeletal deformities, neurological deficit, sphincter disturbances, gait disturbances, and pain. The delayed diagnosis in these cases are due to the presentation common to other pathologies, and this problem is slowly progressing. The secondary effects have been found to be repeatedly treated with failures, not knowing and still correcting the primary cause, that is the tethered cord. In Nepal, we have a network where we go to different schools. It's a screening program, and we go to different districts, and we have so far been able to cover 233 schools and health centers in different parts of Nepal. These pictures are some of those programs where we went to different schools and we're screening the children for the secondary effects of this spinal dysraphism. This is Nepal, where we can see the dots which represent the areas we have covered, but sadly we have not been able to cover quite significant areas of Nepal, but we're still trying. And once we have find the secondary effects of this occult spinal dysraphism, we refer them to the hospitals in Kathmandu. And in the last decades, from 2010 to 2020, we have been able to cover almost 35 districts out of the 77 districts in Nepal. And I'm mainly involved in these 3 hospitals, but mainly is the Hospital for Rehabilitation and Deformity Correction, where we do most of the work. And in the last 10 years, we had 235 patients, aged from 13 months to 21 years, with a male and female ratio 3:1. We excluded those patients with spina bifida manifesta, and we could not include those with less than 1 year because we did not have pediatric backup for this. And we also excluded all those with a multiple life-threatening anomalies with high morbid anomalies. In a descending orders, these are the presentations these patients had: gait disturbances, sphincter disturbances, neurological deficits, sphincter spinal, significant spinal deformities, cutaneous stigmas, foot deformities, other spinal anomalies, and others. And these are a few pictures of these people which we found in this screening program in different schools. Most of these, all patients had x-rays, but they were not very helpful. So those patients who had clinical features of occult or secondary effects of this manifestation were brought to Kathmandu, where they were subjected to CT scans. And in this order, we found these findings: the tethered cord alone, tethered cord with syringomyelia. Now, this, of course, does not come under dysraphism, anal chiari with syringomyelia, but a lot of patients had this along with the deformity. So I've just included in this table. So others had diastomatomyelia with tethering, anal chiari, syrinx, and tethered. Some had hydrocephalus associated, and almost 4% had grossly normal spinal cord at the level of L2, but probably had a tight and a thickened filum terminal, but they were symptomatic. There are a few pictures of these patients. And all these patients underwent, almost 70% underwent detethering of the cord. Initially, we used to do syringotomy, but nowadays we don't do syringotomy. Those with associated anal chiari, we did posterior fossa decompression also. And those with hydrocephalus, they also had BP shunt done. In the postoperative course, the complications were quite common, actually quite high to present with it. Temporary increase in neurological deficit, pseudomeningocele, wound dehiscence, CSF leak, wound infection. We could only follow these patients when they were still admitted in the hospital or undergoing a physiotherapy or rehabilitation, not after that. But the setup we had is pretty poor. So there were a lot of complications and we had to deal with it. But initially, nowadays, the complications are quite less actually. And retethering were in patients when we followed up to 8 years, there were almost 4% had retethering of the cord, and we had to reoperate this patient. Post-operative mortality was 1%. I must admit that the follow-up is very poor because we have to reach out to these patients. The patients don't come to us. So when we go to the medical camps, then we try to reach out to the patients, but either if they are okay, they don't come. Only if they have complications, they do come back. I think it's true everywhere. This was an interesting case because this was one of the teachers in this school. She could not get married because of this scoliosis. She and when we investigated, she had a tethered cord with diastomatomyelia, which we released. And this another case. He's a 21-year engineering student with a deformity of the hands, the back, and the foot. He was supposed to have polio and was discarded and was not investigated till he had a problem in writing with his hands and came to us. On investigation, he had a chiari 1 with the syrinx and a tethered cord. So we decompressed the cord, all the three. We did not do the syringotomy. We decompressed posterior fossa and detethered in one sitting. Now he's doing fine now. Now all these deformities are finally corrected by the orthopedic surgeons and the plastic surgeons. And physiotherapy and rehabilitation is an integral component of this program. Now, management of the occult spinal dysraphism involves a big team of planners and other administrators, doctors of different specialty like neurosurgeon, neurologists and all, physiotherapists and counselor, and a local community leaders, teachers, which is almost impossible in our situation to have such a great and a big team, but we're still trying to help as much as possible. We neurosurgeons do most of the neurologist work, and we do have some orthopedic and plastic help. The red flag signs of OSD we think are the refractory, recurrent, resistant, and a progressive foot and spinal deformities, and appearance of deficit or gait abnormality with the incontinence in a growing child. Surgery for the spinal anomalies is to prevent further neurological deterioration and to improve the quality of life, avoiding the crippling complications. The surgical results are superior if they could be detected and treated early. However, in Nepal, these patients live in remote places suffering by the ignorance, poverty, and the lack of logistic support. And we have to reach out to these patients. So we have to organize medical camps more frequently, and we have to cover more areas of this country and bring them back to Kathmandu or where the facility exists and correct them, investigate and correct them. We need to help and work with other health-related organizations because we, being a clinician, we cannot do all the work. So we work along with other NGOs and INGOs who also work in these health sectors, and in their programs, we integrate our programs to detect these patients, mainly the children with foot and back deformities, and bring them back to Kathmandu and investigate. So for this, we need to arrange a sustained fund, which is the most difficult part, sadly. Awareness, we have to educate also. So we have awareness campaigns and prophylactic folic acid distribution in ladies of childbearing age, which has to be initiated. This is the main hospital. It is almost 32 kilometers from Kathmandu. It's called Hospital for Rehabilitation and Deformity Correction. I do most of the work in this hospital, but difficult cases, I bring it to the other hospital. Now at present, I'm a full-time in Nepal Medical College as the head of Department of Neurosurgery. Thank you very much.
Thank you, Professor Sharma. There is any question from the audience?
A question from me. I think there's one question from Dr. Mohammed Bangash. Thank you for the presentation. What's the future, Professor Dr. Sharma? What's the from Dr. Bangash? What's the future plan to prevent dysraphism in your country?
I think the future plan is to try to expand our program. Due to the coronavirus, for the last 6-7 months, we have been pretty dormant because we cannot travel and get to the village. But our program is to have more camps, raise more funds, and try to reach out to the most remotest area of Kathmandu and try to detect these deformities and try to correct so that we can improve the quality of life of these people. And of course, simultaneously, we want to distribute the folic acid and educate these ladies of childbearing age so that there's some preventive measures also can be carried out.
Just as a follow-up question, I know that Nepal is obviously a mountain country. In terms of reach of television and radio through those mountains, do everyone have access to radio and television in most of Nepal?
Radio definitely, definitely, but television also, yes, because telecommunication is very widely available, even in a remote area, yes.
Yeah. And is there any way of combining with people with these media to promote maternal care? Is there a possibility? Would those organizations be interested in helping you?
We are trying to reach, but we are using telemedicine to try to detect all these cases of scoliosis, foot deformities, and because if they detect some case, so they consult us through the telemedicine. So even if we cannot be physically present in those remote areas, the health workers in those working in those areas contact us through telemedicines, videos, and all that. And we do advise them to send back, but sending the patients to Kathmandu or the nearest good center is still a challenge.
In terms of education, would television or radio programs on on maternal health be useful? Would those companies be helpful for you to, or the government telecasters be helpful for you educating about folic acid, etc.?
Now the folic acid distribution is under the national program itself.
Okay.
So it is quite readily available,
okay.
Even though we do still get a lot of cases. Yes.
That's brilliant. Congratulations on
Thank
the
you very
work,
much.
Dr. Sharma. Well done. And if anything we can do, listserv, please let us know.
Thank you. Thank you. Thank you.
Maurizio, do you have any questions for?
No.
Great, thanks. Thank you very much. I will introduce Dr. Nicholas Sirmos from Thessaloniki in Greece. I'm sure many of you already know Nicholas. He's one of those people with a large heart and a great personality. He's going to give us a talk relating to elderly people and spinal injuries, and I'm certainly interested in both the children and the elderly. So, Nicholas, I'm looking forward to your talk. Do you want to share your presentation, Prof. Sharma? If you could unshare it, then Nicholas should be able to share it. Thanks. Nicholas, are you trying to share?
Naren, thank you for your kind words. Thank you for your invitation. We are far away, but our hearts and our souls are near, and I hope that when this pandemic will be finished, I don't know when, I'm sure that we will meet again, and everything it will be good for us and for our patients. I don't know if you share my screen.
We can't see your presentation yet, Nicholas.
Now?
It's coming. Yes, it's great. Thank you.
Naren, this is not a words, typical words. This is a word that they are coming from my heart, and you know that. When you saw these big names that participate in this wonderful congress, it's a kind of mondial of like football, like soccer mondial. When you saw all these big names that participate, I'm delighted to participate in this very big web event, and I thank you very much.
You're very welcome.
My presentation, my work, it's a simple one. It's a kind of epidemiological study. When I was a resident, I made some observations about the cervical spine injuries in elderly male patients. Due to falls, it is very common. I don't know how to get down. Okay. Aim of this study was to present cases of cervical spine injuries in elderly male patients over 65 years old due to falls. All the European countries we haven't in the future, maybe we will, or not maybe, it is sure according also to the World Health Organization that we will show much more elderly patients, both male and both female, because the population of Europe it will become older and older. We will not speak about a continent. We will speak about an old continent. 10 cases are presented, 10 male patients. The range of age was from 65 to 85 years old. The mean age was 75. In all of them, we performed CT and MRI studies, scan studies as always. Four of them, 40%, they had one level fracture and one level dislocation. One patient had two level fractures and two level dislocation. 3 of them had combined cervical and thoracic traumas, and 2 of them had combined craniocerebral and cervical traumas The combination of cervical spine injuries with craniocerebral injuries, it is very common, and all the medical doctors that they are in the emergency department, according also to the studies, they have also to study and to search about also for a craniocerebral injury when they are focused on cervical traumas. We followed conservative treatment in 60%, surgical treatment in 40%. The good outcome was in 8 people, and the poor outcome it was in 2 people. The neurosurgeons, we are speaking also in all the congresses about the good outcome, but we have also sometimes to speak about also to poor outcome. We don't manage to treat well and to save the lives in all the people that we are interested about. According to recent studies, epidemiological studies, there are 12 injury-related emergency department visits for every 100 persons over the age of 65. The cervical spine injuries are relatively common in the elderly population. These injuries are associated with high morbidity and high mortality. The percentage of elderly patients with trauma has been on the rise and will continue to increase into the next coming decades. The clinicians and the neurosurgeons have to have clinical suspicion to rule the cervical pathology. And we have sometimes, not sometimes, always to focus and to study the mechanism of injury. Often geriatric traumas present with confounding variables such as dementia, auditory and visual impairment, and this creates many difficulties when we are trying, or our residents when we are trying to do physical examination. The most geriatric cervical spine injuries are secondary to falls. They can, however, occur secondary to any traumatic mechanism from a simple one to a combined one, and the geriatric patients have a higher risk of low energies secondary to, but not limited to, other pathology as osteoporosis, osteopenia, and many times in psychological and psychiatric diseases. The management in geriatric patients is still controversial according to the literature. Sometimes we have to immobilize and to make a conservative treatment, but sometimes we have also to operate them. And since these patients has other associated injuries, these patients should be managed by a multidisciplinary team. This is the gold standard, the multidisciplinary team approach. Spine trauma surgery, neurosurgery and orthopedics in European countries, physical therapy, and very important is the other medical disciplines, such cardiology, internal medicine, and geriatrics is very important. And for finishing, the role of neuroradiology is essential to plan an optimal support and an optimal resolution for this patient. I want to dedicate this presentation and my presence in this Congress in James Wooldridge, a very good friend, a very good teacher, also a very good friend to Naren. We lost him last April due to coronavirus pandemic. Jim was a real master of pediatric neurosurgery, a real master of craniofacial surgery, a very good teacher and also a very good friend. We will remember him in eternity, as I wrote in Facebook, down of this photo, this painting photo, a true master of neurosurgery. Thank you very much.
Thank you very much, Nicholas, for a very pertinent talk looking at the elderly, as we know that that population is going to get large and they are also going to get powerful. Now most of the leaders seem to be all in that age brackets. Am I right? Your practice is in Santorini?
No, I was practicing in Crete when I made the study, when I was resident. Now I'm located in Thessaloniki, my city, now that I'm consultant.
Excellent.
It will be great to practice it in Santorini. It is a wonderful place, Naren, and it's a wonderful place after coronavirus to make a congress, maybe Mediterranean Congress. Also, Dr. Maurizio Iaconelli from Ancona perhaps will join us.
Absolutely, absolutely. My question is to you, Nicholas, is that, these elderly patients, how much, when they come with a fracture, how much geriatric input do you get in them? Do you have a dedicated geriatrician coming to see these patients, or are they under the surgical care?
In that time when I make the study, we didn't have in our hospital the geriatrician, but now they have. And we have also to see them to be observed under internal medicine and cardiologists, because 90%, perhaps also 100% of them, they receive anticoagulant therapy and also therapies for altered medical pathologies. It is very important that sometimes, or not sometimes, always, you can do also a very good, a perfect surgery, but because they don't have the organism many times has not the resistance to afford this operation.
Sure. Thanks.
And many times we do good things, but we lost our patients. And we have to be, as pediatric neurosurgery, we have perhaps, I think there is, perhaps we can study also geriatric neurosurgery. Perhaps it's our future.
That same, both are very similar categories. Thank you very much, Nicholas. Well done.
Thank you very much, and greetings also to Professor Iaconelli from Ancona. I met some very nice and very good colleagues from Ancona department in various congresses, and I will remember them with very and great happiness and my best wishes also.
Thank you. We can do a Mediterranean lab.
Perhaps in the future we will meet. We will meet for sure. I don't know when, but we will meet.
Okay. For sure. Thank you. Baton back to you.
Best wishes, Naren, my best wishes.
Thanks. Thank you.
My heart and all the best.
Thank you very much. Thanks, Nicholas. Maurizio, baton is back to you. Thank you, Maurizio.
Okay. Now we move to Dr. Khalil Hajadi from Tunisia. We'll talk about intracerebral hematoma, an unusual mode of revelation of acute lymphoblastic leukemia, a case report and a review of the literature. Dr. Hajadi, are you there?
Yes, sir. Can you hear me?
Go on.
Greetings from Tunisia. I'm really excited and grateful for inviting me and including me in this wonderful congress. I am honored to talk about my presentation entitled Intracerebral Hematoma, an unusual mode of revelation of acute lymphoblastic leukemia. The case report is about a 1-year-old female baby with no particular medical history. She was admitted in our department for rapid head volume growth, evolving for 2 consecutive months, with recent vomiting. Physical examination found an agitated baby with macrocrania. Biological examination showed hyperleukocytosis with cytopenia, low platelets, and anemia. CT scan and MRI showed right temporal frontotemporal subdural collection with a right temporal hyperdense mass. The subdural collection was enhanced with the injection of contrast agents. So the baby underwent surgery, and the surgical evacuation of the hematoma was performed. During the operation, the dura and the subarachnoid space contained a thick fibrous tissue that was in continuity with an intraparenchymal hematoma. The hematoma was evacuated. However, the patient had severe bicytopenia in the post-op, and unfortunately, she died in the early days post-op due to a severe infection. We performed an autopsy, and the pathological exam was in favor of an acute T lymphoblastic leukemia. In fact, acute lymphoblastic leukemia has neurological manifestations in nearly 10 to 25% of the cases. Clinical signs and manifestations are those essentially of increased intracranial pressure syndrome with or without motor deficit, depending on the localization. Hyperviscosity due to hyperleukocytosis and coagulopathy due to thrombocytopenia are the main causes of intracerebral hematoma during acute lymphoblastic leukemia, and ICH, intracranial hematoma, is the second most important prognostic factor after infection in the patients having this disease. Management of intracranial hematoma complicating an acute lymphoblastic leukemia can be conservative, and evacuation is indicated when there is neurological deficit or severe mass effect. Leukemia should be suspected when there is an association between an intracerebral hematoma with hematological abnormalities, and especially hyperleukocytosis. Bone marrow biopsy and genetic analysis are the key to the diagnosis. In conclusion, hyperleukocytosis and or thrombocytopenia in a patient with an intracerebral hematoma should raise the suspicion of leukemia. It is a major prognostic factor in patients in this kind of patients with this kind of disease. Treatment depends on the clinical and radiological presentations, and the positive diagnosis is based on histological and genetic analysis. And thank you, sir.
Thank you very much, Khalil. There is any question?
There's a question for you, Khalil, from
Yes.
Dr. Rahul Srinivas from India. He's asking, what are the hematological parameters? What hematological parameters were corrected before taking this case?
Yes. So this patient had bicytopenia, the low platelets count, and anemia. So we transferred the patient with hemoglobin and with platelet fractures. We had the anesthesiologist to check the parameters, the correct parameters before the interventions, so that we do not have bleeding or we do not aggravate the anemia, especially because this is a baby, a 1-year-old baby, who is very dependent on these hematological parameters.
That's great, thanks. Dr. Khalil, I think
yes,
yours is the next presentation as well.
Yes, sir. So my next presentation is about an intramedullary tuberculoma, about a case report about a 21-year-old male with a history of treated pulmonary tuberculosis.
Dr. Khalil, we can't see your presentation there. So.
Sorry. Yes, can you see it now?
No.
No?
Yep. Do you want to just start from the first screen?
Yes, sorry. You can see it now?
Yeah, we can. Yeah.
So my case is about an intramedullary tuberculoma in a 21-year-old male. He had a medical history of treated pulmonary tuberculosis. The patient was admitted in our department for progressive working disturbances with sphincter disorders. A neurological exam found a spastic paralysis with a positive bilateral Babinski sign, a T8 sensory level with urinary retention and anal hypotonia. A spinal MRI was performed, and as you can see, we found a T7 intramedullary process that was in the center of the medulla. The patient had an urgent surgery, and the dura mater appeared to be infiltrated by the tumor. Total excision was not possible due to important pseudo-inflammatory reaction and the strong adhesion of the process to the medulla. However, fortunately, the patient had slight clinical improvement after the operation. Pathology was in favor of intramedullary tuberculoma. Tuberculosis of the central nervous system accounts for approximately 1% of all cases of TB. It usually affects fragile patients, old patients, very young, or those with immunodeficiency. And spinal tuberculosis is common in developing country due to the pandemic expansion of the TB. And usually tuberculosis spondylitis is the most common presentation of spinal tuberculosis. However, intramedullary tuberculoma is possible. It is rare but possible. It is seen in nearly 2 cases in 100,000 cases of TB, and spinal intramedullary tuberculoma is mostly induced by or caused by hematogenous dissemination. However, local spreading is a possibility, is a rare possibility. MRI is the key exam for spinal intramedullary tuberculosis. A differential diagnosis include mainly common spinal intramedullary tumors. Medical treatment should be tried first whenever possible. However, surgery is indicated in cases with neurological deficits, association with paravertebral abscess, or in case of failure of the treatment. However, the results of combined medical and surgery are excellent. In conclusion, although rare, intramedullary tuberculoma should be considered, especially in pandemic countries. MRI is a necessity. It is the key exam. Prognosis is good if the diagnosis is correct and is early. Medical treatment should always try it first when possible, and combined medical treatment and surgery when indicated has good results. And thank you for your attention.
Thank you, Khalil.
Thank you, sir.
Any question? One question. This is a classic question in dealing with spinal cord tumor. Do you think the monitoring and the evoked potential could be useful, necessary, advisable? How is your philosophy, your practice about the monitoring?
Well, there is a theoretical response and the practical response. The theoretical response, it is a necessity to have the monitoring during surgery of the medulla. However, in practice, it is not always found, especially in my country. We do not always have the possibility because the hospital does not have the adequate equipment. So patients sometimes have to afford that for surgery. That's why there is the balance between the theoretical aspects, which is a necessity during this kind of surgery, and the practical aspects, especially in low-income country where the equipment is not always available.
Okay.
There are 2 questions.
Yes.
In terms of, I think Professor Ersin Erdogan from Ankara is asking, do you use long-term antibiotic therapy?
Yes. The treatment of intramedullary tuberculoma uses the same antibiotics. However, the duration is very long. It attains sometimes many months. Sometimes it takes, I think, 1 year or more or less to treat these infections, because the dissemination is slow and the effect of the antibiotic takes really long time.
Thank you. One question from me. You have other questions from the chat box, if you could answer. If I have missed, I'm sorry, I do have to look after the system. Is there any telltale signs of on MRI scan of a intramedullary tuberculoma?
Sorry?
Is there any MRI sign that's something intramedullary, when there's an intramedullary tuberculoma, to say it's a TB?
Well, I think not. However, the context is very evocative. As in our case, the patient had already tuberculosis, so we thought about it. It's not, I think, to my knowledge, there is no specific sign to discern that.
Thank you. Thank you very much. There are a couple of questions on the chat box. Khalil, if you could please, if you could quickly please type on the chat box and answer them.
Okay, sir.
That will be great. Well done, and thank you very much. Well done. So I'm going to introduce Professor Quintana, if that's okay, Maurizio. And sir, I have known Professor Quintana now since 2004, and it's one of those great people that I have come across in my so far life and career. I had started this listserv back in 1998, and I was a serious kid and very, I go from ABC but Professor Quintana brought, humanism to the listserv. He changed the atmosphere, and Professor Quintana is the professor and chairman of neurosurgery at Valparaiso in Chile. He was the president of Chilean Neurosurgery Society, the Latin American Neurosurgery Society, and also the vice president of the WFNS. He has been featured by the American Association of Neurosurgeons with the medal for him, and his influence for neurosurgery in his country, in South America, Latin America, and certainly listserv is immeasurable. So it's with great pleasure and privilege. It's my great pleasure and privilege to introduce Professor Quintana to give this lecture, which is very passionate about vascular surgery. Thank you, sir.
Oh, thank you, Dr. Narichiran. I thank to you really for invite me to this webinar, excellent webinar. But the main point is Dr. Narichiran is a great manager of our neurosurgery research listserv. Really, all this work is very hard, and he continues and stimulate us to present some experience. Well, I chose this topic, intracranial arterial hemorrhagic dissection. In other words, is a blood blister-like aneurysm. First is general consideration, because many residents are hearing and watching this excellent webinar. Well, the blood blister-like is a dissection caused by the entry of blood into the arterial wall, spreading and separating the different layers of the arterial wall. And this dissection may enter to the subintimal space, usually causing ischemic symptoms, or cross almost all the wall and locate between the media and the adventitia. This is very dangerous, because usually produce extravasation of blood to intracranial levels. That is subarachnoid hemorrhage. That is the blood blister-like aneurysm, as you can see in this picture. So about the etiology of this dissection or blood blister-like aneurysm, mainly two, I think it's a acquired injury, two pathologies. I mean, base pathology is systemic hypertension that produces lipomyelinosis and weakens the wall, and hypercholesterolemia producing ulcer, a traumatous ulcer. And the other point important is the hemodynamic stress of cerebral flow over areas with structural dysfunction of collagen. This disease of collagenopathy, I mean, Marfan disease, Ehlers-Danlos disease, pseudoxanthoma elasticum, imperfect osteogenesis, and so they may suffer some structural dysfunction of the artery and produce also dissection. About the topography, usual topography of this kind of dissection, at the supratentorial anterior circulation level, we have a superior wall of the internal carotid artery, frequent, M1 portion of mid-cerebral artery, A1 portion, A1 segment of anterior cerebral artery, and before segment of the vertebral artery. Here you can see in the right side, the usual point we can meet this kind of blood blister-like. About the epidemiological frequency, usually it's 1 to 2% of all intracranial aneurysms that we must resolve in our clinics. This information came from Professor Jiro Suzuki and Ohara from Japan. Well, about the clinic is, as you can see here, if the dissection is produced in the posterior circulation, usually we have subarachnoid hemorrhage from the posterior fossa, mainly before vertebral. At the supratentorial level, we have, as usually imagined, that produce sometimes the very aneurysms, depending on the location, internal carotid artery. We have a paracellular subarachnoid hemorrhage, and sometimes I have experience if the superior dorsal wall of the internal carotid artery may produce intracerebral hematoma. So this is the clinical and imagenological. And this is a very important point. The intracranial arterial dissections is located usually in the path of the main artery, different of perianeurysm, as you can know, is producing the bifurcation, arterial bifurcation. This, as you can see in the left side, is produces in the dorsal portion, the path of internal carotid artery. The right side is very typical of a dissection. First, stenosis of the vertebral artery, and after a dilation. This is what was a general topic. Now we enter to the surgical technique to be used for the treatment. First is direct clipping. I will wrapping and clipping over the wrapping material. Trapping, plus or not associated with bypass, and angioplasty when you have to repair the artery, and it's very difficult. Usually it's difficult. Well, the first point I learned many years ago, about 40 years ago, from Professor Kenichiro Tsushita in Japan. If we found this aneurysm in the dorsal portion of the internal carotid artery, you can see optic nerve, internal carotid artery. Usually, he recommended that, and I have experienced that, not use early operation. Not early operation, but it's very difficult and you can find a disaster. It's better if you suspect the dissection to perform the late surgery 1 week, 10 days later after the rupture. To use light clips, I mean mini clips, not so heavy clips. And following, when you apply the clips, is following the direction of the artery, not cross, direction of the artery. And if possible, include a part of the neck, I mean the edge of the neck in the main artery. I will explain with one of my case. You can see here, entering to the frontoterminal left optic nerve and A1, left A1, typical blood blister-like. It's very fragile, with a wall, it's very fragile. So I put the mini clips in the direction of A1 and included a part of the neck of the aneurysm. Another technique is wrapping of the blood blister-like. And here you need to use your experience, because if in this aneurysm, you put the clip, direct clip over this portion, you may broke the artery. So in this case, according with my friend Akira Ogawa from Japan also, I usually use muscle and wrapping with muscle. He uses silk material is okay, and cover the artery and the dissection, the blood blister-like. And you put the clips over the material, not to break the artery. And sometimes it's very useful. I have used this. For instance, in this case, it's one of my cases, left side middle cerebral artery trifurcation, posterior, anterior, lateral. And here I first take off, and I didn't take off all the dissection. Of course, fibrin, this is a portion of fibrin. Of course, I didn't touch off because it was occluded in the rupture site. And over this, I put the wrapping with muscle. Here I put the muscle and secure the muscle with a clip. Stretching, not more than that. And was successful, and the aneurysm did grow and did progress with good results. The other is trapping, very useful. Here is the dissection of a vertebral artery. You show that. And I perform this schematic. I could put the clip under the pica, under the vertebral artery. If the pica is included in the dissection, I must perform a reposition of the pica or a bypass. So usually you can perform trapping of the artery, but ensure that you have collateral circulation of the other branch, like pica, for instance, in this case. If we perform the same technique in the internal carotid artery, we must perform a high flow bypass. It's very important, that point. Also, all these vascular cases are discussed in team with endovasculars, and they can't support. This is experience of one friend of Seoul, Byung-hee Lee, wonderful experience with dissecting. He showed this case. It's not so easy also. He put a fenestrated stent and put coils. Oh, you can see a wonderful image. But the control, after 2 months, you can see the dissection of the aneurysm, the blood blister light may regrow. So he used the technique called stent between stent. So inside the other stent, he put a flow diverter stent, and the problem was solved. He's very skillful. He's an endovascular, excellent endovascular, and he has a very good experience using endovascular technique. So I respect so much that experience. So in my clinic, during this time, we treated more than 1,000 cases of total aneurysms, but we had 21 cases blood blister-like. That is 2% of our experience. And in this scale, you can see three points. The majority of the case was in the proliferation scale. 17 cases were grade 3 and 4. All were severe hemorrhage. At the CT scan, with the modified Fisher scale, that meant Columbia scale, 19 were grade 3 and 4. So not so good result. I mean, not so good case, all severe cases. The treatment was half and half, but on the right side, you can see the functional discharge, modified ranking scale. And we must be very honest, but this is a very difficult pathology. We have 11 good case, that is good case, modified ranking scale 1 and 2, 52.4%, and bad case, that is modified ranking scale 3, 4, who didn't have 5 and 6, I mean, died. So 47.6%. I show this experience because in one Congress I met Professor Juha Ernest-Niemi, we discussed, and he said, I congratulate you because you are saying the truth. Here is his report. And as final conclusion, we must say that treatment of blood vessel-like is associated with a high morbidity rate. Usually because are very small aneurysms, but we can catch. But we have a very high risk of intraoperative aneurysm rupture due to the fragility of the main artery and the wall and the aneurysm wall. So if you must use your experience, one to put the clip, one to wrapping, one to trapping. It's very important that this is the decision because you have very high probability of losing parent vessel patency, either intentionally or as treatment. So final result are half and half, good and not so good. Thank you for your attention.
Thank you.
Thank you very much, Professor Quintana, for that elegant presentation of a very complex aneurysms. And do you have any questions, Professor Maurizio?
I would just want to ask you, what do you think about the combination, the combined treatment, endovascular and surgical, just in some way to overcome these surgical difficulties in dealing with this difficult aneurysm?
Yes, right. Usually we discuss with endovascular, and even he entered to the operating room, and if he's capable to perform endovascular, for me it's the best, I think, because using the technique I show you with my Korean colleague is the best, I think. But sometimes even the endovascular, they cannot enter, you know, the wire to put coils or stents. For the endovascular also is very difficult pathology. So if the endovascular say me, I'm sorry, doctor, I cannot continue with this procedure, I must resolve this with the other, but usually trapping or wrapping, combined with a bypass. I can call another colleague and perform a bypass. But I think in this moment, it's not, we don't have the answer for all the case. Usually the therapeutic decision is case by case, case by case.
Can I, Professor Dr. Robert Spetzler is here. Dr. Spetzler, do you have any comments, sir?
Fine, fine. He knows a lot.
I'll just a second.
Yeah, terrific lecture. I agree really with all the points. And as it turns out, I'm going to be presenting a couple of these because they fall under the term of complex. But as far as the various treatment options, I am in 100% agreement.
That's great. Thank you. Thank you very much, Dr. Spetzler. Thank you very much, Professor Quintana. Once again, I'm most grateful. I'm now going to pass the chairmanship to Professor Maurizio Iconangeli. Maurizio.
Okay. Thank you, Naren. Now is my okay, big job, but it really is an easy task to present Professor Spetzler because everyone knows him. In my opinion, he belongs to the Olympus of the modern neurosurgery, with other very few neurosurgeons, like, in my opinion, for me, Yaserji, Pernesky, for example, because they are not only superb neurosurgeons in terms of surgical skill, clinical practice, and research, but even because they suggest or discover or give us some idea that we still use even after so long distance of time. Professor Spetzler has written more than 300 articles and 180 books chapter. In this COVID period, staying at home, we fortunately rediscover the pleasure and importance of reading books and meditation. His articles and books are like, I would say, the Bible. Every time you read it, you can take an idea or an inspiration. A few words about his biography. He was born near Würzburg in Germany. I also have a good memory of Würzburg because it was the workplace of another giant, in my opinion, Professor Johannes Lang, which was one of the best and one of the first anatomists who translated the anatomy into the clinical and surgical practice, stressing the importance of microanatomy and in neurosurgery, along with Professor Roton and Chabisher. The same did Professor Spetzler with one of the first renewed dissection lab that I attended so many times ago. Professor Spetzler entered the medical school in Northwestern Medical School in Chicago in 1967, receiving this medical degree in 1971, and a residency in neurosurgery at the University of California, San Francisco, training under Charlie Wilson. And from 1983, Professor Spetzler was named chair at the Division of Neurological Surgery at Barrow Neurological Institute up now. Aside from all the 1,000 prizes he received, I would mention in 1999 the Herbert Oliver Krona Harvard, that is a sort of Nobel Prize for neurosurgery. I think that I have nothing to add. Naren, if I forgot something or if you want to add something, go on.
I think, if I may say so, I think all neurosurgeons' lives are inspiring, and I think I can never find a resident who's not inspired. You mentioned the word Spetzler. So you're blessed, sir, and look forward to your talk. Thank you.
Okay, so we move to this keynote lecture. Professor Spetzler talked about the giant cerebral aneurysm.
Thank you, Professor. Do you see my screen?
Yes. No.
I think it's coming. Yes, yes, we can. Thanks.
Okay. Well, thank you for your very, very kind words. Way over the top. I have had the joy of being in neurosurgery for these many decades, and I have loved every minute of it, except when things didn't go well. And sort of complications always sit with you forever. And I think it's our job, which is really part of the process of these kind of presentations, to take every mistake we've made and turn it into a lesson for the future, and to teach it in such a way that our followers don't have to repeat that mistake. So I'm delighted to be part of this World Conference. And let's just review what we know. We know that when we're talking about large aneurysm, the larger an aneurysm gets, the greater the risk of rupture. And in some, like the Isola study, when you've had a 25 millimeter aneurysm, the risk of rupture was over 20%. Flow diverters undoubtedly have a great potential, and I'll get on that just a little bit, but there have been no prospective studies for flow diverters. Coiling for large aneurysms is inferior. And I want to spend just a couple of minutes on Brad tenure results because we forget what clipping really can accomplish. It was a study with primary outcome of modified Rankin score at 1, 3, 6, and 10 years. And what you looked at was repeat subarachnoid hemorrhage, retreatment, and death. And I'm only going to really look at those. If you look at retreatment at 10 years after discharge, just about 20% of patients that were coiled were retreated. Less than 1% of those that were clipped. Aneurysm obliteration, the same. If we look at 10 years, there was only 22% of aneurysms that were completely obliterated. And this was adjudicated by an independent neuroradiologist, whereas more than 90% of patients that were clipped at 10 years were still completely obliterated. And when you look at what is really important, which is the subarachnoid hemorrhage, is, as it turned out in the study, because of so many patients being moved from intent to coil to actually clipping because the endovascular surgeon did not think they were appropriate. So that's why you had 175 in the clip group and 83 in the coil group in the prospective study. There were no subarachnoid hemorrhages in all these patients and no death. Out of the 83 that were coiled, there were 2 subarachnoid hemorrhages, and unfortunately, both of those patients died. And you can see the significance of clipping over coiling in a 10-year period. I think that the critical question remains is how protective is coiling? So you have an aneurysm, it's nicely coiled, it disappears, and then what happens? It starts to recur and it gets bigger. And then you have a subarachnoid hemorrhage and a recurrence. The same is true if you clip the aneurysm. If you clip an aneurysm inappropriately and you leave a big portion behind, with time it will grow. The lesson here is that aneurysm growth, regrowth, has an enormous amount of implication from whether you have residual aneurysm. So if only 22% of patients that were coiled were completely coiled at 10 years, that leaves almost 80% of patients at significant risk of regrowth and subsequent subarachnoid hemorrhage. Recurrence remains a concern. This is one that was coiled in Pennsylvania by a very famous neurosurgeon, an endovascular neurosurgeon. 6 years later, she was in Phoenix to see me. And here you see the coil mass, you see the aneurysm. And when you look inside surgery, one of the things I want to address are the coils that migrate out of the aneurysm. Does this happen frequently? Well, it happens. Here's one that was coiled in California and came to see me 8 years later because of progressive visual deficit. The coils have come out and have migrated into the optic nerve, causing the visual deficit. This is a neuro-ophthalmologist in our who actually worked at the BNI, and she was stented and coiled, and 3 years later she developed a progressive third nerve deficit. Remember, this is a neuro-ophthalmologist, and here you can see the coil migrating into the third nerve. We rarely talk about this. This is a patient, a little 9-year-old, where this aneurysm was discovered, and they decided to treat it with a pipeline stent. The first pipeline stent was inserted, but you still had persistent filling of aneurysm. Subsequently, a total of seven pipeline stents were inserted to try to control this aneurysm. He developed loss of vision after first stent placement and has had progressive worsening vision since subsequent placement. So on examination, there's no light perception in the right eye and temporal field in the left eye. So it's been progressive, and that's when we saw him. And if you look at the early portion of the angiogram, it looks pretty good. You see the stents. You do see quite a bit of narrowing right by the lenticular striates. But when you look at the MRI scan or CT scan, you see a large enhancing mass. And when you look at the later angiogram, you see why, because there's still blood coming through all those stents. And this is basically the problem. So there's continued growth of the aneurysm, which is causing the visual loss. What we did is we took him to surgery. You can see the tines. There's the aneurysm underneath. You can see the tines in the carotid artery. And I won't spend a lot of time on this, but added on a bypass. And then we verified that it was working, and we ended up with a partial occlusion of the internal carotid artery and then complete occlusion. And this is what it looked like afterwards. So the aneurysm no longer lights up. You can see the bypass over here, and there was no change in the exam immediately postoperatively. And then 3 months post-op, he'd had dramatic improvement of vision, which has returned to completely normal over time. And you can see the aneurysm has shrunk dramatically. So my point here really is, just because we have a new tool doesn't mean we should throw out all the tools we already have at our behest. Patient and surgeon in position. I think for the young that are watching, it's very important for you to be comfortable, for you to use the right approach. Remember, we have a lot of things that we can use now. Lighted instruments, we have surgery scope, we have adenosine, cardiac pacing, cardiac standstill. And I usually operate without a retractor altogether. And I'm going to show you some case examples. This is the way I like to sit. I like to sit with arm support so that I have really the maximum amount of balance and use my foot control. Mouthpiece, very important for me personally. And that's what it looks like. Having the right bipolars that don't stick can't be overemphasized. Using lighted instruments at the right time is really critical. So what does a lighted instrument do? This is a cavernous malformation that's steep. And because our visual axis and the light come in at different degrees, so the visual is at 0 and the light varies between 3 to 6. So the lower we get, the less light we have because it comes in at a slight angle. If you add light there, then you can see it very nicely, no matter where it is.
Sorry.
Retractorless is basically the concept being that instead of putting in firm spatulas that hold the brain apart, we use dynamic retraction. And so we use our instruments to retract. So they're always moving, and we only retract to the area of visual interest. Here is, I'm using forceps on the dentate, just slightly lifting the spinal cord. And did you see how the blood vessels fail to fill? And it's not until you relieve that pressure. So to think that when we put in a major retractor that we're not affecting blood flow and causing potential harm is a misconception. Here's a giant aneurysm, been coiled and stented by one of my colleagues. You notice no retractor in place. Unfortunately, the aneurysm broke, no retractor. I put proximal and distal clip, and I have no option except to sacrifice that carotid artery. And still no retractor in place, getting rid of that. And then I was prepared to do a radial artery graft from the internal carotid artery or external carotid artery here. So that's the proximal, and there it's open. And because it was ready, here's the radial artery coming up, feeding not just the entire middle cerebral artery territory, but even coming across to fill some of the anterior cerebral artery territory. And she ended up doing very well. Professor Quintana was talking about is the little aneurysm. Here's a patient that had a subarachnoid hemorrhage and a perfectly normal angiogram. Supratentorial was perfectly normal. So the question really that we face is, do we do a repeat angiogram before discharge? Do we do an angiogram in 1 year? Do we do an MRI CTA in 1 year? In my opinion, when you have this kind of hemorrhage, which is way out of proportion to one of the little pontine hemorrhages that happen, I say we do it before discharge and see what we have. We developed a little blister aneurysm at the top of the basilar artery. I don't really think that is one that is appropriate for stenting or coiling. It's not appropriate for observation, so clipping was the right choice for us here. And how did we do it? Through a small modified orbitozygomatic approach. We have all the blood. And so we have published before, and along with Dr. Barrow, the use of cotton to increase the strength at the neck of an aneurysm after it has ruptured. We're cutting the posterior communicating between where there are some branches. I like to bipolar instead of clips so they don't get caught on you. And now we're coming down to the area of interest. Basilar artery, contralateral third nerve, SCA, contralateral PCA, ipsilateral PCA, aneurysm right there. Mammillary bodies above us. And you can see it's just one of those little blister aneurysms. So I'm putting no tension on it whatsoever, but I have enough room for a temporary clip if I need to apply it. So put a little cotton on the base, and then you'll see me really distort the basilar artery because I want to catch as much of normal basilar artery as possible so that we don't create a big hole in the basilar artery. So having done that, I then go around, make absolutely certain that there are no vessels incorporated. And then once I see it's completely clear, no vessels, that's what I consider the end. And here's the post-op, that little blister aneurysm is completely done, and that patient made a full recovery. Giant aneurysms. This does not look like a giant aneurysm. When we look a little closer, we can see, yes, it's a giant aneurysm. Personality change. This is the size of the aneurysm. So the problem here is really being able to close this off to prevent the continued growth of the aneurysm. With the left OZ, because of a small middle cerebral artery aneurysm, opening it, no retractor in place. I'm just taking off the top. Then I'm putting temporary clips on the 2A1s and then reconstructing the aneurysm. I've cut off the dome of the aneurysm from the base, and then using a myriad of clips to shut off the aneurysm. And this is what it looked like afterwards. Naturally, intraoperative ICG, if it's adequate, can tell us that the anterior communicating artery is open. If not, then I will do intraoperative angiography. But you can see the dome of the aneurysm remains. That will slowly disappear. This one is a little more difficult. You have an A2, and you really don't have an A2 on the other side. That'll become important in a minute when I show it to you. But this patient presented with progressive dementia and walking difficulty. So here we're coming in, optic nerve, A1, making a space between the dome of the aneurysm and A1. So we've got the two A1s clipped off, opening the aneurysm, using the CUSA to give us room, removing some of the coils that are in my way, and then doing the same thing we did last time, is cutting off the dome of the aneurysm so that I can try to close the bottom. Did an aneurysmorrhaphy in the bottom to give us more room, and then applying clips to recreate the ACOM. And so it looks pretty good. This is the contralateral A2. It had coils in it. That's why it wasn't filling. So I can get rid of that one as well. Put a clip. Now I'm going to take off the temporary clips. And I think maybe it looks pretty good going up here. But look at the ICG. There's no flow. In desperation, I cut it off altogether. And then I take the A1 and hook it directly to the A2. And that's really the importance of knowing bypass skills. And then when we do the ICG, we get very nice flow of the anterior cerebral artery. And when we do the post-op, we see very nicely that the anterior cerebral artery is alive and well. This one's a little more difficult. This is a patient that had thromboembolic symptoms and a big hemorrhage. And if you look, you can see anterior cerebral artery, and this is now on A2, a dissecting giant aneurysm. So there's really only one reasonable treatment here, and that is we're into the interhemispheric fissure. This aneurysm is A2 coming up to A3. There's a thrombus inside that right there, and we've already seen the subarachnoid hemorrhage. So I cut off A2 right as it is the callosal and pericallosal branches, shut this off, and then do an A3 to A3 bypass. So this is what we're doing. This is what it looks like, bringing them together. This is really a relatively straightforward bypass. You just have to obviously do the back wall first. So we do the back wall in a running suture. We come from the outside in and then sew on the inside all the way to the other end. And when we're at the other end, we turn around and we get this sort of bypass. And here you go, coming up one anterior cerebral artery, but feeding both sides. This is a problem that we see way too many times. 48-year-old female, no subarachnoid hemorrhage. She was coiled, but then it regrew and it regrew. She tolerated an Alcock test at good posterior communicating arteries. So an attempted recoiling failed. So what did we do is we did what was already published in 1961 by Lester Mound. We did flow diversion by clipping the basilar artery below the SCAs. And this I've done a number of times, works very well. When there's no good posterior communicating, then you have to add a bypass to the PCA or the SCA. So we look at it. We always see whether we can do the aneurysm beforehand, but you can see it just obstructs everything. So now I go down to just below the SCAs and occlude the basilar artery. This is what it looks like post-op, and that aneurysm has disappeared and never returned. Sometimes you have different options. Same sort of problem, recurrence after coiling, looking, always looking before we occlude. Here I was getting ready to do a bypass because there were no good PCOMs. Here's the thalamoperforator, PCA, one side. Now I'm using a fenestrated clip in order to get some room away from the top of the basilar perforator perforators on this side, was able to clean that off. And then I closed off the perforation. And that's what it looks like post-op. Aneurysm gone. That's obviously the best solution. Just one more case like this. Again, repeated coiling time 3. You can see this huge mass that is just causing problems. And so again, we go down. This time we do a little bit different. Separate the perforators. Put on a clip. Temporary third nerve paresis, removing the third nerve, whereas otherwise with a smaller PCOM, you never see the third nerve. And then we place a clip, you have the temporary clip on the basilar artery, and we stagger it and then come back and put it behind it, taking the one in front off. So to see whether in fact we get good flow, we have the PCA in this fenestration and everything is filling. And when we look at it post-op, you can see very nicely how we completely occluded the aneurysm, making the point that inspection is worthwhile. We have so many additional tools. We have bypass, we have wrapping, we have adenosine, we have cardiac pacing, and cardiac standstill. We published 106 cases of cardiac standstill and haven't used one in a long time. This is the last one. And that's because we have much better endovascular techniques, and cardiac pacing and adenosine have made it safer. But every one of them was posterior, giant posterior fossa aneurysm. So here's one that I still think would be best served with a cardiac standstill. Large base. This is what it looks like, immediate inflow. There's really no place that you can get a good purchase. This is what it looks like. And then this is what we do at surgery. So here we are, this is in 2005. Aneurysm is under cardiac standstill, bringing it together. There are these perforators that have to be maintained. You see the tine clipping right below the perforator. And I used fenestrations and then ones to close off. You're gonna have this here just because it was so large. Here it is post-op, remaining good flow. And this is 5 years later. Complex approach. So when you have an aneurysm at the P2, P3 junction that has grown, you have observation, stent coil. Well, obviously, I'm going to recommend surgery for this. And the best approach really is the lateral supracerebellar infratentorial approach. So this is it. We're coming in. No retractor, tentorium, ambient cistern. I'm going to cut the tentorium here because the posterior cerebral artery is partially underneath and probably the cause of this aneurysm in the first place. So I'm shrinking it back with these non-stick bipolars made by Stryker. And I go around, get proximal control. And here's the aneurysm. Now the problem is we have this little branch coming over the dome. We have the bigger branch coming up this way, and I really want to preserve everything. So we're just cutting all the arachnoid adhesions. And now making a space for the tine between that small branch and this branch. And then naturally the bigger one underneath. And here I'm putting it in. And this is all without rigid retraction, just what I call dynamic retraction. And once we have it closed, we inspect it. And I look at this, and that looks a little bit too pale. So I move the clip up and then use an extra little clip to make sure that this vessel remains patent and yet getting rid of the aneurysm altogether, and then the ICG, and nicely gone. ICA aneurysms are also more difficult. Here's one here that has had a subarachnoid hemorrhage. This one is a good example of one that is caught in the arachnoid and pia of the brainstem, sixth cranial nerve. Notice no retractor. This patient is supined with the head turned to come in through a regular retrosigmoid approach. So basilar artery in the background. And there's ICA and the aneurysm coming off. So you can see the aneurysm very nicely here. Now I have to find a space between the aneurysm and the brainstem. And this, unfortunately, is really scarred. So I have to use sharp dissection to separate the arachnoid and pia. I have proximal control, but really not distal control. So we just have to keep working here to create a pathway for the tine of the clip to slip underneath. And you can see we're getting there. You see the branch of ICA coming out toward us. Now we have room. Now we've got a little room. And that allows me to put the tine across, occlude the neck of the aneurysm, and preserve flow, as you can see here, in ICA. And then what Professor Quintana was talking about, I want to just show you mine. I didn't realize he was going to do that, but the classic subarachnoid hemorrhage. This is what it looks like. No retractor in place. Carotid artery, optic nerve, aneurysm, and there's a branch right on top. So I want to get distal control and proximal control. These are really very dangerous. Now, my favorite material to wrap these is Gore-Tex. And the reason for that is that, unfortunately, when you look at long-term muscle placement, it completely resorbs. It may have done its job and the wall has healed enough, but this gives you a permanent reinforcement of the carotid artery. We bring it around, and now that I have complete control, I say, well, let's see if we can't get this little branch off. And so again, with sharp dissection, we free it up. There it comes. And then again, I like the thrombotic effect of real cotton, not synthetic cotton. Put it around the aneurysm. And then we grab the two edges of the Gore-Tex, slide a right angle clip down, and that right angle clip is going to go and occlude the aneurysm as well. And the reason for that is we want to bring it down snugly so that we even want to make this carotid artery a little bit more narrow so that we have healthy wall to occlude that space. And that's basically what we do. Then cut off the remaining residual Gore-Tex. And this is what it looks like afterwards, a little narrowing. This was the stroke that she started with, not new, no change in her exam, and she recovered slowly from her severe subarachnoid hemorrhage. Complex middle cerebral artery aneurysm. This was a challenging young man because he was from Israel, and he said, I need this taken care of because I'm getting married in 2 months. They send him over here. And so when you look at this is really not an ecliptical aneurysm. So we're going to have to do a bypass. So what we do, here's the aneurysm coming up and 3 branches coming out. So there's one branch we cut off and another one we cut off the aneurysm. which is a little unusual because usually the branches are at the base of the aneurysm. So we cut the aneurysm out to give us more room. So we have the proximal middle cerebral artery, and we have 3 branches. So I'm going to take 2 of the big branches that are right in the sylvian fissure and hook them up to the big proximal middle cerebral artery. And by taking out the aneurysm, we create enough room. So here we have this one filling these 2 branches, and then doing nothing more than taking the STA and hooking it up to the 3rd branch so that all of them have flow. And you can see them all filling very nicely. And this is basically what we did. We cut that off, we cut these off, we hooked these 2 to this, and then this one to the STA. And this is what it looks like. Here you have the branch coming up, filling the 2 branches here. And then you have the STA filling the other branch. And this slowly absorbed, and he fortunately did very well. We also have to get out of trouble. It's not everything is easy. Not everything comes without paying a price. This is a patient with a pica aneurysm. She'd been coiled 3 times, and it continued to grow. So this nice obliteration and then regrowth. And here it is. So she underwent surgery. We were looking at the exposure. This is pica. That's the aneurysm that's already been opened. I take out coils proximally so that I have enough room to put a clip around the neck. Temporary clip on the proximal basilar artery, vertebral artery, on the distal vertebral artery, opening the aneurysm, cutting out some of the coils, being cognizant that this is pica, which naturally we want to preserve. Taking out coils. The instrument makers love this because we're ruining scissors in the process. And then putting a clip at the base of the aneurysm. Unfortunately, that base is very, very stiff. And putting a clip on has torn a hole from the pica and the base of the aneurysm. So I cut off pica. Now I have a hole in the vertebral artery and pica. So all I do is take pica and hook it directly into the vertebral artery where the hole was, where it originally came from. Aneurysm then is completely excluded, and we have created a new vertebral pica junction. Washing it out before closing off the last stitches. And then I'm just taking off the proximal clip so that I can, distal one is still there, so I can check the patency, do an ICG, and you can see pica filling beautifully. And when we look at it, that's what it looks like. And you can see beautiful filling of the pica territory. So I want to go through we're almost to the end of the thinking process of when you're faced with a difficult case. This was an aneurysm, had 2 clips in 91, a clip in 2000, had 3 clips in 2001, and then came to see us. This is with her permission. Now what? So if we get an angiogram and we look at what do we really see? So here it is. What do we notice? Well, we notice, first of all, that the aneurysm is really coming off a branch of the middle cerebral artery. It's not the whole middle cerebral artery. Second, we notice that if we get just rid of this branch, we keep intact normal vascularity of the middle cerebral artery. And then we notice that the anterior temporal artery is still intact, despite all the surgery that she's had. So our goal is really to occlude proximal so that this doesn't come back and supply blood to the distal portion of the aneurysm outlet. So here we're going proximal. You can see all the old scarring from the previous surgery. Some of the clips, this is all aneurysm. Now we get distal. This is the portion that's coming out of the aneurysm. And there are multiple ways to test this. This is the anterior temporal artery. It actually doesn't go to the brain anymore. It goes to the dura. And it has nice flow. So I'm going to use the anterior temporal artery, something we've described earlier on, and using it as the conduit for the bypass to this small distal vessel that came out of the aneurysm. And I'm using 11 sutures and bringing that together. And that really goes very well. And then we clip proximally the vessel that's going to the aneurysm. And when we do ICG, we see this filling very nicely, and we see this filling very nicely. And if you look at it post-op, you can see anterior temporal artery coming around. That's the bypass. And middle cerebral artery filling this way. And she didn't turn a hair. And the last case I'm going to show you is an 18-month-old with this dissecting aneurysm, difficult case. Optic nerve, this is A2. It's a blister aneurysm, so there's just this hole in the A2. So what I'm doing is taking the frontopolar branch from the other side to close this off. It'll be a bypass and a patch to get rid of the dissection. And you can see it all open. And basically post-op, this is what happened. So this is what we did. Frontopolar from the other side, and then attached it on. And what is surgery all about? It's this sort of a result. So in conclusion, nuances for giant aneurysm surgery. Remember that clipping is still an excellent choice. Obviously, close collaboration with your endovascular colleague as their tools become better and better. But remember that for coiling, risk of rebleeding, retreatment, and obliteration, they all favor clipping. Nuances: correct positioning, avoiding retraction, getting adequate exposure, combining your skills with your endovascular team. Anatomy, 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 protect the brain. And the beauty of today's neurosurgical world, that there are so many courses where you can practice not directly on the patients. Develop your bypass skills. They come in very, very handy. Collaborative efforts remain mandatory for giant complex aneurysms. I thank you very much for your attention.
Thank you, Professor Spetzler. Really outstanding lecture. I ask to the younger attendees if they have some question for Professor Spetzler. Don't be shy. This is a unique opportunity. Okay, I break the ice. You are, of course, a giant, you, Yazergil, and the best neurosurgeon. We are now, we facing the, I would say, the advance of the endovascular colleague, the endovascular treatment. You, with your experience, Ernest Niemi, you have, I would say, the charisma, the prestige to counteract them. How a young, even valid neurosurgeon, as you say, clipping is still the best option in terms of long-term results. But we have to face that people always ask for endovascular treatment. Of course, some kind of aneurysm are better treated by endovascular treatment. But how can, I would say, overcome this lack of prestige in facing with the endovascular colleague? This is something, a concern. No one of us perhaps will have the same level of experience that you had. Maybe your fellow Lawton, I don't know, Professor Lawton, but there are very few neurosurgeons that can reach your experience. How can I say, overcome this situation in order to offer, in some case, the best treatment. I'm not in favor of surgery of endovascular. I just want to give the patient the best option for now and for the future. We have to think about the future. You show us people that were treated with 12 clips or with the endovascular. So we have to think about this concern. What do you suggest?
You know, Maurizio, I sort of have the philosophy of we are certain of two things in life, and that is paying taxes and dying. And endovascular, my only real point with endovascular is that they have to prove that they're better. An angiogram does not mean anything. We know that. We know how many patients that had perfectly beautiful angiograms and then went on to have problems afterwards. We ethically need to provide the best treatment. Now, you've really put your finger on it, because the simple aneurysm is very well treated with a flow diverter. What we really need to do is we need to look what they look like 10 years down the line. And so the neurosurgeon, like what Dr. Lawton gets now, is really the most complex cases. And naturally, they also carry a lot of surgical risk. But until we have proven that one is really better than the other, they both should be at the table. I do not think that as a neurosurgeon, if we just do 1 or 2 aneurysms a year, that we will be giving the best to our patient. We need to subspecialize. I mean, if I look at the complex spine surgery today, it is something so different than what I do. And if I had a back, I wouldn't go to somebody that only takes a few back cases. We need to centralize. We need to have cerebrovascular surgeons that specialize in this. The need for bypass will always mean that we are at the table. And I think also it's very important that neurosurgeons are very much involved in endovascular surgery, so it remains part of our decision-making process.
Thank you. Maybe this will be the attitude in the future. We have to.
Yeah.
Yes, thank you, Maurizio. Professor Dr. Spetzler, there are two things. One is the endovascular, and one is getting residents to be once again, absolutely get engaged in vascular neurosurgery. When I started neurosurgery, vascular neurosurgery was the top of the pyramid. And how do you, what do you say for a resident just starting off, that he's not going to be, I think you have mentioned it, but how that he's not going to be there to look after the patients of the endovascular person? That's what the worry for many residents are. Well, in Europe anyway, because we don't coil, you see.
Yeah, and see, at the BNI, I have insisted that our endovascular surgeons are neurosurgeons. They're at the table. In fact, as one of them was a fellow of mine that trained as well in microsurgery, but then had to exclusively treat just endovascular. And he's absolutely terrific. I think in today's world, we can really practice outside of the patient arena. For the vascular neurosurgeon, there's one entity which we see a lot of, which cannot be taken over by the endovascular surgeons, and those are cavernous malformations. I love cavernous malformations because they occur anywhere. And I know that Dr. Lawton is addressing on brainstem cavernous malformation, but those are my favorite lesions because they teach us different ways to get to the most awkward places in the brain. And that translates immediately to a skill set that you can apply for aneurysms. So we should not give up aneurysms, but on the other hand, if there's a better technique to treat an aneurysm that gives long-term protection, then we have to embrace that.
Thank you very much. Maurizio, to you.
If there is no other question, I thank Professor Spencer for this outstanding teaching. And I hope that we can do something in the future just to get the most from this master.
Well, Maurizio, that will be fine, but my communication was misaligned, and I suddenly found myself that I was supposed to give a lecture at 1 o'clock in the morning. Fortunately, that was wrong. Right now, it's a perfect time. So as long as me in that sort of time slot, I'm all yours.
We'll select the best time.
May I ask one question?
Sure, yes. sure, Professor Schroeder.
Hello, Robert. Good to see you all. I have one case with a pretty large MCA aneurysm, not a giant one, a large one, and it had a calcified neck. And each time I placed the clip, it went down to the bifurcation and was occluding it. And then I made the decision to make a wrapping, and I learned from you cottonoid is the best. And I put 2 layers of cottonoid on it, and everything went fine. She went home, and after 1 month, she came back with a complete thrombosis of the aneurysm and a stroke. Have you ever experienced that after wrapping?
I don't use cottonoid. I use cotton. Cotton is very thin, but I don't actually like wrapping a whole aneurysm. I like reinforcing the neck when it's small. Yes, Henry, this has been well reported. In fact, in the old days, what would happen is you would wrap an aneurysm and then would come back this reaction, usually much longer, this reaction to the cotton would be like a separate tumor, reactive tumor, and you'd have to operate on that. So I think cottonoids are a little bit too thick, and that's a lot of cotton for the body to really tolerate.
Okay, but no, I mean, maybe it's the wrong term, but it was cotton.
Oh,
like from
when we talk about cottonoids, we're talking about the pledgets we put in.
No, not the pledget.
You mean cotton? Yeah, Henry, I don't know. not a satisfactory outcome. So we have to learn another solution.
Yes.
Why didn't you do a bypass and just shut up proximally?
Because it was an old lady, and I thought it is enough. I think it's just for another 5 years it will fix it.
Okay.
But next time I'm more smart, I guess.
Okay.
Thank you.
Thank you very much, Dr. Svetla. It has been an honor and privilege, and I'm sure we will all remember. I have put a screenshot from the discussions on the file, so if anyone wants to download it. Thank you very much, sir, for your time. Most grateful, and look forward to your contributions to us in the future meetings. Thank you, sir. Good. Thank you very much. So now, thank you to Professor Yakan Anjali for chairing the late afternoon session. We have got 2 more talks before we go for a 15 minutes a stretch break. So can I please invite Dr. Tracy to share his presentation, please? Are you there, Dr. Tracy John?
Yes.
Thank you very much. Could you please share your presentation? And
thank you.
Dr. Tracy Jones, she's going to present on development of guidelines for early diagnosis of childhood brain tumors at Kenyatta National Hospital in Kenya, Nairobi. Very interesting. Thank you. You have to upload your presentation. Thanks.
Okay, thank you.
Okay.
You click on the share screen.
Almost there.
Great, it's coming. Well done. All there.
It's there?
Yes, absolutely.
Okay, thank you very much.
Well done.
My name is Dr. Tracy John, recently qualified neurosurgeon based in Nairobi, Kenya, and I will be presenting on development of guidelines for early diagnosis of childhood brain tumors at Kenya National Hospital, which I did for my postgraduate thesis at the University of Nairobi. And my supervisors were Professor Mwang'ombe and Dr. Patrick Akuku. Okay. Brain tumors are the commonest tumors after second commonest tumors after leukemia, and the commonest solid tumors in children. Childhood brain tumors are the commonest cause of cancer-related deaths in children and adolescents. Delayed diagnosis is a common occurrence which is associated with increased morbidity and mortality. The pre-diagnostic symptomatic interval for brain tumors in children is one of the longest of all childhood cancers. Therefore, the development of guidelines will help in the early diagnosis and management of childhood brain tumors in Kenya and also in the sub-Saharan Africa to provide better outcomes. The objectives of this study were to outline the signs and symptoms of childhood brain tumors, to establish the pre-diagnostic symptomatic interval, determine the reasons for delayed diagnosis, ascertain specificity of signs and symptoms, and develop clinical guidelines for early diagnosis. Of note, Kenyatta National Hospital, where we conducted the study, is the main national teaching and referral hospital in Kenya. In the methods, we had two phases of this study. The first phase involved a cross-sectional study on childhood brain tumors at Kenyatta National Hospital, which we did to establish objectives 1 to 3, as read before, and approval was provided for. And the sample included all the patients between the 0 to 12 years who presented with childhood brain tumors in Kenyatta National Hospital during the study period of 7 months, who met the inclusion criteria. The second phase of the study involved a Delphi survey, which we did to provide professional expertise through building of professional consensus. This helped to determine the specificity of symptoms and signs and advise on appropriate indications for imaging. The results that we got from the phase 1 of the study were used to formulate statements for the Delphi questionnaire, which was then presented to consultant neurosurgeons and pediatricians from the University of Nairobi and Kenyatta National Hospital. They ranked their level of agreement for each statement using the Likert scale. The statements that had a score of 7 to 9 for more than or equal to 80% of the respondents achieved consensus and were outlined into the final guideline document. The statements that did not meet that threshold did not achieve consensus and were hence eliminated. In the results, we had a total of 61 children with childhood brain tumors between the ages of 0 to 12 years who were analyzed. The age ranged between 1 month to 12 years, with a median of age to 8.2 years and a mean of 7.3. The male to female ratio was 1.7 to 1. In the types of tumors, we identified 15 histological types of tumors, and the most common was craniopharyngioma at 27.9%, followed by medulloblastoma and pilocytic astrocytomas at 16.4%. In the signs and symptoms, we were able to establish a total of 25 signs and symptoms, and the most common of them were headache, which had 75.4%, followed by nausea and or vomiting at 70.5%. Lethargy and school difficulty scored 39.3%, while focal motor weakness scored 32.8%. Of note was there was a high incidence of reduced visual acuity at 26.2%. In the PSI, the range was between 1 week to 3 months. Where is this? Yes, sorry. The PSI ranged between 1 week to 3 years with a median of 3 months. The mean was 7.7 plus or minus 9.6 months. 82% of the patients had a PSI that was longer than 1 month, and only 18% had a PSI of less than a month. In the reasons for delayed diagnosis, the predominant reason was a lack of healthcare worker expertise at 59%, followed by lack of awareness by the parent or guardian at 14.7%. Financial difficulties constituted 5%, while unavailability of CT scans scored 1.6%. In the Delphi survey, a total of 25 statements were derived from the cross-sectional study and formulated in the Delphi questionnaire. Out of these 25, 72 statements achieved consensus. That is 80% or more of the respondents scored between 7 and 9 on the Likert scale, and these were consolidated into the final guideline statements. 7 of them, that 28%, did not achieve consensus and were eliminated. These are the 7 statements that did not meet consensus and were eliminated. The 18 statements that achieved consensus, I summarized them into 8 broad categories, and they fell into first, the general considerations while making a diagnosis of a childhood brain tumor, expected signs and symptoms that the health worker should be looking out for, the patient assessment that should be undertaken for the patient where the differential diagnosis of a child brain tumor is top on the list, specific areas of assessment like eye assessment and the details, assessment of gross motor skills, specifically fine motor skills, and after assessment, also outlined on the indications for brain imaging where there is a differential diagnosis of a brain tumor, as well as imaging modality recommendation. And the discussion, the PSI range from 1 week to 3 years with a median of 3 months and a mean of 7.7 plus or minus 9.6. This compares, although on the upper limit, with the mean and median symptom intervals for cohorts and case series, which were published over a duration of 15 years that had showed a score of 1.8 to 9.8 and a median between 1 to 3 months. Wanyoike et al. On a study at KNH showed a PSI of 3.7 months as well as a median of 3.7 months. Opala et al., another study in KNH, found that the PSI in Kenya was comparable to other low and middle income countries, but was longer compared to the high income countries. 82% of patients in this study had a PSI that was longer than 1 month, while only 18% had a PSI of less than 1 month. In documented studies, only 33% are diagnosed within 1 month after the onset of symptoms. Factors associated with late diagnosis, the main reason was lack of expertise by the healthcare worker. And Wanyoike et al., a study at KNH, found the reasons for late diagnosis to include lack of knowledge and awareness of the caregivers and inadequate diagnostic tools, especially in the rural areas. In Kenya, we only have 2 main neurosurgical units at KNH and MTRH, Eldoret, and patients are mainly seen in the peripheral county facilities before referral, where the majority of health workers are clinical officers and nurses who mainly lack the expertise on childhood brain tumors. This lack of expertise and awareness is associated with the complexity of the symptomatology of these tumors. In our symptomatology, we identify 25 signs and symptoms, with the top being a headache at 75.4%, followed by nausea and vomiting. And this pattern clearly established a similar pattern that has been documented by studies. Wilner et al. Also found the commonest signs and symptoms to be headache, nausea, and or vomiting, amongst many signs and symptoms that were recorded in that study. In the Delphi process, we had 18 statements that formed the final guideline, the ones that met the consensus threshold. This Delphi process is a practical and validated method of guideline development as documented in other studies. In the clinical guideline, the development of these guidelines was based on quality level of evidence through a combination of a cross-sectional study and a Delphi survey as documented. In the conclusion, we were able to establish the varied presentation of child brain tumors with headache as the most common at KNH. The study also showed that the delayed diagnosis at KNH had a median PSI of 3 months and a mean of 7.7. The main reason for delayed diagnosis was lack of expertise by the healthcare worker, and therefore the guideline will assist the healthcare worker primarily by providing the varied presentation pattern as well as imaging recommendations for children with brain tumors. Recommend that once the guidelines are published, should be able to disseminate the guidelines through the Ministry of Health, Kenya, to all the health facilities in the country for implementation. Would require training of health professionals on the utilization of the guidelines, as well as improvement on availability of MRI and CT scan machines in the health facilities to facilitate in the diagnosis. So my references. Thank you very much.
Thank you very much.
Thank you.
Just a second. Thank you very much for your very important study that you have done. I'm glad that you will be taking this to the ministry and that it will be taken further. One thing that I noticed that you found that the majority of the largest group of the tumors was craniopharyngioma in your practice. Is that right?
Yes.
Yeah, it's interesting because in the Western practice, in our practice, it's a very small portion, craniopharyngioma. So obviously there are differences between different places. Any questions from the participants? And in terms of the ages, at what age is childhood for you? Is it 16, 18, or 21 in Kenya?
For hospitals, for healthcare delivery, pediatrics is between 0 to 12 years.
Okay.
Yes.
So after so this is the 0 to 12 years.
Yes.
Okay. And so in UK, pediatrics is some places 16, some places 18. And in states, they even take the pediatric definition to 21. So when you compare the epidemiology of different places, you might find children might be defined as different. Thank you very much, Dr. Tracy, for the important project. Well done. Congratulations.
Thank you very much.
Thank you. So now I'm going to introduce my co-chair, Dr. Russell Andrews. Dr. Russell Andrews is coming from California, a distinguished neurosurgeon. He was, I first knew of Dr. Andrews back in the 1990s when he published the first book that I can remember of on intraoperative, as well as I think it was neuronavigation as well. And he's was in Stanford, and then he has been in his practice in California, and also is associated with the NASA as well. But his international contribution is amazing. He has been one of the very active WFNS officers over the years, holding many posts, and his commitment to global neurosurgery, you will come to his talk later. So thank you, Dr. Russell Andrews, for co-chairing this session. What I will do is, shall I introduce, I'll bring in the next speaker. It's Dr. Dr. Johnston Muthoka. Dr. Johnston Muthoka, do you want to share your presentation? And I hand over the baton to Dr. Andrews. Thank you, Dr. Andrews.
Thank you, Naren. You're the one who deserves all the accolades for getting meetings like this together.
Thank you, sir.
Right. Hello, everyone. Can you hear me?
Yes, sir.
Oh, all right. Thank you. Let me share my screen. Can you guys see my screen? Can everyone see it?
Yeah.
All right. Right. My name is Dr. Muthoka Johnston Mativo. I'm a neurosurgical resident at the University of Nairobi, currently in my 5th year. So today I'm presenting a case that we handled in our department, myself, my colleague Munyalo, and our professors, Professor Mwanda of hematology and Professor Mangombe in neurosurgery. So just as a recap, intracranial hemorrhage and hemophilia occurs in about 3 to 8% of those who have hemophilia, and definitely causes high rates of morbidity and disability in those who end up with intracranial hemorrhage. Of course, the more common presentation is a joint swelling and hemorrhage, which occurs more in the patients who have mild or moderate hemophilia. But in patients even with severe hemophilia can have spontaneous intracranial hemorrhage. Those with mild or moderate can have, with minimal trauma, minimal provocation, can also develop intracranial hemorrhage. Mortality approaches 20%, more so in developing countries, most of the time due to a low index of suspicion. Risk factors, severity of the factor deficiency. Just as an indicator, severe hemophilia, these are patients who have less than 10% of normal factor 8 or von Willebrand factor activity. Presence of inhibitors to the factor 8 and its receptors, a history of trauma, hypertension in adults, viral infections like HIV can couple the factor deficiency with the thrombocytopenia, and so make things worse for these patients. A previous episode of intracranial hemorrhage and patients who have severe hemophilia but are not on any prophylactic regimen. All these are seen as patients who have a higher tendency to develop intracranial hemorrhage. For ourselves, here the diagnosis of hemophilia itself usually is by accident because we don't have very set records, and patients most of the time chance on the diagnosis of hemophilia by accident. Maybe they went for a circumcision. Actually, this is one of the commonest ways in which we discover our patients have hemophilia. They go for a circumcision, usually done by just a local practitioner, not in any hospital setting. And afterwards, the bleeding just doesn't stop. So again, we also have that challenge as far as diagnosis and keeping our records as far as patients with hemophilia are concerned. Definitely presenting a formidable challenge in their management. So our case report is a 10-year-old boy who had the severe form of hemophilia, and he was actually a known patient, but had been lost to follow-up. Had last been to the hematology clinic about a year ago. He presented in an altered state of consciousness, GCS of 12/15, a history of a fall 5 days prior, headaches since, and then had convulsed twice that same day when he presented to the A&E. He had a cubital fossa hematoma that was occasioned by venous sampling. The other neurological exam was unremarkable. There was prior history of an intracranial hemorrhage that had occurred a year earlier, and hence the diagnosis. His hemogram showed a HB of 11.1. These are just the important parameters that I felt I needed to share, but we had done a full panel of investigations, renal function and liver function tests. Also, the coagulation test showed an APTT of 45 seconds. Our laboratory range is 24 to 35 seconds. So given the history and the presentation, we did a head CT scan. And our head CT scan showed an intraventricular hemorrhage that was mostly located in the third ventricle, extending into the fourth ventricle. There was also a mild hydrocephalus. But then since the patient, we had controlled the convulsions initially, and the patient was stable in casualty, so we decided to go the conservative way in consultation with the hematologist. We gave factor concentrates, 50 international units per kg, put on phenytoin, cetazolamide, paracetamol. We were to monitor the HB and the PTT, and also the intracranial hemorrhage, with serial head CT scans. We're also definitely going to include the hematology and the pediatric ICU teams to see the patient. But then later on, a few hours within the same day, the patient went into status epilepticus, and we required sedation and mechanical ventilation. So he was admitted to PICU, pediatric ICU. We increased prophylactically, even before we had done the image, we increased our factor 8 to 50 international units per kg twice a day. A repeat full hemogram showed a HB of 5.8, so we knew he had bled somewhere. And the PTT was 92.1 seconds. Factor assay done showed that the factor activity was 12.9%. But the normal should be 50 to 100% of factor 8, to 150% of factor 8 activity. So repeat head CT scan. Again, this is day 3, so you can see that we also had a bit of delays as far as getting the image.
Dr. Johnson, Dr. Johnson,
Yes.
you've got 2 minutes. Sorry, the time is tight, so you've got 2.
All right.
Thanks. Thank you.
Sorry, so I'll rush through.
Yep.
So this is the increase in the size of the intracranial intraventricular hemorrhage. So we decided to insert an EVD. We gave a factor 8 stat. That changed the PTT to 45 seconds. We inserted the EVD on day 4, and then we maintained on 100 international units twice a day. Our post-op GCS was 60/15. He self-extubated 2 days later. EVD drainage 100 to 200 ml per day. The PTT remained elevated, maybe due to inhibitors, but we never really confirmed why it remained elevated. But then he gradually improved, and over the next 2 weeks, we were actually able to discharge the patient. So this is our head CT scan on day 6 after the operation. You can see the EVD on the anterior aspect, on the anterior horn of the right lateral ventricle. The hemorrhage is still there. And then you have on day 15, almost complete resolution of the same, and we removed the EVD. So my last slide, hemostatic support for us was our main target in management. We don't have ICP monitoring in our setup, so mostly we use imaging and clinical assessment to guide our decision-making. The EVD serves to lower the intracranial pressure, not targeting the intraventricular hemorrhage per se. A high index of suspicion and multidisciplinary approach totally helped us to manage this patient. Prophylaxis is key. Now, if you wanted to really apply the best care and prevent future events and improve quality of life, inhibitors are there and they pose a challenge. But with when you induce immune tolerance with giving repeated doses of the factor 8, then you're able to also surmount the challenge. Thank you very much. Those are my references. Sante sana.
Thank you very much, Dr. Mutoka. In terms of, if you have that case again from the beginning, anything that you will, if you have another case like that, would you do something different? Anything that you will advise for people who have similar hemophilia patients? What would your advice be?
Okay, as we were managing the patient, we noted that the initial dosage of factor 8 should have been a bit higher because we started with the 50 international units once a day. That does not increase the factor activity to a large percent. So probably you should have gone straight to 100 because you already had an event, and probably we should have been a bit more aggressive. That's what I think the different thing we could do if we saw the patient. But then I was just highlighting the fact that given the fact that we don't have ICP monitoring in our setup, we are still using our imaging and our clinical assessment, and we were able to intervene using the EVD. and the patient did well. But I would have increased the dosage at the beginning.
Well done with the case. Well done to the team. Thank you very much for the presentation. Thank you.
All right. Thank you.
Thanks. Dr. Russell, do you want to introduce the next presentation?
Sure. I'd just like to congratulate the last speaker for doing a good job despite the lack of ICP monitoring. That may actually be a blessing in some cases where it forces you to be more clinically attentive. So our next speaker is from Tunisia, the hospital Habib Bourguiba in Tunisia. Khalil Ayadi be talking about association between breast cancer and glioblastoma. Is it a coincidence?
Thank you, sir.
Dr.
Can you see my screen?
Yes.
Okay. Well, my presentation is about the association between breast cancer and glioblastoma. Is it a coincidence? I will start with a case report. It is about a 39-year-old woman with a familial history of breast cancer. In fact, she had, at the age of 23 years old, an in-situ right breast cancer treated with surgery. Then she was followed up by the oncology team. 16 years later, at the age of 39, she was admitted for an increased intracranial pressure syndrome that was evolving for about 1 month. Cerebral MRI showed, as you can see, this tumor. It was a glioblastoma after surgery and pathological examination. Immediately after surgery, she had a right side hemiparesis that improved gradually with physical rehabilitation. The patient had radiation therapy, and the genetic study showed that she had the BRCA1 mutation. So we thought, is there an association between glioblastoma and the cancer, the breast cancer that she had 16 years before? Well, in discussion, breast cancer is the most common cancer in women. It is the second leading cause of death in women and has, as you all know, many risk factors such as genetic predispositions, hormonal factor, obesity, etc. As we all know that the glioblastoma is the most common intracranial tumor. It affects males more than females. So is there an association? The association between the two tumors is uncommon, and a few cases have been reported in the literature. In fact, GBM or glioblastoma occurs in these cases many years after breast cancer, usually around 18 years later, and patients do not have a change in the survival rate. It is not shortened. These are some examples of articles treating the cases of the association and searching an association between the mutations and the glioblastoma. This Italian article in 2005 has the most cases. It has 11 cases, in fact. And conclusions are not really clear. In fact, the authors did not find any association between glioblastoma and the mutations. It is unclear, and no association between the mutations have been found. So what's happening here? In fact, there are many theories aside from BRCA1 and 2 gene mutations. Some authors suspect the mutation of the P10 tumor suppressor gene. Others suspect the P53 tumor suppressor genes. Some suppose that there is a hormonal effect that causes the association between the two. Others say there is the effect of radiation and chemotherapy used in the treatment of breast cancer. Well, in conclusion, is it a coincidence? Well, in fact, we don't know. And further molecular and genetic studies are essential in order to dig even deeper and find if there is really an association between the two tumors. And thank you for your attention.
Well, thank you. It was excellent. I just wonder,
Yes.
People who have one form of cancer, it seems like there's certainly a higher incidence of a different kind of cancer appearing at some point.
Yes.
And I wondered if you run across other tumors that are associated with breast cancer. I mean, glioblastoma is pretty rare.
Yes, yes.
But when you're looking through the literature, what else have you run across?
Well, I found other mutations. Well, I think, in fact, they enter in different syndromes. If I can remember well, there is the Di-Fumani syndrome and other syndromes that associate breast cancer with other types. However, we focused on this this specific type of association because it is uncommon and we don't have an explanation if there is an association or not.
No, I guess another question is going the other way, looking at patients with glioblastoma and seeing a history or coincidence of other types of cancers in addition to breast cancer. You know, looking at it
in our study.
Backwards.
In our study, we did not have any other associations because mainly the patients that have other tumors, in fact, there is not very long survival except for few tumors such as breast cancer and some colorectal cancers, I suppose. In fact, with pulmonary disease, the survival is not very, very long, so we do not have a clear idea if there is a chance to develop or a risk to develop other tumors.
Well, I think the question would be whether they had different type of cancer earlier that was either cured or dormant.
In our series, we did not have any other association between the glioblastoma and other tumors.
Yeah, it's an interesting question.
Yes, yes, it is. It is a subject to dig in.
Other questions? So, well, again, thank you, Dr. Ayadi.
Thank you, sir.
Thank you very much. Thank you, Dr. Russell. So I think we'll just before we go for a 5 minutes stretching, I just want to say we had a absolutely outstanding session just now, and you from I think the topped it all with Professor Spetzler's talk and Dr. Professor Quintana's talk, and then the talks from everyone from different parts of the world. And the last session is absolutely another fascinating lectures. We are going to get Professor Lawton. He is giving us the last lecture, but Dr. Andrea Servio from Argentina is going to present their series of brainstem cavernomas, and Dr. Russell Andrews, who's the co-chair, is going to present on can we make global neurosurgery truly global. I think that's an important question. I think we have to get the gear 1 or 2 notches up, and I will see what Dr. Russell Andrews has to say, and always collaborators. We have a talk on brain tumors on the pattern in Kenya. And one of those things, when we all do shunts, we have all heard of it, extrusion of distal catheters. And we also have from our Mexico colleagues on trigeminal neuralgia to giant osteoma. So fantastic session left with the highlight of Dr. Lawton's, I'm sure, mesmerizing and stimulating talk on brainstem cavernoma. So let's meet up in 10 minutes. Thank you very much. Thank you, Dr. Andrews. If you could please continue with the moderation once we come back. Thanks.
Sure. Thanks, Tom.
Thank you. Okay. Good. Welcome back for the late evening session or the night session. And I think this will be a 12-hour meeting. I think in the history of neurosurgery, I doubt that we have had as long a meeting even in the non-webinar, the real world, with about less than 1 hour of total breaks. The next presentation is from Dr. Muninga Rodriguez. I will just to make sure I can get the.
Thank you.
Hello, thanks. What name are you under, so I can let you be a co-host so you can share your presentation? What's your screen name, please?
Okay, I will share it.
Is it Aaron? Is it? Good. I got you. Excellent. Okay, you should be now able to share. Aaron. So Dr. Mungia Rodriguez Aaron Giovanni, he's presenting from Mexico. He's going to present, this is a flash presentation on trigeminal neuralgia secondary to a giant osteoma. Thank you, sir.
Thank you, Naren.
Thank you.
Well, my name is Aaron Mungia. I'm going to present you a case report of trigeminal neuralgia secondary to giant osteoma. We are from Hospital Angels in Morelia, Mexico. We are specialists in treating trigeminal neuralgia, which is a chronic disorder characterized by spontaneous and recurrent episodes of neuropathic pain, generally affecting one side of the face and involving one or more branches of the trigeminal nerve. Based on the etiology, trigeminal neuralgia is classified into idiopathic with an unknown cause, classic when a nerve is compressing the root and trizone of the nerve, and secondary when it's caused by an underlying disease, such as tumor or multiple sclerosis. Osteomas are slow-growing tumors characterized by the proliferation of compact or cancellous bone. Osteomas are benign tumors of long bones that might uncommonly arise from the skull in the frontoethmoid region and rarely from the temporal and occipital bone. They are incidentally identified. Complications derived from the osteomas are due to the involvement of surrounding structures. When the tumor affects a nerve, compressive neuropathy may be developed. The case presentation: in April of the last year, a 37-year-old female presented with severe paroxysmal pain of 3 years of occlusion of the right side of the face, radiating the territory of the B2 and B3 branches of the trigeminal nerve. The pain progressively worsened until it became incapacitating. MRI showed a hypointense mass located in the inner side of the petrous apex in the right temporal bone with an irregular multilobe shape measuring 20, 36, and 40 millimeters extending to the right cerebropontine angle. In the blue arrows, we show the tumor. In the green arrow, we show the trigeminal nerve in its normal path. And in the red arrow, we show the trigeminal nerve displaced by the tumor. Angiography revealed a lesion with bone consistency displacing intracranial structures. The tumor is delimited by a red border. No blood vessels were identified supplying the tumor, and the right superior cerebral artery was interrupted by the tumor. It is shown in the green arrow. Its circulation was possibly replaced by a duplicated upper right anterior inferior cerebral artery. The duplication is indicated with the yellow arrows. The surgical technique, minimally invasive microsurgical decompression surgery was performed with a retrosigmoid craniectomy of 20 millimeters. An abnormal osseous structure was identified in the right sister. The bone lesion was interfering with the clear identification of the trigeminal nerve and facial vestibulocochlear complex. Here we show that only the trigeminal nerve was affected by the tumor. Osteoma was progressively dried, avoiding to damage adjacent vascular and brain structures. Due to the high risk of causing a neurovascular damage, it was decided not to remove the osteoma completely. The trigeminal nerve was identified anatomically intact in its external part, and exploration was performed in order to verify that there was no hidden vascular conflict. The results: after the surgery, patient was neuropathic, pain-free, and neurologically intact. No alterations in hearing and facial functions were informed. Here we show a preoperative computer tomography where the osteoma can be clearly identified. At 3 and 9 months of follow-up, the computer tomography revealed that no growth of the osteoma was observed. At 18 months of follow-up, the patient remained asymptomatic for trigeminal neuralgia. Histologic examination reported a benign lesion characterized by the formation of mature trabecular bone with absence of osteoblast and osteoclast. It's important to highlight that only patients with symptomatic or deforming osteomas should be treated, generally by tumor excision or drilling. Periodical imaging tests, audiometric evaluation, and clinical observation are necessary in order to exclude recurrence. Our conclusions: despite its low incidence, osteoma of petrous bone should be considered as a cause of trigeminal neuralgia. To ensure pain relief, the osteoma must be drilled carefully without damaging adjacent structures, in addition to verify that there is no neurovascular conflict. Trigeminal neuralgia secondary to osteoma must be diagnosed after a correct clinical, radiological, and pathological evaluation. Thank you.
Thank you very much. That's an impressive case. Dr. Andrews, do you have any question for Giovanni?
Just want to ask Dr. Munguia, if, do you have cranial nerve monitoring available? Or did you do this with, you accomplished that without the monitoring? That's, congratulations very much. It's a technical feat to protect those nerves.
Could you repeat the question, please?
Did you have cranial nerve monitoring, facial nerve monitoring during this case?
Facial nerve?
Electrophysiological monitoring of the nerve function, the facial nerve.
We don't have any monitoring for the functions.
Oh, that's congratulations on your technique. Then that's makes it extra difficult.
Yes. It was our first case after more than 700 microsurgical decompressions.
Well, good.
Well done, and well done to, I presume your senior colleague is Dr. Mauro Seguro. So well done, Dr. Seguro, fantastic. So if there's no other question, I will move to the next presentation. Dr.
Yeah, speaking about the appointment at 3:30, correct?
Just a second.
May I say something?
Yeah, sure, absolutely.
Yeah, that should.
Well, we use.
Okay, we'll see at 1:30. Wow.
Wanted to present this very, very rare case, huge osteoma in the petrous apex, because it's a very strange condition, clinical condition. And before the CT and before the MRI, we didn't know that we will find this huge tumor, bone tumor. So it's part of the preparative previous to the surgery, CT and MRI. And this is the first time around more than 700 trigeminal neuralgia cases. So we thought it could be interesting. And we, beside that, we have another.
Sorry, the link is not link is working. Is it okay, Dr. Andrews? Do you want to introduce the next presentation, Dr. Andrews? It's also a let me see. It's an oral presentation. Thank you very much, Dr. Giovanni. Thank you, Dr. Sigro. We'll move to the next talk for sake of time. Dr. Benjamin Matiso, are you there?
Yes, I'm here.
Good. I will just, oh yes, I got you. Okay. Okay. Good. So you have 10 minutes for talk, 5 minutes for discussions. We are slightly tight on the time. So Dr. Russell Andrews, may I hand over to you for this talk? Thank you.
Yes, it's Dr. Benjamin Matiso from University of Nairobi. And the topic, as you see here, is extrusion of distal shunt catheter, a report of 3 cases. Problem we're all familiar with, I'm sure.
Yes, can you see my presentation?
Yes, we can. Yes.
All right, thank you very much. So, my name is Benjamin Mutiso from the University of Nairobi. So, greetings from Nairobi, Kenya. And I'm a 6th-year neurosurgery resident, and I'll be presenting to you a report of 3 cases of distal shunt extrusion that we have managed in our institution, and supervised by Professor Nimrod Mwangombe. So there are no conflicts of interest, and I would like to start with a synopsis of hydrocephalus in Kenya. And Kenya is a country with a population of 50 million people. And we see about 6,000 new cases of hydrocephalus every year. And majority of these children are treated by ventricular peritoneal shunting. And from studies that we have conducted in our institution, the average shunt duration in our setup is about 18 months, with the leading causes of shunt failure being shunt blockage and shunt infection. Now, looking at the distal catheter complications, these seem to form a smaller proportion of the total shunt complications compared to the proximal catheter complications, and they form about 10 to 30%. And even rarer are the cases of distal catheter extrusions, and these have only been seen in case reports. So these are extremely rare types of shunt complications, and some of the sites of extrusions that have been described before include oral, anterior abdominal wall, umbilical, vaginal, urethral, and anal extrusions. So our unit performs about 350 shunt surgeries per year. And we usually use the Chabra shunt, and this is because this is a relatively low-cost shunt. And from studies done in our region, it has similar efficacy and a safety profile compared to more sophisticated shunt systems. And from this kind of a practice, we usually see about 2 to 3 distal catheter extrusions per year. And this is an illustration of the called Shunt. I think the audience is well aware of this, and it has a proximal catheter, a distal catheter, and a reservoir, which also contains the ball and spring valve. So straight to our first case. This was a case of vaginal extrusion that we saw in an 8-month-old girl that we had treated for hydrocephalus that was brought and that came after a bout of meningitis, and this child had had the shunt for 4 months, and she came to hospital because the mother had noticed that the shunt was protruding from the vagina. And you can see that from this image, you can see that the shunt is actually protruding from the vagina. And this is the distal shunt catheter. Immediately when you saw this patient, we performed a shunt tap and took the CSF for microbiological studies. And then we planned to remove the shunt promptly in theater thereafter. After 3 days, the microbiological studies showed us that the CSF was actually sterile, and we put a new shunt on the opposite side, and the child was allowed home after 3 days in good health. So this is the first case that we are presenting, and the second case is a case of anal extrusion of a shunt, which we saw in this child who we were managing for congenital hydrocephalus. We had shunted at 2 weeks of age and came to us at 3 months of age. So it had the shunt just a little above 2 months. Of notice that the child was severely wasted, and you can actually see from this image that there's a lot of wasting from the limbs with a lot of redundant skin. And we could see the shunt catheter that was protruding from the end. And what we also know, this shunt was actually active and was draining clear CSF from the distal slit valves. So immediately we saw this child, we also took CSF from the reservoir and took it for microbiological studies and planned to remove the shunt as soon as possible. And after 3 days, this CSF was also sterile, and we put the shunt on the opposite side, and we were able to allow this child home 3 days later with no complications. Our third and last case was a child who presented to us with umbilical extrusion of a distal shunt catheter. And this was a 6-month-old boy who we had shunted at 4 months of age. So I'd had the shunt for about 2 months. This is a child who was also known to have a reducible umbilical hernia. So he came with a shunt catheter that was protruding from the umbilicus. And if you'll see this image, this was the site of the previous surgery. So the incision in the abdomen that had been done about 2 months before. And you see that the shunt has now actually extruded from another part of the abdomen through the umbilicus. So for this particular child, it took 3 days to get to hospital because of socioeconomic challenges. And by the time they were coming to hospital, there was actually a purulent discharge from the distal end of the shunt. We aspirated pus from the reservoir, and while we were removing the shunt, disconnecting at the cranial end, we also got pus from the ventricular catheter. So this is the amount of pus that we aspirated from the ventricular catheter, and we subjected this pus to microbiological studies and grew Staphylococcus epidermidis. We put an external ventricular drain in this child that we maintained for 10 days. And after 10 days, the CSF had cleared, and there was no, and then we monitored the child thereafter for signs of shunt dependence, which he did not develop. And we allowed him home after a 3-week hospital stay to complete an 8-week course of antibiotics. So these are the 3 different types of shunt extrusions that we have seen in the last about 1 year. So in the next 1 or 2 slides, I'm going to discuss the the mechanisms of shunt extrusion that have been elucidated before. And the exact mechanism of shunt extrusion is not known. Several hypotheses have, however, been suggested, and one of which is adhesion of the distal shunt catheter to the body, to the viscera or to the body wall, and this leads to a local inflammatory response that weakens that part of the body, and therefore the shunt can extrude through there. Another theory is that patients could be allergic to some of the shunt components, and then again, this would also lead to an inflammatory response that could also weaken the body wall and lead to extrusion of the shunt. Other factors that have been thought to play a part is malnutrition, like we saw in one of the children, excessively long catheters, and remember the Chabra shunt is only one standard size, so the same length we use also for adults is the same one we'll use for children. And one of the other theories is the water hammer effect from the CSF pulsations that is transmitted across the shunt to the distal end. And these continuous pulsations can also lead to erosion of the body wall with extrusion of the shunt. So how do we manage an extruded shunt? Initially, the first thing is to obtain CSF from the shunt reservoir, and this is important to clear CSF of any form of infection that could have arisen from the extruded hardware. And in the next step, at that particular point, it's also recommended that you start the patient on antibiotics as soon as possible. Then the next step is to remove the shunt as soon as possible. And this is usually accomplished by dividing the shunt just below the reservoir, such that you're able to pull the shunt from the extruded end. This is to prevent contamination of the tract. So you don't pull it upwards, you pull it downwards. And abdominal exploration for the site of internal perforation is usually unnecessary, and reports have not shown any complications that have arisen from the internal site of perforation. Temporizing measures for the management of hydrocephalus can be employed by the time you get the microbiological results to decide the next move. If the CSF culture is sterile, shunting can be performed, and oftentimes this will be done on the opposite side. If there's evidence of infection, an EVD is placed until the infection clears, and thereafter a shunt can be placed if the patient has features of shunt dependence. So this is an algorithm to demonstrate this management, that if a shunt is extruded, the next step is to do a shunt tab and then remove the shunt. And then if there are features of infection, you remove the, if there are no features of infection, you replace the shunt and put a new shunt on the opposite side. Whilst if you find an infection, you put an external ventricular drain and let the infection clear, and then plan for definitive ventricular peritoneal shunting or endoscopic third ventriculostomy after the infection has cleared. So thank you very much. This is the hospital that we practice in. This is Kenyatta National Hospital in Nairobi. And thank you very much. Asante.
Very nicely timed. Dr. Russell, questions for?
Yes. Well, I think this makes the point. I mean, you had 3 cases. They all were less than 1 year old. From your review of the literature and your own experience, this is primarily a problem of the very young, correct?
Yes.
That's the only case that I can recall when I was a resident, and it was perhaps a 2-year-old with an extruded catheter. So other people have questions?
Obviously in UK, we nowadays rarely see this problem. In my time here now for how many years, almost 20 years, I haven't seen any extrusions. Did you see any extrusions, Dr. Russell Andrews, in your time?
I saw one as a resident, but again, it was a young child, but not an infant. Yeah, I think it's very rare. And I think one thing we certainly in an infant would not put in a lengthy catheter, keep it quite short, and admittedly revise it as they grow older to put an extension or convert it to, like I say, to a ETV.
Just one question, Dr. Matty. So this is a obvious question. I'm sure the answer is no. These the tips of this distal shunt tips, they were not in any way sharp or anything like that, no?
No, they are not. The typical Jabra shunt, the tip is actually blunt.
Okay.
Yeah.
And now I think the shunt material might be one reason that we nowadays don't get it here, but we still here in UK we put the whole length of the shunt in infants, even if they are premature infants. So thank you very much. That's very, very useful, thought-provoking talk. Any other questions for Dr. Ben? Let's see. Anything on the chat box? Let me see. Just I think we are got a couple of minutes. Anyone else who has come across in the audience shunt extrusion? Okay, if you have, you can put it on the chat box. So we'll move to the next talk. It's an oral presentation from Kenya, from Professor Nimrod Muangombi on the pattern of brain tumors in Kenya, a review. Thank you. So once again, Dr. Muangombi, just because of the time, 10 minutes talk and 5 minutes we can discuss. Thank you.
Thank you, Dr. Naren.
Thank you, Raj.
You can see my screen?
We can.
Not yet.
Not yet.
Okay, let's see. Can you see my screen? Not yet?
We can, yes.
You can?
Yeah.
Okay,
Yeah,
great.
you have to maximize it.
Do you want me to maximize it?
Yeah, if you go to presentation mode, then.
Okay.
If you press from the beginning, then it should.
On the left side,
on
all
the
way to the left.
Okay.
Brilliant, thank you.
Yes. All right, thank you very much. I'll try my best to keep time.
Oh, we need to keep time, I'm afraid, because we are very tight. Sorry. Okay, so I will give you a shout after 10 minutes. Thank you.
All right, thank you.
Thanks.
Now, this is I'll start from the beginning. We did a part where the presentation is on the pattern of brain tumors in Kenya, a review. It's work which was done between me and my colleague, Dr. Kitungu. The outline is as shown there, and conflict of interest is none. Now, previous studies have shown that brain tumors, previous studies seem to show that brain tumors are not as common in Africans as they are in Caucasians. And these were studies which were done elsewhere. But we still do see brain tumors, and probably the reason why these studies say that the brain tumors are not common is because of the lack of brain tumor registries in our country. The objectives of this was to provide an overview of the primary brain tumor epidemiology in Kenya and provide comparisons with reported global and African values, to review the pattern of common brain tumors at the Kenyatta National Hospital in the pre-CT scan era and in the post-CT scan era, and to see if advances in neuroimaging have led to the improvement in the management of these patients at the Kenyatta National Hospital. The methodology was that we reviewed data collected in Kenya between 1971 and 2019, and we also did peer-reviewed search articles on PubMed, African Journal of Medical Sciences, and in NARI databases. The annual global age-specific rates of malignant brain tumors is approximately 4 per 100,000 for males and 3 per 100,000 for females. These are high in developed countries, where it's about 6 for males and for females, and they are less in developed countries. We think that this is probably due to underdiagnosis, although sometimes it's also said that there is ethnic differences in susceptibility to brain tumors, as some studies in Israel have shown. Are brain tumors common in Africans? Earlier studies which were done in East Africa by Moazi and Trowell in 1944 seemed to suggest that the pattern of brain tumors in Africans were fewer than they were seen in Caucasians. And this was supported in the earlier literature of data which was obtained from South Africa, where Froman and Lipschitz, in a study done at Barag North Hospital in South Africa, a hospital which mainly serves Black population, observed that the rate of brain tumors in the Caucasian population was at least 10 times that seen in the Black population. However, the incidence of brain tumors overall in Africa is 1.2% from previous studies done long ago. And this seemed to match the incidence of brain tumors in the Caucasians, which was 1.5 of the total populations. From the Nairobi Cancer Registry, data which we obtained from the Nairobi Cancer Registry, and this gives a pattern of mainly of not only brain tumors, but cancers generally in Nairobi. This is data from the Cancer Registry, where the population in Nairobi is about 3.2 million. Data was collected between 2004 and 2008, where there were a total of 8,900 cancer cases were registered. And of these, of interest is that 3,800 were men, and 5,900 were women. Women were much more than men. But also of interest is the fact that in these cancer tumor collections, the brain tumors reported were 2.3 per 100,000 for men and 0.9 per 100,000 for women. And if I show you this data here, you can see from the cancer data collected in Nairobi, the main tumors which we tend to get are prostate, esophagus for men, and breast, and cancer C of the cervix in women. And you can see the brain tumors or tumors of the central nervous system are right down there at the bottom. And this is, of course, one of the reasons why when it comes to priority in management of brain tumors, then it's not given very much priority in developing countries, because in terms of tumors, you're not producing as many, you're seen to be not to be having a big problem as compared, let's say, with, say, a prostate or say a breast or say a cervix. Well, how was the pattern in the pre-CT scan era? In the pre-CT scan era, the neurosurgeons who practiced then, that is in the 70s, Robotic and Mopi, did a review where the gliomas formed 45% of all intracranial tumors at the Kenyatta National Hospital. This was also similar study findings by another pathologist. This one was a pathologist, Kasili, who did a review of histopathological specimens which he was receiving from postmortems and also from surgeries around that time. And again, 45% of the tumors were astrocytomas and ependymomas. Again, gliomas seem to be making the bulk of the tumors which were being seen around that time. An earlier study which we also did ourselves But this was a review of brain tumors actually in the pre-CT scan era, although we published in 2000, but these were tumors which we managed in that hospital before the CT scan was available. Again, we were seeing that the tumors which were most common were gliomas, and then they were followed by meningiomas, which made up about 34%. These were histological types of tumors which you saw that time, and you can see the data which was published there, gliomas and cacilis, and as also there, gliomas. Now, the lower data which you're seeing there, this was the post-CT scan era. The post-CT scan era, now this from 2005, we started seeing more meningiomas, and you can see the data. This data is quite reliable because it was from imprint cytology of all the cases which we were doing. We're trying to test the significance or the effectiveness of using imprint cytology to diagnose tumors when you do surgery. So we did all the surgeries and we did imprint cytology in all the cases which we did surgery. So these are reflection of the cases which we did. And you'll note that 40% of the tumors which we analyzed then were meningiomas, and astrocytomas were making up 26, almost 30% of the tumors, but we were seeing more meningiomas in that study. That repeats basically what I have talked about in the previous slide. And then another study, which was a 2-year prospective study on the pattern of meningiomas in the hospital. This just confirmed the fact that meningiomas are more common in females than in males in our setup also, although the rates are they're in a rate of 2 to 1, which probably is a bit lower than seen elsewhere. But what is significant there is that the duration of symptoms was less than 6 months in about 30% of the patients, and 6 months to 12 months in 30% again, and at least 2 years and more, about 17%. And again, what is significant there is that about 30% of the patients who we saw in this study actually presented when they were already blind. And this was in the post-CT scan era. And the post-CT scan era, patients actually were presenting when they were already blind, a large percentage, 30% of patients with meningiomas. Again, what is also significant in this study was that the Karnofsky pre-op functional status, which again, in 50, about nearly 60%, it was between 70 and 100, but another 40% was between 50 and 70. And less than 50, of course, was very, very low. But again, what is most significant again is the fact that quite a number, about nearly 4% of the patients had such a low Karnofsky score that we did not do surgeries. But again, what is significant in this review is the fact that even in the post-CT scan era, patients were still presenting with a low Karnofsky score, of at least 50 to 70, which means that there is still late diagnosis even in this post-CT scan era. So in the post-CT scan era, gliomas, we think that now this is another study which we just did recently. Now this is a review of brain tumors in children, and this we reviewed 87 brain tumors in children between 2018 and 2019, and this was a histopathological review. So basically, this was done by the first author was writing this for his thesis in pathology. And in this, he found that gliomas in children were the commonest tumors. He obtained 48%. And of course, the low-grade gliomas made up the big bulk, about 48%. And in this collection, craniopharyngiomas were making the third, and Glioblastoma, of course, was the second. Craniopharyngiomas were making the third commonest. And again, in this review, what he found is that meningiomas in children were making almost 10% of these tumors in children were meningiomas. But in children, with the meningiomas, the male to female ratio was almost the same. There was no predilection for males or females. In conclusion, in the pre-CT scan era, earlier reports of patients who underwent surgery at Kenyatta National Hospital found gliomas to be the commonest tumors, 45, followed by meningiomas. In the post-CT scan era, later reports of patients who underwent surgery in the 3 same institutions in this institution have consistently shown angiomas to be more common than gliomas, 40%, 26 and 26%, 41 and 26%. However, these observations may be as a result of patient selection, where in a developing country, emphasis may be directed towards offering surgery to those patients who are likely to benefit. In the most recent study, the distribution of brain tumors in children between infratentorial and supratentorial compartment was almost equal in frequency. Low-grade gliomas are the commonest tumors in children, followed closely by medulloblastomas. Late presentation is common, especially in children, where 20% of the children come when already blind. This is due to shortage of health workers' expertise, as well as ignorance of the problem by the parent guardian. Future efforts should be directed towards addressing the issues, as well as establishing population-based tumor registries for purposes of surveillance and monitoring, and the establishment of population cancer awareness programs. Such programs will provide a true picture of the frequency of various types of brain tumors in the Kenyan population. The establishment of multidisciplinary care in the management of brain tumor patients in sub-Saharan Africa should also be a priority, because this is something which we are still struggling with even in our setup. Way forward priority, I've said there, of establishment of brain tumor registries in all institutions handling brain tumors in surgery in Africa, and the establishment of multidisciplinary care in sub-Saharan Africa. These are my references. I'd like to acknowledge the management of Kenyatta National Hospital for allowing us to do this research. And also I'd like to acknowledge the generosity of the sponsors of World Neurosurgery Webinar Conference of 2020. Asanteni, thank you.
Thank you very much, Professor. That's a fantastic talk. I think it's very impressive what you have done in looking at the brain tumors in Kenya, and that really will be very helpful. Is there any plan that you have to build on it? This is to in terms of service provisions, or this can form the basis. But I know you are president of the Pan African Society. Do you have any plans to extend a similar epidemiological study across Africa?
Yes, we would like to. Well, the plan we have at the moment, we have already started to set up a hospital-based brain tumor registry at Kenyatta National Hospital. And this is through the Red Cap program, which Kenyatta Hospital subscribes to. And this, we have found this very, very useful. And in our communication with our colleagues in sub-Saharan Africa, of course, through our conferences, we hope to be able to share our experiences and help each other, because each African country is different and each has its own constraints and challenges. And you will find that probably as much as we have challenges in Nairobi, Kenya, probably we are much better off than some of the other colleague African countries. We try our best to try and assist each other. And probably the next presentation of global neurosurgery, this issue is going to be discussed probably. Thank you.
Congratulations with making use of the Red Cap, because I think it is a transformational tool. Thank you very much. Dr. Andrews, do you have any comments for Professor Nimrod?
Well, I think they're moving ahead very nicely, and I think as we get more data, we'll see if there really are those differences between Caucasians and Africans that were postulated decades ago.
Yes.
Pretty
hard when the data isn't good to make comparisons.
Yeah.
Thank you. Thank you very much. Dr. Russell Andrews, may I introduce you to the audience again? They might have changed. Could you please, first of all, share your presentation? I will make you a co-host already.
You want to use the one I sent you earlier, or?
If you can try from your side, that will be.
Okay, let me see if I can upload it here. Just a second.
Sure.
Are you seeing it yet?
Let me just. Yes, we are seeing it. Yeah, great.
I'll have to go back. It was, see if we can go back.
If we look at the.
Oops, sorry, this is not. Tell you what, let me load up. We'll narrate it ourselves here since it's not working well. Are you seeing it?
Yep, it's yeah, we are seeing it. Yeah.
Okay. Yeah. Well, welcome everyone. You can see this is a presentation, has multiple authorship here. Sorry. And I'd like to talk about two topics actually. One is how we can leverage disaster response and mass casualties to improve surgery globally. And secondly, to look at some of the technologies that allow us to achieve that goal. And you can see here the first author on this is Tariq Khan, and Leo Quintana you're all familiar with, and a number of other neurosurgeons, but also a number of people involved in this project who are non-neurosurgeons, trauma surgeons, even IT people, and hospital administrators. I think Naren will recognize Nigel Crisp was, Lord Crisp was head of the NHS back in the early 2000s, and he's taken an interest in learning about how we can deliver effective healthcare from developing countries. But if we look now at what you see in the upper right there with the two blue arrows, natural disasters such as earthquakes in many years result in more than 200,000 deaths per year. And the estimated annual cost just of earthquakes is $500 billion, and 26 million people are forced into poverty due to natural disasters. But additionally, we have unnatural or man-made disasters, such as infrastructure failures, transportation accidents, and also terrorism and warfare. And as you can see on the graph in the lower right, in some of the recent years, there have been more than 40,000 deaths just from terrorist events. That's not including warfare and conflicts. So the total number of disaster deaths per year frequently exceeds 400,000 people. Well, thanks to the Global Commission, the Lancet Commission on Global Surgery 2030, which published a few years ago, we know that 1/3 of all deaths worldwide are due to lack of surgery. And there's also a huge economic cost here, as you see in the bottom right, the graph, the GDP, the gross domestic product, that is wasted due to lack of surgical care because injury and neoplasm are largely surgical conditions. It's now exceeding $1 trillion a year, and the cumulative loss by 2030 will be about $12 trillion. As it notes in the bottom left, global surgery is is an investment, it's not an expense. Every dollar we spend will save us $20 later on because we take care of things before they become a real problem for society. And this slide, if we look at the upper left, the Sustainable Development Goals of the UN, number 3 is the healthcare goal, but these are tied intimately with the goals to improve education and reduce poverty. If you look at the upper right, the Sendai framework was developed a few years ago by the UN to address disaster risk reduction. And a little bit to the left of that, you see the NSOAP domains, the National Surgical Obstetric and Anesthesia Plan for developing countries. These parallel each other to some extent. And in the bottom, you see a timeline that compares the development of programs such as the NSOAP for surgical development with programs to improve our disaster response. So these are really parallel and becoming more and more integrated. In this slide, if you look at the top, it's a recent article from Nature. And in the upper right, you see the circles, the gray being 100% of GDP. And the cost of violence, warfare, terrorism is roughly 1/10 of total global GDP. That's double what we spend on the Sustainable Development Goals and 10 times what we spend on meeting the Paris Climate Agreement. In the bottom, you see a proposed national trauma care system combining the military and civilian trauma resources in the United States. This is to address the problem of trauma resulting in nearly half the deaths of people under the age of 47 in the USA. Percentage of trauma deaths, and in the right, in the blue, you see where you're within 1 hour of a trauma center. So if you have a car accident, say in New York City, you may be in a trauma center in 5 to 10 minutes. That same accident in rural Western United States, such as Wyoming, it might be 5 to 10 hours. And so where you live may determine whether you live following trauma. As far as technologies, telemedicine is certainly a great advance in trauma care. In Albania, for example, the only neurosurgical center is in the capital, Tirana, and they implemented a basic telemedicine program a few years ago. And as you can see in the pie chart, less than 1/3 of the people needed to be transferred. This was a much lower rate than prior to the telemedicine program. And so the savings and transfers more than paid for the system of the telemedicine system. In this slide, if you look at the upper left, you see Cesario's, a smartphone app that's been developed for people with epilepsy when they have a convulsive seizure. There's immediate, due to the accelerometer in the smartphone and its GPS capabilities, it immediately notifies both the patient's family and the hospital. So there's immediate care. Then this could be applied to any sort of a trauma event that an accelerometer can pick up. In the bottom left, you see the possibility of combining drones that deliver a defibrillator to a cardiac arrest victim much faster than an ambulance, and a bystander can administer these basic defibrillators. In the upper right, you see Good Sam as an interesting combination of smartphone apps and drones to address various emergency conditions. Naren may be familiar with this. It's particularly developed in the UK. And in the bottom right, Zipline is battery-powered drones that are being used in Rwanda and Ghana to deliver blood products, vaccines, medications, and lab specimens to remote areas that may not be accessible very readily by land. This will be a real boon when we start distributing vaccines for the COVID pandemic. They're also working on establishing these in the Philippines and India and other countries. So we can combine the smart glasses and these, quote, smart drones for what we'd call smart mass casualty triage. Some of these drones have capabilities such as thermal imaging, and they can detect humans that may be under collapsed building rubble and direct the resources then to save these people. We can thank our colleagues in Malaysia for this use of smart glasses in the ICU during the pandemic to minimize the exposure of personnel. One person can convey all the information that the whole team would normally see on rounds, and thus avoiding exposure. As you can see in the survey at the bottom, they anticipate using this in many other settings once the pandemic is resolved. So the smart glasses may have it's really only limited by our imagination how we can use this in neurosurgery. In this slide, you see on the left, there are now mobile battery-powered CT scans. So you can have an actually mobile operating room that can be transported to a disaster site within minutes to hours by helicopter. You can also have a ground-based mobile clinic that can be used, say, for cancer screening in a country. On the right, you see CRASAR, the Center for Robot Assisted Search and Rescue. They will deliver robots and drones for an emergency worldwide. Just give them a call or contact them by email. Turning now again to the ENSO program, Pakistan is the first country that has pursued this outside of sub-Saharan Africa. And in the bottom, you see that some of the categories involved. And on the right-hand side, you see the targets for 2030 in a country that's undertaken an ENSO program, such as Pakistan. And I must congratulate Tariq Khan for what he's done in Peshawar, as he noted earlier in his talk. But just to reinforce, he's had a community education program to prevent neurotrauma for over 20 years in Peshawar. In the last 10 years, he's opened 2 hospitals, a medical school, and a nursing school, and as well as a ambulance service. He also has been very involved in the Pakistani ENSO program. And so he's really set an example for many other developing countries to follow as far as mass casualty and using this ENSO idea. So to summarize, the Mass Casualty Center project aims at integrating both the natural and unnatural disaster response into the ongoing surgery and healthcare system in each country and also globally. We want to integrate the civilian, that is public, private, and NGO resources with military resources, and coordinate all these resources with the UN, WHO, Red Cross, Médecins Sans Frontières, and other healthcare resources. This also depends on collaboration between developing and developed countries, these twinning or dyad programs, which I think we're all familiar with in neurosurgery in sub-Saharan Africa in particular. And interesting that we take the concept of the Trauma and Stroke Center, it really goes from prevention to pre-hospital care to intensive care and through rehabilitation. The global benefits are not only in healthcare delivery, but improves medical education, medical research, and through the improvement in education can result in poverty reduction due to better healthcare outcomes. So we'd like to leverage mass casualty disaster response to benefit day-to-day healthcare and surgical care worldwide. And finally, if you're interested, there's a couple of recent publications from our group. And again, I'd like to thank Tariq Khan in particular, but there's a whole host of people, many of whom are not neurosurgeons. And I would ask that all of us look beyond our neurosurgical colleagues, work with our trauma colleagues, anesthesia, nursing, and hospital administrators and ministries of health if we really want to improve neurosurgical care globally. And with that, I'll thank you for your attention.
Thank you, Dr. Russell Andrews. It's pretty impressive what you are doing, and you and your team. And I think the more people know about it, the better they can contribute. Professor Muwang Gombe, could you make your comment on what you have seen from Professor Dr. Russell Andrews' talk? Thank you.
Yes, my comment is that's a very nice talk Professor Andrews has given. And I know WFNS has a big branch on this, on global neurosurgery, and with a huge team, and which they are coordinating from Harvard University. I don't know whether Professor Andrews would like to make some comments on that.
I think we are just 1 minute in Dr. Andrews. Yeah, just a quick comment. I appreciate. Thank you.
Yeah, certainly. I think all the neurosurgical organizations are recognizing the global. We really need to go global, and I think we have to realize we've been doing that for many years. Say these twinning programs have been around for several decades now, but it's become much more formalized thanks to the Lancet Commission documenting how important surgery is for healthcare worldwide. And many of the people on these publications are involved with the global surgery program at Harvard, Luke Cadell, Key Park, and others, Hytham Showman. And so it really is a global effort. We need more people from developing countries to become involved.
Brilliant. Thank you very much. Thank you much, Dr. Russell Andrews. Look forward to hearing updates, and please use the listserv to post anything to spread the message. Thank you very much. So I'm introducing Dr. Andres Servio from Argentina. He's going to present surgical treatment of brainstem cavernomas, and this is a nice follow on to Dr. Lawton's lecture. Dr. Servio, could I please ask you to share your presentation? Looking forward to it. Thank you.
Yes, Dr. Naren, do you hear me?
Yes, we can. I can hear you.
Are you seeing my screen?
Yes. If you could maximize it for me, please, that would be great. Thanks.
Yes, I am trying to do this, but it doesn't work. I would like to thank at the beginning the scientific committee for having accepted our presentation, and of course my pleasure to thank Naren for having replied all my previous emails. So in the next minutes, we will speak a little bit about, I'm not sure if I am doing the right thing in order to have the complete presentation, but in order of the time, I would like to give in this format. In the next minute, we will discuss a little bit about the treatment of cavernous angioma in the brainstem. This is from the literature. You know that the annual rebleeding rate of cavernous angioma of the brainstem are a little bit higher than the supratentorial space. In our department, we used to perform surgery between approximately 1 or 2 months after the first bleeding. Of course, it depends on the state of the patient. And it's necessary to remember that more or less 1 to 5 patients, 20% of the patients will develop new postoperative neurological deficit. Of course, many of them will improve with the rehabilitation process, but it's necessary to have this, to take this to the patient. I adhere to these rules. I suppose it was written by Spetzler, the 2 points rules. 1 point in the middle of the cavernoma, and then the other point in the PL expression or ependymal expression of the tumor. And in this case, it's the best way to look for the best surgical approach. Regarding surgical techniques, I repeat, we prefer to do in cases with PL and ependymal expression. Neurophysiological stimulation, it's really necessary for this type of patients. At the beginning, we used to do hematoma evacuation. Then we used to dissect the plane, the cleavage plane between the brainstem and the cavernoma. We are not so obsessive with the hemosiderin rim, and we perform hemostasis with Surgicel and warm saline solution with very, very low bipolar use. In this case, of course, the real talk about brainstem cavernoma will be soon with Professor Lawton. Maybe this is the introduction for his lecture. But our series is 21 cases operated in our department. We have 4 cases in the midbrain, 12 in the pons, 4 in the medulla oblongata, and 1 in the fourth ventricle. You can see here that we operated on more than 66% of the patients after the second hemorrhage, because sometimes we prefer to avoid the surgery at the beginning, at the first bleed, if the patient is in good condition. We use 10 cases the retrosigmoidal approach, and then in 7 cases the talovelo-tonsillar approach. This is the most frequent approaches in our department. I like this paper written by Carvacanti, but we have here in Argentina Dr. Recalde and Dr. Maximiliano Nunez, who has written a lot about the safe entry zone. I put here the most specific approaches we like to do in the midbrain, the lateral mesencephalic sulcus, in the pons, the supratrigeminal and lateral peritrigeminal area, and in the medulla oblongata, the posterior medial sulcus. You will see here a case of 41 years old male patient with a huge cavernous angioma in the midbrain. You can see here the pictures, and you will see the Raverick tumor, preoperative Raverick tumor. We operated on in the supracerebellar in the park bench position, infratentorial approach. After opening the tentorium, you see here the forecranial nerve. You have enough space to look for the lateral mesencephalic vein. You will see here immediately after the sectioning of the last portion of the tentorium. You see here the vein, and in front of the vein with the forceps, we perform the opening. This is to check with the neuronavigation to open the brainstem, and you will see here immediately the evacuation of the hematoma. And after the evacuation of the hematoma, we perform the dissection of the maybe this pseudo capsule in between the brainstem and the cavernoma. Sometimes it's necessary, no, not sometimes, every time it's necessary to remember about the possibility of venous anomaly drainage, which has to be preserved. After the dissection, I like to remove, if it's possible, in block. Otherwise, it's necessary to remove the cavernoma piece by piece. This patient was resected in 2 pieces. You see here the famous cavern of the cavernoma. This is the first portion of the lesion, and then the rest of the portion was removed in a second. The problem is not the problem. The point with the hemostasia is necessary to warm with warm saline to irrigate a lot, and we use Surgicel, fibrillar Surgicel. This is the monitoring and the histological sample, preoperative and postoperative MRI. This is another patient operated on in the same position. You see here pre and postoperative remotion with very good result of the movement of the eyes. In the pons, I repeat, we use 2 types of approaches. This lady, 28 years old, female patient, was operated on in the retrosigmoidal approach in the peritrigeminal space. You see here the 7 and 8 cranial nerves, lower cranial nerves, and PL expression. The video is faster because of the time. This is the dissection of the plane. I repeat, we are not so obsessive with the remotion of the hemosiderin plane like in the supratentorial approaches, because you do not have seizures in the brainstem, and of course because of